Mm. You think that I shouldn't stop you? I'll tell you that. But if I didn't say it, well, I still felt it. There's the sense in that. I promise. Trying to return to function to go back again. I cause nothing but trouble. I understand if you can talk to me again. And if you fight the side, it's so short of anything.
Oh, great, great. Yeah, there we go. Nice. Hello, is anybody there? Greg, are you there? Okay, do you want to try the audio from there? Good morning. Do you want to try the audio from the podium? I don't know if you guys can hear me in the auditorium, can you? I will go down with the ship.
Mic check, checking, 1, 2.
Good morning, Greg. Is that you? Hello? Yes.
Knock, knock. Hello, hello. Good morning. Sorry, I'm the official party pooper. I gotta stop the socializing and start work. Good morning, everybody. A beautiful, beautiful day ahead of us with a lot of great speakers, all the way from different countries like Iowa and Massachusetts. You like that, Edgar? To start today, we have our own Dr. Foy talking about insight of a primary care physician on brain aneurysm. Dr. Foy has always been, since her first time with us, so energetic and so passionate about the topic. You see what I mean. Thank you, Dr. Foy.
Good morning. I am Dr. Trishella Johnson Foy, and I am family medicine physician at Baptist. So I want to first thank you guys for allowing me the opportunity to speak with you today. I think I might be the official party pooper because now the learning starts. So I appreciate, hopefully I'll be waking you up instead of lulling you back to sleep. I have no disclosures. The objective for me today is to really start this off from a perspective of what we as primary care physicians need to do when it comes to aneurysms. So I know some of this may be a little bit more primary for you guys, but as you go back into your communities and you want to see those around you know how to refer properly and know how to truly recognize such an important condition, this hopefully will allow you an opportunity to be able to do that. So we're going to define the condition, identify the different types, discuss epidemiology, and then clarify risk factors, and really talk about how to approach aneurysms from the primary care perspectives. So kind of hot off the presses, you know, I'm always careful about communicating things that are not confirmed, but it wasn't long ago, about exactly a month ago, that news flash came out saying Jamie Foxx had been rushed to the hospital. His daughter released a statement saying, you know, thank you for all the prayers, thanks for everything, but good, quick actions by doctors have made it where my father is doing well. Well, immediately those things kind of were removed. And there was for a short moment, a release that said he had had an aneurysm and that it had bled, and then it just disappeared. And so I don't know if that was a matter of, let's make sure we keep this as private as possible, or if it was just misinformation. But it is something that can happen to many people. And one person who hasn't been quiet about it is Miss Amelia Clark. Now, you might not recognize her, but unfortunately, I'm a big fan. She is our breaker of chains, the queen mother of dragons. And while she was fighting things on Game of Thrones, in her real life, she was actually being faced with the biggest fight of her life. She had 2 aneurysms, 2 brain surgeries, and 2 near fatal events. This was all during the first season of A Game of Thrones. And so this woman has truly triumphed at a time when she was being faced with something that was completely life-threatening only at the age of 24. So what was her war? Well, this beautiful creature here is what her war was. Now, she isn't the first and unfortunately won't be the last who has been affected by aneurysms. Just here locally, there's a park down the street named after a woman, Miss Tilly Fowler, who was actually up and coming star in our legislative party, who fell too soon from an aneurysm in 2005. And so aneurysms have really affected many people in ways that are devastating. So how common is it? There are about 1 in 50 people who have brain aneurysms. Now, in our country, those 1 in 50 people, it doesn't sound like it may be as bad, but of of those who actually have an unruptured aneurysm, when they do rupture, there's a 4 in 10 chance that they'll die as a result of it. So it becomes very important to make sure we are recognizing the potential effects of aneurysms. This means about 1 in 3% of the population have aneurysms. And of those, about 80 to 85% of actual subarachnoid hemorrhages are associated with these ruptured aneurysms. Autopsies, though, show that the prevalence may be even a little bit larger than we realize, in about where there may be about 5% of the population that's affected by it. Fortunately, though, 50 to 80% of aneurysms do not rupture during a person's lifetime. This is great for women, especially because the ratio of women to men is about 3 to 1 when it comes to the prevalence of aneurysms. So what do these numbers translate into? That means about 6 to 15 million people have a brain aneurysm. Unfortunately, 90% of them don't know anything about it. It is one of those silent conditions that can really be life-threatening. It almost never causes symptoms until it ruptures. And most of the time, it's only found incidentally through imaging that's being done for something else. When it does rupture, it usually causes the most debilitating strokes. So how often does it rupture? Well, there's about a 1% chance or less sometimes that there's a risk. And we'll talk about that a little bit later. So I've said all these things that seem to be more doom and gloom, but I do like to be a glass half full type of person. So as we understand that this can be devastating, preparing doctors, preparing the community to truly know how to identify these conditions is what we need to do to be able to really put a dent in helping people who live with it understand better. So I like to identify the risk factors, make sure we're doing proper radiology, refer when it's appropriate, but most importantly, reassure people. So before a doctor can be able to talk to a patient about it, they have to remember the anatomy. So just taking a step back, the blood to the brain is supplied by our 4 major vessels that join together, forming that circle of Willis, which is at the base of the brain, with the anterior cerebral artery, the posterior cerebral artery, the internal carotid, and the basilar artery. Now, this has always been just a beautiful structure to me, even in medical school. An aneurysm is when there's a disruption of this beautiful structure. It is a bulge or a balloon-like dilatation or swelling in the wall of the blood vessel in the brain, and it develops there because of a weakness in that vessel, usually at its branch points. So those weak areas cause the blood vessels to bulge or balloon out, and this usually occurs at those bifurcation points or areas where the anatomy is changing, or where you may have like AV malformations. So again, most often people have no symptoms associated with it, which is why identifying it is very important. And there are 3 types of aneurysms: saccular, fusiform, and dissecting. The thing to know, though, is that saccular and fusiform are true aneurysms, whereas a dissecting aneurysm is really more of a false aneurysm. In order to be a true aneurysm, you have to involve all 3 layers of the vessel wall. And so that dissecting aneurysm, there's a disruption in the wall. And so you get this outpouching out, which is really accumulation of blood. And so that's why it's considered more of a false aneurysm. So how do these aneurysms develop? Well, there are degenerative changes that occur within these walls that either is from trauma, mycotic forces, oncotic issues. It can be flow related, vasculopathy related, or drug related. Most often they occur in the anterior communicating artery, where you'll see about 40% of these saccular aneurysms sit, and then followed by the middle cerebral artery and then the posterior communicating artery. So again, the most frequent cause, though, of non-traumatic subarachnoid hemorrhage is a rupture of the saccular aneurysms in primarily that anterior communicating artery. So this just identifies it a little bit more. Now, there was a time when it was thought that most of these were congenital in nature, meaning they were something that arose from some genetic predisposition. But we now understand that there hasn't been much evidence that shows that there is actually a congenital malformation, but that this is more likely a weakness that occurs from defects in the media that happens over years from arterial pressure, and it just weakens the area and the wall just subsequently balloons out. Now, with that being said, there are going to be some genetic conditions that predispose people to aneurysm development. So those other causes, I'm going to take a step back for a second, actually. So the most common or most intracranial aneurysms likely result from those degenerative vascular injuries that are associated more so with high blood pressure, smoking. Those are the things that really puts those stressors on the wall. So we want to make sure that we identify those risk factors. Those high flow states are also associated with AV malformations and aneurysm formation. So less common causes of aneurysms include trauma, infections, and tumors. Now, again, hot off the presses, unfortunately, there was a boxer who just passed away from a brain hemorrhage just yesterday, who was in a fight in the Philippines. He won, but he collapsed shortly after and has subsequently passed away. Now, there are several inherited risk factors that are known to be associated with aneurysms. And so alpha-glucosidase deficiency, alpha-1 antitrypsin deficiency, which is actually very common. If you have patients who have emphysema, it's important to check for this because it does increase their risk of having aneurysms as well. AV malformations, history of coarctation of the aorta, Ehlers-Danlos syndrome, and family history of aneurysms, and once again, female gender. Fibromuscular dysplasia is one of those ones that has been identified as well that we really want to make sure that we pay attention to, because those patients have definitely been shown to have an increased risk of aneurysms. Hereditary hemorrhagic telangiectasias, Klinefelters, Noonan's, and another one that's very common is polycystic kidney disease, where you'll oftentimes see these patients, they have resistant hypertension, and they don't even realize that this is actually the source of their hypertension. So if you are seeing them getting a renal ultrasound, identifying the condition, and then now you know you don't have to you shouldn't just be looking at their kidneys, but also at their brain. And then other conditions like tuberous sclerosis. As our patients age, that is going to increase their risk. And of course, in our country, alcohol consumption, especially those who do mostly binge drinking, we see an increase in aneurysm development. Atherosclerosis, cigarette smoking, and the use of illicit drugs such as cocaine and amphetamines, really those stimulants put patients at risk. There's a lot of vascular pressure that's associated with hypertension that's uncontrolled, oftentimes increase the risk, trauma, and infections. So helping patients understand their risk is important, but also clarifying for them that having a risk for something does not mean you are going to develop or have the disease, because we, in those terms, kind of embed fear, and we don't want to necessarily do that. We want to do it just what we do with other conditions, which is make sure that people understand their risk, so whatever interventions they can do to mitigate risk, they'll be doing those things. Genetic testing then is something that has been looked at for certain patients who have strong associations with aneurysms, because there are some that have been identified to increase risk, like the chromosome 4 gene has been shown to have some increased association with aneurysm development, and several others. But again, it's been considered to be lower risk factors than others. And we've looked at large studies to kind of understand the natural history and the development of aneurysms and which ones are more likely to progress to rupturing, how they grow. And so there is a risk score that was developed called the phases risk score that looks at the population that a person is from, hypertension, age, the size of an aneurysm, if they've had an earlier subarachnoid hemorrhage, and the site of the aneurysms. When you look at these different factors, it allows you to come up with a score that tells us what is the likelihood of rupture. And so, of course, the greater the score, the greater the likelihood of rupture. Now, the phases score was just one way to kind of discuss or determine what's the likelihood of rupture. With that being said, it kind of was clarified that perhaps we should be looking at the likelihood of rupture from the likelihood of growth. How often or what's the chances that this is going to get bigger? And what's the chances with it getting bigger, then what are the chances of there being a rupture? So now there are other types of scoring systems that are available that allow us to get clarity on this. So we now have the ELAPS score, ELAPSS. And with those, we're looking at, again, earlier subarachnoid hemorrhage, the location of the aneurysm, age, population, the size of the aneurysm, and the shape of the aneurysm. And it's been shown to reliably predict the likelihood of growth and rupture when it comes to a patient having an aneurysm. Of course, we're always looking at ways to do things more simply. So there was a meta-analysis done of the ELAP score that now allowed us to come up with a new growth score. And this new growth score is very simple. It consists of just looking at female sex, cigarette smoking, and age less than 40 years to depict whether or not an aneurysm is likely to grow. When it was compared to the ELAP score, it was found to actually be superior or better with predicting the likelihood of growth. So just those few things made a huge difference. The thing that ELAPS didn't look at was cigarette smoking. And so in our country, even though there is a decline in cigarette smoking, it has been shown that that one factor really helps to clarify even better the risk that someone will develop an aneurysm, that the aneurysm is more likely to grow. So the scoring system is important from the primary care standpoint and from the specialist standpoint of really being able to educate your patients on what the likelihood of them having a rupture or a growth of their aneurysm, and knowing when to order studies, how often they should be seen, and really how we should be managing these patients. You're polycystic kidney disease patients, so you really want to pay great attention to, because there's a 5 to 40% chance of them having an aneurysm. Also, those with AV malformations and fibromuscular dysplasia, you want to make sure that you are assessing them appropriately, that you're doing the proper studies and helping them understand their risk. Now, family history has been shown to predict the likelihood of the development of an aneurysm, but again, not the risk of rupture, which is why we go back to our scoring system, which actually doesn't include or doesn't show that the family history is as critical to the growth of the aneurysms as we were previously thinking. So there are some institutions where they are guided by family history. They order MRIs yearly on patients who have a family history with the idea that we are mitigating risk. However, it may need to be looked at again as to how we're utilizing our resources if really the evidence suggests that this isn't one of the things that guides whether or not a patient has a growth of an aneurysm or a rupture of an aneurysm. So then what screening do we do? Right now, we're still guided by the idea that if there are 2 immediate relatives with intracranial aneurysms, there's a 4% risk in one family member if you have one family member with an aneurysm, but then there's an 8 to 10% risk if you have 2 or more family members. All patients with autosomal dominant polycystic kidney disease have that 5 to 40% increased risk, which is an interesting number because 5 to 40% is quite a great range. So the idea is just make sure that you're paying attention to these patients, making sure that you are assessing them at least once. Now, we live in a world where genetic testing is available at the point of a click, phone call, any place you're actually able to go on Amazon, Walmart, and do any genetic testing. So counseling patients on how to properly use these genetic tests becomes something that's important. And I put that in just because that's one of those things that is going to be continuing to be conversations that you'll have with your patients. And so knowing how to navigate those is important. Remembering the presence of risk doesn't completely correlate with that you'll definitely develop a condition. So really knowing how to use information becomes important. Right. So as we look at rupture risk, there has always been a debate about aspirin and how we should utilize aspirin in these patients. So there have been many retrospective studies that have suggested that the rupture risk is actually reduced in patients taking aspirin, which for some that seems counterintuitive, but that's what the studies have shown. In the general sense, though, it remains a bit unclear if the benefit of aspirin use in patients with unruptured aneurysms outweighs the potential risk. So you'll want to make sure you have a good conversation with your specialist about how you should be proceeding with those patients. This is when great minds together can help make the best decision. If you have a population of patients who are of color, know that they are twice as likely to have a ruptured aneurysm than other populations. So know your demographics of patients, know what their risks are, and guide your care with these patients according to what their risks are, and making sure that you're doing your due diligence. Otherwise, that's how disparities continue to persist when we don't know who we are taking care of and don't know how to properly assess risk, and making sure that our care of them is guided by a lot of the cultural things. So we have identified what an aneurysm is, what the genetic risks are. Now it's a matter of this patient is presenting to you. What are some of those signs that you should never ignore? Severe headache. If a patient is presenting with severe headache, there says the worst headache of my life, then that's an opportunity to make sure you're doing appropriate imaging and evaluation. This is where you, as much as we don't like to send them to the emergency room, where you would help make that call and say, hey, you need to have imaging right away if it's a severe headache. Seizures, new onset seizures, unexplained seizures are another indication that there may have been a bleed in an area that they need to, that has now set off a little focus that is causing seizures in a patient. Light sensitivity, of course, that's a little bit more vague, but if there's a persistent, continuous light sensitivity beyond just, oh, I have a headache or a migraine, then you need to pay a little bit closer attention. Double vision, those changes where it's not just, oh, my sight's off a little bit, where patients are truly complaining of double vision or blurred vision. Severe face pain. This is another symptom that goes beyond just your basic headaches and your basic presentation of pain, and making sure that you are watching patients and making sure that they don't have an aneurysm. If they present with a small embolic stroke, this also can come from just an aneurysm thrombus. So you want to make sure that proper imaging is done to detect and determine what is going on with these patients. Visual field defects, TIAs, when they present with a dilated pupil and there's no explanation for it, again, looking for aneurysms becomes something extremely important. The idea is to avoid misdiagnosing these patients. One scan can truly save a life. So you want to make sure that you are doing the proper scanning. So what scans should we do? There are several ways to evaluate aneurysms. You have CTAs, MRAs. CTAs and MRAs are the methods of choice in unruptured aneurysms, but angiography by direct intracranial intraarterial catheterization is the gold standard. So, and they're going to talk a lot later, I think, about these things, but just remembering you have these different modalities to make sure and to evaluate these patients. This is a beautiful catheter angiography presentation picture. And again, this is the gold standard, although it is a more expensive and invasive way to evaluate for aneurysms. This is going to give you the best representation of what's truly going on in the anatomy of these patients. So if you're still unclear, then refer. If you are not sure of what you should be doing in these patients, make sure that you're doing the proper referral to these fine gentlemen who have been kind enough to put it on, or to the proper clinicians in your communities, making sure that they are in the best hands to truly manage these aneurysms. But what do we do mostly? Primarily conservative management is what is done. Patients over the age of 60 and those who have a small aneurysm are usually monitored and imaging is done properly, and except in those with a strong family history or who are symptomatic. Patients with aneurysms 7 to 12 millimeters in diameter, you want to individualize them. Again, getting them into the proper care, making sure that they are seeing the neurosurgeon who will help guide these decisions is really what you would want to do. We have an aging population, and previously they were told to go and rest in the pasture. We know that people have longevity and that we should be really making sure that we talk to them in a way that they understand that their life does not end because they have been diagnosed with an aneurysm, and that we monitor them appropriately, try to make sure that they're educated in a way that mitigates their risk, and that they are actually guided that if they make sure that they are limiting their risk factors, that the potential for survival is high. So conservative management is usually going to be first, but you would consider intervention if aneurysms growth is noted to be increasing. Again, these are decisions made by the neurosurgeons. So because of that, I am going to move through that a little bit more quickly, just reminding you that aneurysms are usually either clipped or coiled. Okay? And this shows coiling of a brain aneurysm. And then the stent also, a picture of a stent-assisted coiling of a brain aneurysm. So things that allow us to really save lives. This is the clipping of an aneurysm. And so making sure that these patients get proper treatment, but those who are not being treated, reassurance is the most important thing. Say or do something that removes the idea that they're going to die tomorrow. When you have patients who know that someone in their family has had an aneurysm, or who know that they themselves has an aneurysm, the biggest thing that they're contending with every day is what is their own mortality. So as the doctor, you are the clinician, you presenting to them and you guiding them in a way that allows them to know the chance of risk is much lower than they're probably thinking, encouraging them to live their lives, encouraging them to make sure that they follow those protocols that will help decrease the likelihood of risk, keeping their blood pressure under control, not smoking, making sure that they're eating healthy and doing the things that are going to help them to live just a long and healthy life. Also pointing them to the resources that are available to support other people who have aneurysms, making sure that we provide them with hope and faith and not this idea of doom and gloom. Reassurance that they can live their best life because survivorship is real. We have lots of examples from the patients who sit in front of us to those who are celebrities who are still making a difference in our communities, and people who don't go crazy and kill communities and set them on fire with dragons is more likely to survive. So keep your prayers for Mr. Jamie Foxx if he does have an aneurysm. Otherwise, I am here to answer any questions that you may have. Thank you. Yes, I have answered them all. So you guys, any questions?
Thank you, thank you. What could be, I don't know the case, but what it could be happen to Fox is we have this condition named angionegative subarachnoid hemorrhage. 20% of the subarachnoid hemorrhages, we don't find an aneurysm. And a common explanation from a physician to the patient and family said, oh, maybe you had a small one that bled and disappeared. That would fit specifically in what he had. Don't know the case, but just speculating.
Yes. It's all speculation. I did not say that Jamie Foxx absolutely had an aneurysm, but it was
It's
good
already on
opening.
Instagram. It's already on
And-
Instagram.
And so if he did, pray for him.
Highly scientific publication.
Yes.
I'll share a little bit later what we are doing on the genetics. We have a study at Baptist sponsored by the state of Florida, and we have screened over 500 people. I'll share 2-3 slides later, but I really appreciate Dr. Foy, all the efforts every time you're here. I think we enjoy. Anybody, any questions? Okay, we'll move then. Thank you. Comes all the way from our powerhouse of farming. America needs farmers. Dr. Samaniego is associate professor of neurology, neurosurgery, radiology. We're friends through life and engage in many interesting discussions and conversations. And he's one of the world experts. Dr. Foy alluded to that on this uncertainty that we have, all that she present about size, location. If you squeeze really hard, every patient is a different patient. So Edgar has put a lot of energy in studying how can we screen better and try to identify, should I treat this patient or not? And is size the only thing that matters? So I'll let him share his thoughts. Thank you, Edgar, for coming all the way and being with us today.
Thank you so much, Ricardo and Eric and Nima for inviting me to present some of the research that we do at the University of Iowa. Feel a bit depressed this morning coming from Iowa. You guys living in this beautiful place makes me wonder why I'm still doing in Iowa. Yeah, no, great talk from Dr. Foy. There's a lot of questions about surrounding aneurysm. These are my disclosures. None of them is related to this talk. So just a couple cases that I think is interesting to showcase what the talk is about. This is an 80-year-old woman who had a subarachnoid hemorrhage. We did a diagnostic angiogram, and you see that she has two aneurysms, one on the right, one on the left. The distribution of blood is not very apparent. You don't know really which one ruptured. So I treated the one on the left first because it was the easiest, and I thought it was bigger. It didn't look as ugly as the one on the right. We put her on the ICU, and then 2 days later, she re-ruptured from the one on the right. So I had to go back and retreat it. So we don't really know. There is one of the experts in morphology of aneurysms is going to talk later. And also we have, other world experts here, but, we don't really know based on morphology which aneurysm rupture. So that's not going to help. This is another patient I saw in the office, 56-year-old woman with a 4 millimeter ACOM aneurysm. So as Dr. Foy mentioned, you have different scales. If you go by ECUIA, this is definitely not more than 7 millimeters, so we're not going to treat. Faces, same thing, less than 7 millimeters. Her faces score was, I think, 3. So she's not going to be treated based on faces. UIATS, we're using that scale now for one of the studies we're doing with flow diversion, but the UIATS recommended conservative treatment, so no treatment for her. And the ELAPSE score, which is a prognosticator of growth, also very low score, so no treatment. So the next year she came with this. So again, we're still learning. We don't know what's going on with aneurysms, and I think part of that is that if we don't know the biology and we don't understand what's happening with the vessel wall, what makes an aneurysm to form, we're not going to be able to give a good advice to some of these patients. So you have to realize the aneurysms are complex structures. It's not really like the nice sac that we see. They have multiple biological processes undergoing in the wall. You have atherosclerosis, you have some necrosis within the wall, you have inflammation. And that's why I start looking into wall inflammation and as a wall enhancement as a surrogate biomarker of inflammation. We also have to understand that the wall of the aneurysms is a little bit different than the wall of different vessels in the body. It doesn't have a very thick muscular layer, only has an intima, median, adventitious, or very thin layers. That's why maybe they make it more prone to growth and rupture. Multiple inflammatory process with different cells involved, macrophages, neutrophils. The elastin also plays a role. So there are very different types of aneurysms, and there's also very different complex structures. So when I arrived to Iowa 8 years ago, I realized I have a 7 Tesla MRI, and I started doing some research with 7 Tesla. The nice thing about high resolution visual imaging with 7 Tesla and 3 Tesla is that you have a high signal to noise ratio, you have very high definition. If the patient cooperates and holds still, you can have beautiful images of intracranial vasculature. So much you can even see like 0.3 millimeter arteries like lenticular striates and pontine perforators coming from the basilar artery. On top of the high resolution visual imaging, we have different tools. For example, to look at the microhemorrhages, you can use ferromoxetol and QSM, inflammatory signals with vessel wall imaging and contrast enhancement. You can see atherosclerotic processes, and you can also do CFD. So you need a different tool, and that's why this slide of the toolbox is so important, because it's not only one tool you're going to be using to try to understand the aneurysms, because since the aneurysms are complex, you'll have to use different resources to try to have better understanding. And the other thing that I think why so many studies have failed or have not been very useful in trying to understand the biology of the aneurysms is that aneurysms are very heterogeneous structures. Not only we cannot put all the aneurysms in the same bucket, and we that treat aneurysms every day, we can notice that you have the fusiform aneurysms, maybe in patients with underlying diabetes, hypertension. Sometimes they develop these fusiform vertebrovascular aneurysms in the posterior circulation. And also the other end of the spectrum, like this myxomatous aneurysm from a patient who had a myxoma in the heart, and he embolized some myxomatous cells to the brain and had these MC aneurysms. So it's not everything fits the same for aneurysms. They're very heterogeneous, different locations, different populations. So that's part of the complexity of these structures. Wall enhancement, this is one of the first papers published by Charles Matuk at Yale, when he's a very good neurosurgeon who noticed on some of these patients that had multiple aneurysms, which one I'm going to clip. And when he was clipping the aneurysms, he realized that the one that he was clipping was the one that ruptured. And also looking back was the aneurysm that had more enhancement, more wall enhancement compared to the other unruptured aneurysms. It didn't really correlate much with size. Sometimes the larger aneurysm didn't enhance as much as the smaller aneurysm that ruptures. So this is one of the first papers described in the literature. And there have been several other papers. This is one from our group in Iowa, where we have done some correlation between wall enhancement and the histopathology of what's going on in the wall. And the aneurysms that have more wall enhancement, they tend to have more concentration of inflammatory cells, such as macrophages, and also some other changes in the wall, like increased vas vasorum. Some other animal models have also been created. This is an animal model that we did with Mayo, where you inject elastase in the common carotid of rabbits, and then you follow up these animals. The aneurysm tends to form within 1 or 2 weeks, and then you stay and sacrifice the animal and do histopathology, and also do MRI and enhancement of the aneurysm. We found that, that the aneurysms that had more enhancement, especially after injecting IPS, which creates more inflammation, also where the aneurysm that had more concentration of, in this case, macrophages. So not only the live models in samples from patients who had clipping and resection of the aneurysm, but also in animal models. This also has also been translated with other samples extracted from the CSF of patients who had ruptured aneurysms and went into vasospasm, where we also find other cell populations in the wall of the aneurysm. So after the first paper from Charles Matug in 2013, several other papers, and they have done several 3 meta-analyses with enhancement and the risk of rupture. But one of the things that we notice in all of these papers is that the assessment of enhancement is very subjective. So basically, I'm sitting in a dark room, reading the films and say, oh, this aneurysm enhances, this aneurysm does not enhance. So that's not going to be optimal in trying to understand and trying to identify the aneurysms that are going to rupture, because if you want to use this as a biomarker, and especially if you want to put this through a NIH or FDA panel, they're never going to go with a subjective assessment of a biomarker for determining of aneurysms at high risk of ruptures. The purpose of the research has always been try to identify and create an objective measurement of enhancement of how much gadolinium you can quantify in the wall of some of these aneurysms. We have had a holistic approach, taking into consideration all this toolbox, morphological data like aspect ratio, size ratio, some of these morphological indexes that have been described now for years. We also have used computational flow dynamics, tried to better understand how the flow within the aneurysm can cause the aneurysm to first to be born and then to grow and rupture. And vessel wall data, trying to maximize the use of this high-resolution vessel wall imaging to look in magnified views of the vessel wall and try to draw ROIs and isolate the vessel wall and try to extract data from the vessel wall to understand what's going on with the aneurysm. Some other groups also have similar observations. This is the group from University of Washington, where also they have seen that in this case, the aneurysms that had a thicker wall had an increased concentration of inflammatory cells, and also they noticed that they had more enhancement. This has been correlated with histopathology and also imaging data. This is not only our group. They also realized that the thicker the wall, the larger the aneurysm, the more enhancement you might have, which means that maybe the inflammatory process initially makes the wall thicker and then makes the wall thinner. So the research questions that we wanted to address in our group was how to measure wall enhancement. What does aneurysm wall enhancement mean? How does aneurysm wall enhancement correlate with other imaging parameters like CFDs or presence of iron? And also, is aneurysm wall enhancement real? This is being questioned by, and that's good, that's being questioned because every time you come with a biomarker, has to be some question if this really a valid idea or not. So the platform that we have, we do the high resolution with 7 Tesla and 3 Tesla. We do co-registration and segmentation of the high resolution. The protocol that we have is initially was kind of long protocol. It took 35 minutes. Now it's a very short protocol of 20 minutes. We do a T1, pre-T1 post, and a time of flight. The reason for that is because the patient has to hold very, very still because these vessel walls are very, very thin. So a little movement in between the scans can create artifact, and it will make our co-registration more challenging. And then we used to do manual RAO sampling, region of interest sampling, and normalization of the wall of the aneurysm. Okay. This is a case that I always show because I think it's very interesting. A 7 Tesla MRI, in the upper row you have the T1 pre, and the lower row you have T1 post. So on the T1 post, you cannot really see many changes on the aneurysm wall. But when you do a detailed magnified view of the aneurysm, you have different signal intensities. For example, in the anterior wall, you have signal intensity of 349, CSF as a control is 73, and the posterior wall 302 of enhancement. How much bright is this wall? And then when we treated this aneurysm, you see a clear correlation between some of the morphological aspects of the aneurysm, like the presence of this bleb in the anterior wall, which is blebs, as you know, is a high risk for rupture. with an increased signal intensity, in this case of the 7 Tesla high resolution vessel wall imaging, which definitely shows that there is something is going on the anterior. You might call it thicker wall, increased vasovasorum, or slower flow, but interestingly correlates with the morphological appearance of the aneurysm. So one of our research fellows back in 2020 did this very nice work of trying to do an objective assessment of aneurysms. Initially, we're doing ROIs manually. We're kind of selecting with the mouse the wall that we wanted to select, isolate, co-register, and analyze. But he found that the best way to normalize, because you have different variables when you give somebody contrast. The contrast, the gadolinium can have a different distribution, depends if you do it. We try to be consistent, but can you give it at 5 minutes versus 6 minutes, 7 minutes, so that will determine how much enhancement you might find in the tissue after you give the contrast agent. The temperature of the room might change the relaxation times of T1. So all these parameters can introduce artifact into the measurements that you are trying to make. But for this reason, we started normalizing the enhancement to the pituitary stalk, which you see highlighted there with the different values. And he determined in this cohort of 102 aneurysms that in this case, we didn't have the outcome was aneurysms that were 7 millimeters or larger to see what was the best threshold. And he found the best threshold was a 0.734 ratio after normalizing the enhancement that you see in the wall with the value that you get from the pituitary stalk. We start working with that. The interesting part of this study was also that we had 9 patients who underwent 2 different scanners, because there's also a question about how can you do this biomarker with different scanners. It's going to be the same value if you do a Siemens, it's going to be a Philips or a GE scan, MRI, 3 Tesla or 7 Tesla. And interestingly enough, the Pearson's correlation was very high, 0.92. So it doesn't really matter if you use different scanners. I know the sample size is relatively small. We're doing more studies with phantoms now, but promising results that doesn't matter which scanner you're going to be using, but you're still getting the same signal intensity and brightness when you give contrast on these patients. So the other question that is always comes, is this just related because of slow flow? Is something going on in the pulmonary that might make the aneurysm to first start in that part of the artery? Is this an inflammatory process or not? And towards that end, we analyzed with 7 Tesla again a cohort of patients with unruptured aneurysms, and we isolated the pulmonary that's next to the neck of the aneurysm, where the aneurysm is going to start growing and at some point might rupture. And we this was done manually, where we're taking ROIs very close to the neck, initially 5 millimeters, 3 millimeters, and you see the correlation between enhancement of the aneurysm and the pulmonary. So the closer you were to the neck, like in this case, the pulmonary 3 millimeters instead of 5 millimeters, you had a higher correlation as opposed to the control artery, which was the contralateral. So in the case, for example, of a PCOM, you were choosing the contralateral ICA where there was no PICO aneurysm, and there was no correlation whatsoever with the signal intensity or enhancement of the pulmonary. So this kind of like indirectly shows that there has to be some type of inflammatory process in the pulmonary that makes first to the aneurysm to appear, and over time, because of flow dynamics or still inflammatory process is going on, the aneurysm continues to grow and might rupture at some point. So, the gold standard when I was a fellow here in South Florida with Italy Infante and Guillermo. Now, this was the gold standard, 3D rotational angiogram to really is invasive, but we're trying to now know that the gold standard is not only that, you have to understand what's going on with the flow with an aneurysm, what's going on with the wall. There's different things going on. Towards this end, we collaborated with Juan Sebral, who is a world expert in CFDs, computational fluid dynamics. And he used some of our data with the 70s, and we tried to map the areas of increased enhancement on the aneurysms that we image, and then we manually selected the areas of increased enhancement. For example, this anchor aneurysm, you can see in the postcard that there's different areas of the wall that look very bright, very thick. So we superimpose these areas of increased enhancement with the CFD maps that Sebral did for us. And he has all these parameters like inflow jet, how much flow gets into the sac of the aneurysm, flow pattern, how is the distribution of blood within the sac, what is the wall shear stress in the parent area and the aneurysm. And interestingly, it showed that aneurysm wall enhancement occurs in areas of low wall shear stress, which might explain also why we see more enhancement of areas of slow flow. And I'm going to talk a little bit more about later about this mechanism, but seems like what's going on, and this has been proposed by different groups in the world, that when you have initially the inflammatory process in the pulmonary, you have this inflow jet that hits the neck of the aneurysm that makes the aneurysm to continue to grow. And as the aneurysm continues to grow, the sac keeps expanding. And then you get to these areas of a slow flow, like in the bleph, in the anterior wall of this aneurysm, that because it's a slow flow, it will trigger more inflammation and more recruitment of inflammatory cells like macrophages. And these are the points of rupture. So you have different mechanisms going on. You have the inflow jet, which is probably responsible for the growth, but then the point of rupture is not going to go where you have more inflow jet, but the other aspect more distal of the sac, where you have more inflammation and recruitment of inflammatory cells. And that's why we think we see more enhancement in this part of the aneurysm. This also has been shown, this is the group in Magdeburg in Germany, where they did something similar to us. They did a manual selection of ROIs. They correlated with histopathology from the specimens resected with clipping. And also they found that increased wall enhancement was seen in areas of decreased wall shear stress, and this correlated with a higher concentration of macrophages. So, the concept of the aneurysms is a compartmental structure. Is something different is going on at the neck compared to the sac, compared to the dome, and compared to the bleph. We think that the bleph is the final stage of some of these aneurysms, where the wall becomes very thin as about to rupture, as opposed to the neck, where the wall might be thicker, and because of the inflow jet, has a different process that makes it grow and propagate more distally. But again, this is the standard model. Not all the aneurysms are going to go and follow the same model, because as I mentioned before, aneurysms are very diverse and they might respond to different biological processes. One of the issues that we had was doing these manual ROIs. It was very time consuming. So we teamed up at the University of Iowa with a biomedical engineer and computer science person, people way smarter than what we are. And they came out with this algorithm to create these spokes to sample the arterial wall. So basically, we did a segmentation. We isolated what we thought was the lumina of the aneurysm on the pulmonary, and the software creates the spokes that project out there, and they sample the wall at different thickness, because we also know that the wall has different thickness. So it's a customized sampling of the wall based on the thickness of what we think is the thickness of the aneurysm. And you can generate 1,000 data points from one aneurysm. And the other advantage of this approach is that you create these 3D views of the aneurysm, and you can rotate, because before we were doing 2D analysis of the multi-planar views that we got from the MRI. And then we process this data, and you can come out with these histograms, and you can see on the black curve is the pre-T1 histogram of the aneurysm, and after you give contrast, you see a shift to the right because the signal intensity is moved to the right after you give something like gadolinium that make the aneurysm brighter. So we came from here, which was done manually, to these views of the aneurysm. We acquire the image with MRI, we do image processing, and we do image analysis. And the idea is to provide the clinician that's in the office with these 3D color maps and the histogram, so they can make a judgment and assessment of the aneurysm. This histogram looks bad, or this color map looks like this area is enhancing, although this aneurysm might be small, then we definitely need to treat it. Obviously, we need to get to the clinical data validated to show that it's valid. You can see these nice shifts of histogram on enhancement. You can come up with different metrics for enhancement. Sorry, one of the studies that we did is, for example, the isolation of the blebs. As I mentioned, the blebs or daughter sacs are thinner, weaker points on the wall of the aneurysm. And isolating these blebs, we thought that we found that aneurysm wall enhancement was different between the sac and the blebs. There was an 8% difference of enhancement of the blebs compared to the rest of the aneurysm. And, again, giving you some clues that maybe this is why these structures in the aneurysm wall are the ones that usually rupture. This is how, the showcase a little bit how the software works. You can rotate there in some different views, you can take different pictures and you can, from that, see. This is, for example, an aneurysm, one of the outliers that doesn't follow the rules of ESUIA or UIATS. Pica aneurysms are not to rupture, they're usually small. This is a patient come with a normal pica, came with a stroke, the next year came with a TIA, and we found that within a year, she developed this aneurysm at the origin of the pica. We did a 7 Tesla high resolution visual imaging MRI, and we saw that she has increased enhancement of the wall. And then, in doing the analysis of the aneurysm, we show that has this color map with look at the shift of contrast after you give gadolinium, how the curve completely shifts to the right. We don't see that typically with most of aneurysm. There's a little bit of shift, but not so much. So we think, definitely this aneurysm is about to rupture. She was treated. Obviously, the fact that it grew within a year was, something that really worried us. Prospective data. This question always comes when I give this talk. This is a group in France that show that you do have some prospective data. In this case, they analyzed a large series of 120 aneurysms, and only 12 aneurysms displayed morphological changes at 2 years. And that's usually what we see when we follow some of these aneurysms. And from the 12, 8 had increased aneurysm wall enhancement during follow-up, and 4 had pre-existing aneurysm wall enhancement that remained stable after growth. So all of them had enhancement, but only 8 change in enhancement. Well, the analysis that they did is 2D view analysis, subjective. We think that maybe with more detailed analysis of these aneurysms, maybe the 12 might have changed in enhancement. We don't know, but this is some of the data starting coming up with some of these. There's a study in France looking prospectively, including several centers at changes in enhancement and following these aneurysms prospectively to see if they're going to change and rupture. So the advantage of having a 3D view of some of these aneurysms allows us to superimpose some of the other data that we get, we can look at wall tension, which is obtained from FEA or finite element analysis, some of the CFD data that we gather as wall shear stress, OSI, and wall shear stress gradient. And we can do this more complex approach in looking at the biology of these aneurysms. Like, for example, these parophthalmic aneurysms, you have the wall has different thickness on the high resolution 7 Tesla MRI. And you can see that you find these hot spots where we think there is an active inflammatory process going on, because these hot spots have increased, signal intensity, but also they have increased wall tension. They have decreased wall shear stress, which we have shown before with the work that we did with the Juan Sebral. So more clues about what's going on within the wall and the entire aneurysm that will allow us to better understand some of the processes that these aneurysms go. This is the counterpart. This is a fusiform aneurysm in the ICA, where you see that the wall is very uniform. The thickness is about the same. You don't see these big changes. You don't find a lot of hot spots within the 3D color map of the aneurysm. And the wall tension is evenly distributed. The wall shear stress we know is different in these aneurysms, especially in these transition zones, which are usually called the neck, but fusiform aneurysms don't have neck. It's just a transition from the primary. So again, these aneurysms should never be treated, because we know is a stable aneurysm is not really changing. Maybe if we do a scan 2 years from now and we put all this data, might see some hotspots or changes that might trigger treatment. Again, all of this has to be clinically validated. This is the counterpart, an aneurysm distal MCA. Within this is an area of inflammation. We see a lot of hot spots there with decreased wall shear stress, where we think most of the inflammation is going on in that little bleph. Again, because of morphology, this aneurysm should definitely be treated. And this also reflected in all these parameters that we're seeing. So, nice pictures, but what does it mean? Is we think, and a lot of histological reports have shown that there's increased vasa vasorum in these aneurysms. Vasa vasorum we know is abnormal. So every time you find vasa vasorum is histopathological change that shouldn't be there in the aneurysm wall. So larger aneurysms have more enhancement, thicker walls enhance more, they have more vasa vasorum. We know that from other studies. Does this represent a slow flow? Maybe yes, but we have shown that you see more enhancement in the parent artery of some of these aneurysms, like the PCOMs, especially where closer to the neck has more enhancement. So that shouldn't be explained by the slow flow. There's also some reports of aneurysms with AVMs that have shown that AVMs are high flow structures. They also have enhancement. And I'm going to show some data about carotids that will also go against the slow flow theory completely. And, is this an acquisition or processing artifact? There are different variables that can affect the processing and the interpretation of these images. That's why we try to standardize everything and get a ratio after we acquire the images. In this case, we're using more the corpus callosum instead of the pituitary stalk. We found that the corpus callosum is more reliable, uniform structure that behaves more predictably after administering gadolinium. So, this is some of the data that, cardiologists, as always, are ahead of us. They've been looking at enhancement in the coronaries and also in the carotids. They studied the enhancement, the kinetics of gadolinium, in this case, on this group in the plaque. And this is some of what we see not only with aneurysms, but also intracranial athero, where the gadolinium distributes differently in the cap or in the fibrous cap as opposed to the core. And if you have a small areas of hemorrhage, it might distribute differently. So this is an example how the gadolinium reaches different layers, in this case of the axial view of the carotid. And this explains the different enhancement in the carotid. That might be something that we're seeing in the aneurysm wall that might explain why you have these different densities of enhancement because of different biological processes. Again, this is another group that shows similar findings, but the nice thing about this picture is that they also correlate with different histological processes in the carotid, where you see that the lumen has more enhancement as opposed to the fibrous cap, but the lumen also had more presence. The layers close to the lumen had a higher concentration of inflammatory cells. The same group found that the plaques that had more enhancement had more loose fibrosis, had more neovascularization, which speaks towards the presence of vasa vasorum as part of the histological change that we see in aneurysms, and also had this grade 4 Loeber classification, which means that the plaque look like this, and these are the most dangerous plaques because have most of the inflammatory cells. These are the plaques that usually rupture and embolize to the brain. And they were defined as definitely unstable plaques that have thrombus, large hemorrhage, and thinner caps with a very inflamed cap. So again, this is another paper, more recent paper from a group from Mayo, where you see intraplaque hemorrhage with increased enhancement, as you can see that, which, again, in the carotid, you have such a fast flow that will not be explained completely by the slow flow that sometimes we see on some of these studies. This is the flow artifact that we have seen also by our group. This is nicely described in this paper. And you can see the stagnation of contrast in the DSA, but with some imaging modalities, you can extract that with MSD space. Again, you can see in B where is some of the contamination that you see from the contrast stagnation, but you do some post-processing and you see that's gone, but you still see some of the wall enhancement of this aneurysm in this paper. This is a paper that was from the group from Netherlands that they recreated a phantom from an MCA aneurysm. They had different heart rates with a pump in the phantom, 48 and 77, and you can see there is more enhancement with a 48 heart rate, not heart rate, but the pump rate. Even using some of these techniques to suppress some of the flow inside the sac and the parent artery. Some of the critiques to this model is that it's a rigid arterial wall. It's not that behave the same as a human vessel wall. They use water instead of blood, which has different Newtonian properties as and might behave differently in terms of imaging. And they didn't have a diastole. The only thing that they had was the pump, which will behave almost always like a systole. But having said that, we do know that areas of a slower flow, like in this CFD model, are more related to the presence of inflammation, like in this case of the bleb. So yeah, a slower flow will give you more artifact, but is not exclusive of the presence of more inflammation and maybe creating a thinner wall that's more prone to rupture. So I think this finding complements our thought that maybe is an inflammatory process that leads to rupture. Some of the artifacts that we have seen, like in this case where you see a stagnation of flow with this artifact, but now we know how to process that image so we don't get this artifact. Some of the partially thrombosed aneurysms, we're analyzing a large series of 38 partially thrombosed aneurysms to better understand how this partial clot behaves in some of these aneurysms. And this comes back to the theory of the carotid with the different layers. To summarize, high-resolution provides important information about aneurysm biology. Definitely enhancement can be objectively measured. Any study that's going to study these prospectively should have an objective measurement of enhancement. The 3D color maps that our group and other groups can generate will give you a really good 3D view of the aneurysm. This should not study as a 2D view because aneurysms are complex structures. We can also look at the histograms because the behavior of the distribution of gadolinium is not going to be the same along the entire wall. The limitations of high resolution is the voxel size. We can get to a voxel size of 0.4, but we know that the thickness of the wall can vary between 0.02 to 0.5 millimeters. So it might oversample some of these aneurysm walls. You have to take into account the pulsation artifacts of some of these aneurysms that are free floating in the surrounding space. Sometimes it's challenging because of contamination of the sinuses to analyze some of these aneurysms. We have to take into consideration also the intraluminal clot of these partially thrombosed aneurysms. And we also very cognizant of the slow flow artifact that has been described by other groups. So ideally, we have this pipeline with the 7 Tesla. Not obviously, not everybody has access to the 7 Tesla, but the idea with using the 7 Tesla is develop the pipeline, identify what we can measure, do the post-acquisition processing, identify possible biomarkers, and use this for the 3 Tesla. And this is one of the first papers that came from the 3 Tesla analysis of our database, that it showed that all the parameters, all the metrics that we were looking at, which we gave different names, were statistically significant in this cohort of patients that presented with symptomatic aneurysms. And symptomatic was defined as rupture aneurysms, aneurysms that had a sentinel headache, or aneurysms that were causing cranial nerve palsy because of pulsation or inflammation next to the cranial nerve. Challenges, MRI restrictions. Some patients obviously have pacemakers. You cannot do an MRI on everyone. Can be multifactorial. Some of these concepts do not apply to these outliers like fusiform and blister aneurysms. And there's always a human factor component. The pipeline is not completely automated to be used. And these are the collaborators in University of Iowa and some of the funding that we have received to do some of this research. Sorry, I was a little bit long, but thank you.
Thank you. Any questions for Edgar? Fantastic talk, man, as usual. And any questions?
Good morning. I just woke up. No, sorry. First of all, thank you very much for the excellent talk, Edgar. Really, the most comprehensive talk on vessel wall imaging I've seen. A few comments and questions. First of all, when you do the imaging, it's a snapshot. That means a vascular wall or an aneurysm wall goes through a transformation. So have you seen patients who have an aneurysm that have a bleb? You do the imaging, and there is no contrast enhancement, and the patient suddenly 4 weeks later comes with headache, no subarachnoid hemorrhage, with very sensitive, finding. You see the patient and you say something is wrong, and then done an imaging and whether there's a difference. That's one question. The second question I have, 60–70% of the aneurysm occurs in female, right? So all the imaging we do using computational flow dynamics and vessel wall imaging, is that an epiphenomena? In other words, is there a genetic predisposition in the female gender that is linked to the genes and to the immune system as a response to certain focal spots in the vasculature that are weak in all of us? But we don't all become or have an aneurysm, especially in the male population. So when you do your CFD studies and you show low wall shear stress, high wall shear stress, you have to keep in mind that the scale you shows a 0 dynes per square millimeter or centimeter in the vessel wall, which is not true. A vessel wall is under pressure. So there's never 0 dynes per square centimeter on shear. The shear is already in the ballpark of 15, 20. And then when you look at the gradient, it's just a little offset. And those changes happen during exercise, drinking, partying, relaxing, whatever. So the scale, what you see, there's color maps of the CFD. And Adel, I don't know whether Adel is here, is just a expansion, which is not the reality. That's why they're battling in the CFD world about wall shear low, wall shear high, what's really the shear should be. So my question is that all epiphenomena? Main question. And the second question is that a snapshot in our body? So if, we go out, yesterday we went out, I had a little bit more than Ricardo. If you would do vessel wall imaging, maybe I have spots in my brain that will light up because there is an inflammation going on and there's immune response to that. Okay, longitudinal study versus single snapshot studies.
Yeah, thank you, Professor Wacklo. Great comments from one of the world experts in aneurysm, and I know you feel very passionate about this because you've been studying these things for your whole life. But we do have a couple cases that we have seen changes, because of the time, and we have time to show it. Especially with QSM, there's a couple cases we have seen microhemorrhages. The QSM is one of the sequences that you use to look at. They used to do it for amyloid angiopathy to look at the presence of hemosiderin. And it's a sequence that after post-processing, you can see these little volumes of microhemorrhages, some of these aneurysm walls. We have seen a couple of these patients with also wall enhancement, but we don't have a large series to really publish it. Regarding the second question about the epiphenomenon and the analysis of the CFDs, the CFDs is like a lot of assumptions. You don't really know. You assume everything is laminar flow, different parameters for the inflow and the outflow. The interesting thing is that our group and other groups have found the same thing, even with different assumptions, that wall shear stress might be correlated with more enhancement. The solution for that will be the 4D MRI, which doesn't have a lot of assumptions. The problem is that I don't think the technology is up to par to use the 4D MRI to do this very detailed analysis on slices of aneurysms, which are so small. But I think it's trying to pick up signals until we're getting somewhere. But obviously, you know, it's not a complete story, especially with the CFD. And the biological is a great question. That now we have a series of 400 aneurysms that have been segmented. So we'll be looking at some of the biological markers like gender and immunosuppression, things like that, that might give us clues about that.
Any other questions? I have one, Edgar. Phenomenal research, and I thank you for leading that. In your day-to-day practice, how are you using that? I saw the example of the pica. I know working with Dave before. Today, you're seeing a patient in clinic. Are you routinely ordering aneurysm wall enhancement for all your aneurysm patients? And how's that driving your decision on to treat or not to treat?
Yeah, all of the elective aneurysms get a high resolution 3 Tesla with the sequences that we have, and you know, we do use enhancement to the site. I see it myself, and my colleagues, half of the group does the same. If you see like a bordersome aneurysm that you are not really sold into treating, and you see enhancement, we'll treat it. If we see an aneurysm that doesn't enhance at all, we leave it alone, especially is a bordersome indication. So we do use enhancement. Also for the sometimes rupture aneurysms that have multiple patients with multiple aneurysms, we know which one rupture. We use also that in the decision making. The only time when I use phases or UIATS and I document on the note is when I don't want to treat, because that usually gives me a low score, and I leave it alone.
Thank you.
I'm with Derek Schimmel with I'm one of the NeuroRads. You had you published an article with Farahim 4 or 5 years, 6 years ago, and you looked at some patients who had also gotten aspirin therapy and showed decreased uptake of or decreased signal within the aneurysm walls after aspirin, and you had shown also that there was a correlation with macrophage uptake. Are you still using Farahim? And where do you kind of stand with aspirin as medical therapy and how it relates to your management of patients?
Yeah, no, that's a great question. Some of these aneurysms that, again, are borderline, if they need to be treated or not, and we decide that we agree with the patient that we're not going to treat, I put them on a baby aspirin, and I tell them, you know, this is research only, it's not really being validated. We strongly believe on this. One of my previous colleagues, David Hassan, did a wonderful work with aspirin, but we do that in clinical practice, but we disclose to the patient that it's not really in the guidelines, but we strongly believe that's going to help. And the QSM, we don't use it. We took it away from the protocol because 30% of the time you cannot process aneurysms that are close to the skull base. You cannot really, there's too much artifact. So, and it also adds like 5 minutes to the high resolution visual engineering protocol, which the patient is already having a hard time holding still for 20 minutes. So we try to shorten as much as we can. So we're not using QSM anymore.
Thank you, Edgar. We can talk about this all day, as you guys know. Dr. Samaniego was so jealous of Pontevedra that he's taking home a little piece of that to Iowa on behalf of our team. Edgar, thank you, man, for being here.
Thank you.
Phenomenal work, man. Thank you. On the same topic, unfortunately, Professor Malik could not be with us in person, but he was kind enough to jump in and talk about vessel morphology, hemodynamics, and brain aneurysm. Ado, thank you very much, man, for taking time of your busy schedule and be here via phenomenal COVID inspired technology enhanced Zoom Teams. Thank you, Ado.
Thank you very much, Ricardo. It's really an honor to be able to talk to you. And I'm so sorry I missed my flight last night, ironically treating a subarachnoid hemorrhage. So thank you very much. And I really appreciate the invitation and love this symposium. So great job, Dr. Samaniego, really wonderful work. I kind of wanted to switch a little gears and talk a little bit about some of the things that may lead to aneurysms and kind of complete the discussion. These are my disclosures. They're not relevant to the current talk. So if we think about the vessels in the brain, they kind of look like highways. And, you know, what is it that makes the structure of these vessels?
Excuse me, Dr. Malik, you're not sharing your PowerPoint.
Okay, sorry about that.
That's okay. Okay, perfect,
Is this better? Thank you.
perfect.
Okay, thank you very much. So these are my disclosures. And so really, one of the questions is, you know, the blood vessels in the brain have a very specific architecture. There's a rhyme and reason for why these vessels branch at certain angles. What is the relationship of the mother and daughter vessels? And why does this evolve in the way that it does? And I'm going to try to show you that, in fact, there's a link between the structure of these vessels and the actual outcome of aneurysm formation. Can you guys see the screen? Okay.
Yes, perfect.
All right, thank you. So what is it that causes this angle here to change? And what is it that causes these vessels to have this relationship as shown here on this 3D angiogram? Interestingly, if we go back to 1926, Cecil Murray wrote this article, which has really influenced my life and my work. And it actually looked at the relationship between the parent vessel and the daughter vessels. As you know, aneurysms form at bifurcations usually. And it turns out that there is a magical golden rule, if you will, between the size of the mother and daughter vessels. And it's defined as what's come to be known as Murray's law, which states that the radius of the daughter vessel's Q power over the mother radius Q power is equal to 1. It turns out that that is in fact a golden rule that applies all the way from chicken embryos to rats, to mice, to humans. And I will show you that in fact it applies to our brains. And we talked about shear stress. What is shear stress? Well, it's the actual frictional force that regular blood flow induces on the surface on the endothelial cells. And it turns out the endothelial cell is very powerful. It makes a whole slew of products that influence both the function of the endothelial cell, but the underlying smooth muscle wall. The blood flow induces both this shear stress, and it also induces tension in the wall. But this shear stress actually turns out is maintained at the same at bifurcations. So the shear stress on the parent wall will be the same as the daughter wall. And in fact, it turns out that's the lowest energy solution to any network. So if you were to ask your plumber to design a pipe network in your house that's pumping a certain amount of blood flow the way to minimize the energy required to pump the system is to maintain the shear stress constant throughout the network. And that's exactly what the endothelial cell seems to do. In fact, the endothelial cell, when you expose it to flow, aligns in the direction of blood flow. Most of the research on endothelial cells done by biopharma is done with endothelial cells at rest, which is not actually reproducing what they do in our body. This shear stress also happens to direct changes when you have a fistula. When you construct a fistula and increase the blood flow, as you can see here in the common carotid, it actually causes the carotid artery to dilate so that at the high flow, the shear stress is returned back to its prior level. And that's what we see in AVMs. When you see the feeder arteries that have high flow, you see the vessels are dilated compared to the normal ones. But the shear stress in the normal and the feeder arteries are actually the same because they're regulated by the endothelial cell as part of this local network optimization for global minimization of energy expenditure. So the endothelial cell is sensing shear and altering its gene expression pattern to maintain this shear stress constant. And that's how we've evolved. It turns out on the low shear, and this is an article that now is over 20 years old, I wrote part of my dissertation. When you have low shear stress, you actually get a pro-inflammatory phenotype. All of the gene expression products cause inflammation of the underlying wall. I think that has guided my work, both for carotid atherosclerosis, that you saw in these beautiful pictures Dr. Samaniego showed, as well as in areas of low shear, although obviously aneurysm rupture is very complex. So one of the questions is we wanted to ask ourselves, as we started getting these 3D imaging and the high resolution cone beam CT, does this relationship actually hold in our patients' cerebral vasculature? And how do they differ when we have a normal bifurcation versus one that has an aneurysm? And so we actually did this work and published it. And one of the key points was, how do you measure vessels? It's very difficult to do that in 3D because as you window it, the vessel increases in size and decreases, and you get results all over the place. And so we applied something called Sobel filtering. It's basically a three-dimensional edge detection filter. And so if you look at this view here, when you actually change the windowing without filtering, you can see the vessel increases and decreases, and you can't do research with that. But when you actually apply the filter and then you change the width, you can see that the edges don't change, just the thickness of the edge. So they can actually start to use quantitative analysis in 3D. And we actually computed this exponent ratio or Murray's law, and both in normal bifurcation, as you see here in A and B, but also in aneurysmal bifurcations. And one of the things that we started to notice is in aneurysmal bifurcation, this law does not apply. In fact, a lot of the daughters were bigger than their mother. So here's the mother and here's the daughter. You see the daughter is actually bigger. The daughter is bigger than the mother in caliber. And this basically is what this analysis showed. In the human brain, in normal bifurcations, we could see that the exponent ratio, Murray's law, was in fact respected. However, in aneurysmal bifurcations, it was not. And in many cases, the daughter was again larger. In fact, by looking at this exponent ratio at any bifurcation, we actually were able to predict whether it was an aneurysm-bearing bifurcation or not with a very high AUC. Again, another example of this phenomenon, where the daughter in abnormal vessels, like you see here, that have an aneurysm is actually larger than the mother compared to normal ones. And then we also started to notice sometimes very subtle tapering and narrowing of the neck of the mother, leading to the aneurysm. And that's actually, so in summary, aneurysmal bifurcations do not obey Murray's law, and normal bifurcations do. We were lucky to then partner with Kenichi Kono from Japan, because they actually have a lot of intracranial atherosclerosis in Japan. And when we were talking once, he mentioned he had a few case series of aneurysms that had ruptured, that had proximal stenosis. And so actually partnering with him on a Japanese population, we were able to perform this analysis and look at aneurysm that had ruptured and aneurysm that had not ruptured, and look at this area of narrowing to try to figure out, could that somehow be contributing to aneurysm rupture? And it turns out, in fact, that ruptured aneurysms many times had a stenosis that was much higher. This tapering proximal upstream in the mother was significantly different and higher in the ruptured versus the unruptured. And in fact, we could see that this, what we call the stenosis index, was significantly higher. But the other thing that was important was also not only how narrow the stenosis was, but the distance of the stenosis to the bifurcation and to the aneurysm. And if you think about it, it started us thinking, imagine you grab your garden hose and squeeze it. What happens? Well, you can get a much sharper focused jet that has much higher velocity. And using computational fluid dynamics, we're able to model this phenomenon, and it results in increased directed jet of flow into the aneurysm, increased pressure, increased using finite element analysis, increased tension in the wall, which we think contributes to the rupture. We then started to ask, well, this is in a specific population with known stenosis. What about are patient population, patients that have an unruptured MCA aneurysm in the US. Could there be a subtle parent vessel upstream narrowing in MCA aneurysms? We picked the MCA location because it's very simple to study. And we actually compared the side that had the aneurysm versus the contralateral side. And so using high resolution 3-dimensional rotational angiography, we actually performed the analysis where we did the Sobel filtering and followed the center of the vessel and basically cut very finely, and then did the measurements and looked at tapering on the side that has the aneurysm versus not. And sure enough, it turns out that the side in the same patient that has the aneurysm demonstrates a gentle tapering, kind of like a fire hose, compared to the side that does not have the aneurysm. And you can see this modeling as if you have no tapering, this is what the shear forces look like, and the shear gradient. And as you start increasing the tapering, you can see you have a much higher shear gradient. And this is, please remember this picture because and I'm going to show you what it does to endothelial cells. So this phenomenon of kind of tapering or fire hose focusing results in this increased shear gradient at the bifurcation, even in unruptured aneurysms. So then we asked, is this limited to the middle cerebral artery bifurcation? And we started looking at the anterior communicating complex and looking at our cases. And again, we noticed even in unruptured cases that there was many times a subtle narrowing stenosis upstream right before the aneurysm. Again, we dubbed this phenomenon the fire hose nozzle effect, because what happens is you basically focus, just imagine, grab your garden hose and squeeze it. And that seems to be what's happening even in the ACOM when you look at aneurysmal versus non-aneurysmal. Again, with the same analysis, we see that in the aneurysm, we have much more tapering at 0.69. The ruptured aneurysm have even more, but we didn't quite reach a statistical significance compared to the non-aneurysmal side. So significant difference between the aneurysm bearing versus non-aneurysm anterior communicating. And again, you can see this here, the tapering ratio, looking at healthy versus contralateral versus aneurysm bearing A1. We model that simply with inducing a little tapering, and you can see what that causes. You can basically get a concentration of shear over here that you don't see on the side that does not show tapering. We then started looking, well, we know that the aneurysms form at bifurcations as shown nicely by this study with Dr. Rudin, and we started looking at bifurcation angle because in my practice, many times I noticed looking at aneurysmal bifurcation, they seem to be having a much wider angle if you look at the angle of the bifurcation compared to normal ones, which had a much narrower angle. And so we did a study with Fatih Tutuncu was visiting a student from Turkey and looked at the basilar bifurcation and compared with the vertebro-basilar junction, where actually is the only location where two arteries come to join together, and in both patients that had aneurysms of the basilar artery versus healthy patients. And when we looked at that, we saw there was a significant difference in the angle of the basilar artery in aneurysms that have in bifurcation that have an aneurysm much wider compared to the healthy patients that had a control that was much narrower. This did not hold for the vertebro-basilar junction, which showed no difference. And again, we could really predict the presence of an aneurysm based on angle of the bifurcation. Interestingly, Dr. Waklo, you asked about males and females. Females seem to show a much steeper increase in that angle with age, which happens both in male as we age and females, but females have a more steep increase. In fact, if you look at the angle, we were able to predict the size of the neck of the aneurysm purely based on the angle of the bifurcation. And that has to do with the shear gradients that occur at that point. Is this limited to the basilar bifurcation? We then looked at the middle cerebral artery bifurcation, comparing aneurysmal versus normal. And again, we published this in Stroke, looking at both the angle of the bifurcation and another angle we called inclination, which the angle that the M1 trunk makes with the M2 branches. And then what we saw, again, is a significant difference. When you look at the complete angle of the bifurcation, much higher, around 150 degrees compared to controls, and also compared to patients that don't have a aneurysm at that location, but have an aneurysm on the other location. So again, angle playing a very large role, to the point where we can have an AUC of 0.98 when looking at the bifurcation. So what does it mean in terms of hemodynamics if you're an endothelial cell? Well, this is one of the first experiments done in vitro back at MIT by Natasha De Paula, which put this little ledge and actually culture endothelial cells. And what that causes is you get this reattachment zone that basically looks like the point of impingement, and you get this shear gradient that we saw. And when you have a high shear gradient, the endothelial cells actually separate and migrate away. And they actually have inflammatory changes, and actually induce the production of metalloproteinases, which can actually cause dissolution of the wall and potential aneurysmogenesis. This was shown also beautifully by Dr. Meng and the group at Buffalo in construction with these different fistulas and kind of a construction and the animal model, showing these multiple areas of shear and shear gradient, showing that high shear and shear gradient areas are associated with aneurysm genesis and dissolution of the external cellular matrix. How does this relate to us? Well, we actually took back and did some CFD, and actually it turns out that when the bifurcation goes above 85 degrees, you start getting those positive aneurysmogenic shear gradients, regardless. And so it's a very simple fact of bifurcation angle. Any bifurcation that is above 85 degrees starts to induce this flip from a protective negative shear gradient to an aneurysmogenic positive shear gradient. And this applies even if you have a healthy angle, the aneurysm will develop on the unhealthy angle side. And we then did aneurysm removal and showed that these shear gradients actually, depending on angle, also were seen in patients. We then looked at another aspect that bifurcation angle induces. And it turns out that having a wide angle induces these vortices that I don't think have been previously described in the literature. We just recently published that. Again, looking at the shear at the cross section, as we have a wide angle, you can see we start forming these vortices, and these vortices are associated with these aneurysmogenic shear gradients on the wall. And I will just show you, this is a narrow angle, 60 degrees. This is what starts to happen when you have a wider angle and a wider angle still. You can see these vortices occur near the bifurcation and actually gently decay away from the bifurcation, as this shows. So again, in the narrow, healthy bifurcation, you have some and then quickly decay. In the wide bifurcation, you have these persistent vortices and persistent aneurysmogenic changes that occur, as we saw in the basilar and middle cerebral artery. And this is, again, just showing a CFD cross-sectional imaging of these difference between a wide bifurcation and a narrow, healthy bifurcation. I won't, this is, again, just shows the same phenomenon. The wider the angle, the more these persist before decaying. These are actual patient bifurcations that show the same phenomenon, showing, again, more rotational vortices on the wider angle side. So a wide bifurcation angle induces aneurysmogenic longitudinal shear gradients anytime you have an angle above 85 degrees. And it also induces this new previously undescribed transverse rotational shear gradient because of the vortices that occur at wide angle. What does this mean to us as surgeons and physicians? Well, one of the major treatment for aneurysms has been the use of stents and stent coiling. And one of the things that we saw early on working with one of my postdoc, Dr. Bulan Gao, who was visiting from China, is the fact that whenever we treat basilar aneurysm, for instance, and we are here placing 2 neuroform stents, you can see just placing the stents already has decreased the angle of the bifurcation. And this is a phenomenon that happens right immediately after the stent, but continues to occur so that it continues even at 4 months. There's still a straightening of the vessel, going from an unhealthy wide angle to a much healthier. Here you have about close to 65-degree angle change and bringing it back to a healthier pattern. And this is something that a intra-aneurysmal flow diverter like a web device, for instance, does not do. It does not change this angle. Looking at a single stenting of bifurcation aneurysm, we see that this angle change happens more in smaller vessels like the ACOM and less in the ICA. It also happens more with certain types of stents. For instance, the Enterprise stent, Enterprise 1, straightened the vessel dramatically more than the Neuroform 1, and both of these much more than the more modern stents that we use. Here again, comparing the Neuroform versus the Enterprise and the amount of angular change. We again repeated this for the basilar bifurcation for a series of Y stenting, and then this is the same figure, again, dramatic alignment, and you can see the angle changes significantly with time, both immediately and in a delayed fashion. So does angle play a role in sidewall aneurysms as well? To do that, we actually looked at curvature in ICA, and working with Alex Lorick in the lab, she was able to actually show that aneurysms seem to form right after sharp changes in the curvature. Again, a phenomenon that we then took to look at not only kind of paraclinode aneurysms, but more recently at the PCOM. We looked at PCOM aneurysms and looked at the curvature of the vessel in patients that had an aneurysm versus no aneurysm. And looking at this angulation of the ICA at the PCOM location, there's a significant difference. Patients that have an aneurysm have a much tighter curvature, whereas those that don't have a much smoother, gentler. Look at this compared to that. Again, this holds both in aneurysmals that have a much higher angle compared to both the contralateral and patients that are healthy. And these angular changes have many effects. They actually increase, again, the shear gradients and also the focal pressure at that point. So in conclusion, the cerebrovascular tree in our brain obeys Murray's optimality principle. It's a golden rule that dictates the relationship of vessels with the mother and the daughter at all branching points. And the goal is to maintain shear stress the same in the brain and in our body. And that's the healthy state. Aneurysm-bearing bifurcations do not obey Murray's law. That helped us identify this upstream stenosis called the fire hose nozzle effect that happens both in pathological rupture as well as an unruptured aneurysm. At least we have documented it both MCA and ACOM aneurysms, the 2 most common brain aneurysms. The fire hose nozzle effect, as I showed to you, intensifies the aneurysmogenic shear gradients. And as I'd like to describe it, grab your fire hose and gently dangle it over some sand, and then now squeeze it, and then you have that effect where the sand simply gets blasted away. Vascular bifurcations, those wide angles and high parent vessel angulation curvature are associated with aneurysm. I've shown you both the association with the both longitudinal and the rotational shear gradients. And wide angles above 85 degrees are completely a different beast and cause these aneurysmogenic changes regardless. Parent vessel modification using some of the endovascular devices that we use in our daily work have significant implications, both by straightening the vessel, decreasing the curvature, modifying the upstream angle, especially as well with flow diverters and stents, as Dr. Waklu will attest. And those may actually play a role in attenuating the underlying hemodynamics that promote aneurysm formation and recurrence, and may determine whether an endovascular device is more successful than another. And so thank you very much. This is my group in my lab. Alexandra Lorick is an absolute cornerstone, and we've had the help of many students through the Tufts system and visiting scholars as well. Thank you very much. I appreciate it.
Can we keep the screen there, please? Oh, here, thank you. So the transmission here, the voice from above that you heard was not God, was John Bennett from Neurosurgical TV that is live streaming this through all over the world. And you saw a comment, and maybe Johnny can show the Q&A from the transmission there. Thank you, Ado, for brilliant work as usual. We're open for AJ is trying to grab the microphone here, so I'm going to pass the microphone to him.
Adel, first of all, congratulations, your lifetime work, exceptional and impressive. I have a question regarding this funnel effect you're talking, where you get this jet into the MCA aneurysm. First of all, is that structural change born in patient, or is that something that develops over time? And have you seen some reversal changes of those narrowing? I see that in some patients, and I've followed them up, and in fact, it goes away or it gets worse. The second question is, if the endothelial cells experiences in those conditions higher shear, and there's signal going through the smooth muscle cells, is there an adaptation of the smooth muscle cells to the higher wall shear experienced? In other words, does the body constantly compensate for these impingement points that are created by the irregular shear to basically counteract? Have you seen that?
Thank you very much, Ajay, and these are excellent questions. In fact, I don't understand the mechanism of this. And we have looked at it. As you know, I use a lot of intraarterial verapamil when we are doing an intervention just to decrease catheter spasm. And it looks like at least some of it is reversible by using a calcium channel blocker. So I think this is not necessarily a structural change. It may be a combination of a transient or pathological, perhaps smoking, genetics, or other factors may contribute to this. And there may be other medical treatments that may in fact relieve this. That's kind of really all I can say is that it does not appear to be a atherosclerotic phenomenon. At least in the MCA, in a few cases where we've administered verapamil, we have seen it change. It does open up the question of, are there any therapeutics that could be performed, or do, for instance, some of the medications that we take, maybe statins, maybe aspirin, maybe some of the antihypertensive modulate this phenomenon more than others.
Thank you, Ado. A question for you. Are you doing any work, so high-risk populations, fibromuscular dysplasia, familial history, are you doing any work in measuring these angles ahead of time? So let's say 50-year-old, 2 family members with aneurysm, you do an MRA and you see an angle of 240. Are you making any comments to this person that his angles or her angles are off? We've got to keep a closer eye on that. Are you doing anything in that direction?
Thank you very much, Ricardo. That's an excellent question. We have not really applied this to clinical decision making beyond saying that if we do, see stenosis, I can think about it a little bit differently now. You used to think maybe it's somewhat protective, it decreases the pressure, but in fact, it turns out, when I see a stenosis now, I'm a bit more proactive towards treating than not. We have not really focused on kind of subpopulations. Our medical center is relatively small in size compared to others, and you would need a multi-center, very large, group of centers to kind of pull data together for these high-risk populations. But it's an excellent idea.
I have a question. Is Edgar Samaniego here? Congratulations on the talk, and big admirer of your work.
Thank you.
We're starting to do some FAA analysis Do you have some words about the concentration of the wall tension on some of these bifurcation aneurysms? Where you encounter most of the tension?
We have actually done quite a bit of FEA, and the issue with FEA, in fact, the highest tension is actually at the base of the aneurysm, at the neck. The critical aspect about FEA is you need to take into account the wall thickness, because, as you know, it's the force divided by the thickness gives you the tension, and that's where basically we think the thinning of the local wall, and you may be able to show that with the 7T. We don't have the ability to see that, obviously, with just the regular imaging, but that may be one area where you would be able to combine the thickness of the vessel wall seen on 7T or higher with the finite count analysis. It's a good point.
Thank you, guys.
Question.
Please.
Good morning, Dr. Saron, hospitalist. From practical purposes, do we know, I think you already kind of answered the question, but do we know, for example, we see patients very often, comes for a headache, middle-aged woman, smoker, probably use contraceptives before, hypertension, who comes in with headache, we do a CT angiogram, and we find a wide, narrow angle in the basilar artery. Do we start recommending them to have more frequent follow-up with neurosurgeon, more frequent MRIs more often, or to watch for developing aneurysm in the future, or any comments?
Thank you very much. That's an excellent question. You know, this is really work that we just concluded about a year and a half ago for the ACOM. And, you know, what we hope to do is start the conversation and hopefully have other centers confirm our work and expand it. And when we have validation from different groups and you know, it becomes more widely accepted and observed, then I think we can start thinking about you know, the next step where we actually prescribe altering current care. But I hope that will be something that guides us in the future, especially as, you know, with large availability of data sets from the various AI solutions, it may be possible to start looking at that and taking it into predictive space. But that's an excellent suggestion.
Question from the Q&A from the streaming, Ado, Edgar, AJ. If an aneurysm enlarges at a bifurcation or junction area, is this biology, that hemodynamics? Can this change predict rupture? So what are your thoughts about that?
I mean, I think certainly, you know, whenever you see a change in the size of an aneurysm or configuration, it's certainly a call for rapid action, you know, in controlled fashion. You know, because of the way that we treat the aneurysms in the United States, we rarely sit on aneurysms that evolve or change and actually tend to be more aggressive and proactive compared to other countries. But by doing that, we also lose the information that you can obtain from longitudinal follow-up. But in my practice, you know, if I do see a change, I definitely recommend treatment if the patient is in a reasonable risk bracket.
Yeah, I'm on the same page. It's probably a combination of flow dynamics, which trigger biological changes in the aneurysm wall that will lead for growth and eventually rupture. So it's complex interaction of all these things, as was nicely presented by Professor Malik, how all these CFDs parameters affecting the endothelium. Any comments, Dr. Waklo?
So I think that it's interesting that patients that undergo microdissections and are sensitive enough describe that very interestingly. They say, I used to have headaches, but last week I got a headache that's completely unusual. for me. And I think these micro dissections are associated with what Dr. Malik was describing, that they are micro traumas, micro injuries to the endothelial layers, and that there is an ongoing inflammatory response that takes place, and it leads to sudden growth of these aneurysms because there is an enzymatic upregulation, metalloproteinases, and that goes very rapidly. And that's why we in the past have never understood that small aneurysms suddenly rupture. I think there is a change in the endothelial lining, what you heard from Dr. Malik, which is important. It's very difficult because it's a snapshot to describe that longitude. But this is probably definitely an acute situation that needs to be.
Thank you, Ado. Really appreciate your time. We're gonna change a little bit the program. We're gonna take a break now to 10 a.m. and we're gonna come back with a New England Canadian attack from AJ, Matt, John, and Victor. So stay tuned. We'll come back at 10.
We'll go down this flash. Yep.
Glad everybody got a coffee to be energized for the second session of the morning. It is my distinct honor to invite AJ Kumar Wakalu here. Professor Wakalu is, even though still really young, he's one of the pioneers in our field. Cannot tell you how many things I learned from him. A lot of the crew in this room here, Crossroads, early days in Buffalo. So hats off to Nick Hopkins that brought this guy there. And I still have as a contact, Matt Goodness is a he's a biomedical engineer student. It's still the way Matt shows up on my contact. So thank you, AJ, for being here. And he's going to talk to us this first talk about posterior circulation aneurysm or whatever he wants to enlighten us about. Thank you for being here, my friend.
Good afternoon or good morning still. I want to thank the organizers and especially Dr. Hanel for this kind invitation. I think this is my 5th or 6th time here, and I always accept the invitation. My wife just left yesterday for Madrid, and she wanted to take with me. The reason being is I think this forum is excellent. I love the audience. I love the questions. I love also the program Dr. Hanel puts together. And I can tell you that what you heard this morning on lectures, that's the best of the best you get in our field. It's amazing there are other speakers, Matthew, I know when he was a student still, I think he was 18. He says he was 19, but I think he was 18. So you will hear colleagues of mine and researchers. Dr. John Wong will be talking. So you will hear really some exciting research, cutting edge technology that's being done and introduced in our field. And we thank Ricardo for bringing everybody together here. So I will be talking about a stepchild, an orphan of aneurysms, which I deep down even not believe that it's aneurysm. It looks like an aneurysm. It doesn't behave like an aneurysm. And interesting enough, 80% of those patients are male, unlike 60+% female in the typical category of aneurysm you will be finding. That's one thing. And the other thing is, with my second presentation later, I want to introduce you to what are we doing now with these implantable devices. And that's the next step. How do we bring biology, or what we call regenerative medicine, into endovascular treatment? And I think that's the next frontier, as well as imaging, as you will hear later. So these are my disclosures. Some of the work has been supported through NIH and industrial grants, and I have a lot of conflicts. Like some, I think, famous cardiologists used to say, I don't have conflicts, I have only interests. So that's good. But related to this talk, I have no financial disclosure to make. Now, I think that there are two major innovations over the last several decades, and I'm lucky to be a part of them, that have changed the healthcare. The one is the flow diversion, and you have heard about that a lot in the last meetings, and you will hear about it quite a bit, and then stent retriever for ischemic stroke. Now, going back a little bit to the epidemiology of aneurysm, you will find that the latest studies from Japan confirm these old studies that size of aneurysm predicts, whether it's anterior circulation or posterior circulation, the risk for rupture. And the risk for rupture in the posterior circulation goes significantly higher, not only with the size, but also the shape of the aneurysm. And phases score, you heard from Dr. Edgar Samaniego, that the phases score, some of us use, they have all the shortcomings. This one, for example, has the shortcoming that it doesn't consider a history like smoking, hypertension as being a part of predictive value. Then the other stroke scale, you heard the UTIA, has same or similar limitations. It tries to help us giving guidelines, but in the end, machine learning, AI, data collection will probably be better in regenerating neural algorithms that will help us being more specific and sensitive with these predictions. And we log in then the sizes of the aneurysms and the associated comorbidities, and then we come with a scale that is helpful for our patients, and we can tell them you need a treatment or you can wait or you don't need treatment. However, the posterior circulation has remained, that's where my focus is, a stepchild. Like I said, the reason being is that the risk for bleeding of those dolichoectatic aneurysm or having ischemic stroke due to the little branches that supply the brain stem called perforators is high. So there is a risk for ischemic stroke because of the smaller vessels going down, and there's a risk for rupture of these aneurysms, and we don't know why one or the other happens in these aneurysms. The 5-year mortality of these aneurysms and morbidity is very high and well studied in the US as well as in the Japanese literature. So like I listed here, 80% mortality over the last 5 years if untreated. And the endovascular treatment mortality with these cases are, if we can treat, about 20%, and surgery has a very high mortality dependent what kind of management we offer to this patient, up to 80%. So what do we today in the modern medicine of vascular or endovascular treatment of aneurysm expect from these devices and technologies? We expect safety and efficacy, but there's also a global need. So when we invent something in the United States, we help patients here, it should be transferable to other parts, low and middle income country. And that has been a challenge. To give you just an example, and I'm sure tomorrow they will talk about ischemic stroke. For example, we do about 15-20% thrombectomies of all eligible patients in the United States. In low income countries, about 0.01% or less. Middle income countries, 1-2%. So we are living in a population of 8 billion. So we are here on an island and still we don't have the penetration we want. So now imagine the growth, the potential growth and shift of all this to other places. So we have to make sure that these technologies are economically viable. Now the flow diverters, and I don't need to talk about that. I'm sure that Dr. Hanel covered that in the previous meetings, that the flow diverter has been incorporated in the treatment arm and realm of aneurysm. We treat about 20-30% of an aneurysms today with flow diverters with a sidewall bifurcation. And there were some studies here for large and giant aneurysms, the PUF study that confirmed that. Here a patient, as you see, with a large aneurysm leading to compression of cranial nerves. And after the management, some of the deficit went away, but we prevented the patient also from a rupture of these giant aneurysms. Then came the second study, the SENT study, that expanded the indication to more ICA terminus. So we are getting further and further in the vasculature of the brain. And that showed, as well as efficacy similar to the PUF study, that a single device was very beneficial for treatment of these aneurysms. And we have a very low complications with these devices, single digit, and their occlusion rates are somewhere between 70 to 90%. They are not 100%. So we are working on ancillary products and other solutions to enhance that occlusion. Then this is a case that was done with a flow diverter, surgically, definitely a challenging case with a higher morbidity and mortality than with endovasculars. Then there were the third study that was conducted, and Dr. Hanel was the PI on that, was the premier. So we are moving now more and more distal to the circle of Willis as this technology are emerging and getting better and better. Where did the journey start? For the posterior circulation, we had an early experience with stents that came in the late 90s on the market, and we tried to use them and navigate them up into the brain. And we used coils, and then we published our data, and what showed that stent and coiling in the posterior circulation was a feasible method. We had some success. I have to say 60–70% of the patients did well, but there was a lot of peri-procedure morbidity and mortality associated with this, and also the mechanisms to deliver these implants to the area of entrance was very compromised by the systems. So we traveled using cardiac systems through the groin up to the brain, and that was literally a great challenge. This is one of my first patients I treated in University of Miami back in early 2000, was a 75-year-old patient with this monstrous aneurysm. And it was a challenge to get this wall stent, which is a carotid stent, all the way up into the basilar artery, and we placed 140 coils. It was not only from the economy an enormous undertaking, but also technically it was super challenging. But the results was good. The guy came for 5-year follow-up. I don't know whether he's still alive. And he started reading his newspaper, and he was a happy guy. So this was very encouraging. So these early experiences with the stent and coiling and the existence of the flow diverter for other parts of the brain encourage us to use the flow diverter in the posterior circulation. Now we had an implant that could serve this subset of patients. And we did some cases, easier cases. For example, this is a P3 dissecting aneurysm in a doctor I treated with a flow diverter. We placed 2 telescoping because these tubular structures were not long enough. So we placed one and we placed a second one through it. And as you see on the follow-up 4 days later, the aneurysm is gone, and you have cured this patient. This patient can go, it was a ruptured thrombosed aneurysm. This patient can go home, and you can tell him that his chances of rebleeding are significantly lower than taking the coil mass or stents and on and on. So this technology really was beneficial, and these are the tubes. So we went and start introducing flow diverter for the posterior circulation, and at that time, we put the patient on dual antiplatelet treatment. We learned it from our cardiologist. The colleague said, well, if you put a coronary stent, you need to put the patient on dual antiplatelet. We never asked, does that apply to the brain or not? We just did it. We did it, and we said, okay, let's try out in a larger studies. And the interesting thing was when we did the subset analysis of all patients that involved that segment of the artery, so the brainstem, the vertebral basilar complex, we found the same results like in anterior circulation. We had almost 80% occlusion rates. However, the survival and the post-procedure morbidity and mortality was very high. This is one of those patients, generally male, like I said, 80% male. This gentleman came with this monster, already wheelchair bound. We placed our devices. I think we had to place 3 devices, and he had some ischemic events in the posterior circulation, probably from the manipulation itself. And this was 6 months follow-up. And you see already at 6 months, most of the aneurysm is thrombosed. Unfortunately, the patient expires 12 months later due to pulmonary complications. Probably the aneurysm kept growing, created a mass effect. The patient had a gastric reflex, aspirated, and then died, unfortunately. Another patient, basilar trunk, same approach, very simple to accomplish with technology-wise because these flow diverters are easy to be placed. And we used here 2 flow diverters. He again, 6 months follow-up, very good result. We were happy with that. A year later, the patients died. So what we then decided is, based on our study, to be more aggressive with antiplatelet management, blood pressure management, and started a multi-center prospective study. This is one of the cases we did, and the patient survived, did very well. We closed the other vertebral artery to avoid endoleak, because when these aneurysms involve the other artery, we close it down generally in the same session. Other people want to wait. And this is a 14 months follow-up, and you see nice remodeling and complete eliminating of the aneurysm. And those little branches that we want to keep alive, the perforators, that stayed open. So that was very encouraging. Another patient here, young guy with this big aneurysm that was growing. We placed a flow diverter, we coiled the aneurysm, we thought it may rupture, and the patient did very well. Next morning, he is partly paretic on one side because a smaller branch was occluded and created a damage to the brainstem. So what went wrong? So we looked at that and we thought there are many things that we have to analyze. So there was one of the things that we looked into is how did the patient present at the time of treatment? Was that an important factor for outcome? The other thing that we looked into is the shape of the aneurysm, and there are different groups of these basilar trunk aneurysm that need to be differentiated. That was another very important aspect. So when we then did the whole analysis in summary of this prospective study, multi-center study with many people involved with dual antiplatelet, the mortality and morbidity in our series was 27%. Definitely not something what we had expected. If you compare it with the anterior circulation, the morbidity mortality with these devices is in a single digit. We are talking about 5% complications, including large and giant aneurysm as well. So the problem was clear, we were not understanding it. The other thing is that the asymptomatic patient, so patients who came without symptoms, had a 5% morbidity and 0% mortality. And when you did a subgroup analysis, the people who were already symptomatic, either they were wheelchair bound or had speech problem, had gait disturbance, on, had a mortality of 28% and morbidity of 44%. What were the reasons for that high mortality and morbidity? When we break it down, ischemic stroke was one of the driving forces in 2 patients. Rupture during placement of flow diverter, medullary infarction. So you see always the same recurring theme. We were dealing with ischemia due to small vessels. And as you know, in the brainstem, there's an abundance of vessels it's after all the most critical part of the, not only human being, of all species that run and walk around the planet. And when you see the clinic outcome, you see at discharge and follow-up, nearly 1 year, there were a lot of deaths, a lot of improvements, but a lot of deaths in this patient population that we treated. The angiographic outcomes were the same, like we had initially, about 60 to 70% complete occlusion, and then additional 20% near complete occlusion. So the occlusion rates were not the problem. The problem were the ischemic events during the placement. And when we do the subgroup analysis in this over 50 patients, we will see that patients who presented with an MRS of 0 or 1 at the early stage, so having almost no symptoms or early symptoms, they have much more favorable outcome and very low morbidity and mortality, as shown on the graph. And when we move to higher modified ranking scale at baseline, then we start seeing the numbers going up as far as mortality and morbidity is concerned. To summarize that group of study, prospective study, we had patients when they presented with symptoms of VB junction, dolichoectatic basilar trunk aneurysm, high morbidity and mortality that was unacceptable. So our conclusion was it is safer to enroll these patients when they are early in their disease, and that a single implants was better than using multiple implants, and that we needed long-term dual antiplatelet treatment. Now, when we compared our data with other sites, they had a similar problem. It was basically the perforator occlusions that led to a bad outcome in this population with dual antiplatelet treatment, BUSK. What we then decided, and Dr. Hanel was a part of the group, and that was born out of this meeting here. Many people may not know it. We had several meetings around the basilar trunk aneurysm and how to manage them carefully. So out of this meeting, and I'm thankful, Ricardo, for that, out of this meeting was born a consensus. Let us address the ischemic stroke of this patient. Let us address the management. This is not a technical challenge or a problem of flow diverter. This is a problem of post-op management. This is a neuro ICU care and post-op medical problem. So there was a group, I think we were 15, that decided to collect the data, but do a change to management and add what we call triple therapy. So add anticoagulation therapy. And we started this study. And so we did tight blood pressure management, and then we added Eliquis at our place, starting with 5 milligrams BID, and then tapered it over months and years. I have still patients who are on 2.5 milligram BID Eliquis, because whenever I stop the Eliquis, he becomes symptomatic. Probably some of those little perforators occluding that are being bridged by the flow diverter, and that there is not a sufficient blood supply through collateral circulation during the endothelial process and complete occlusion. The other thing is we kept dual antiplatelet treatment with either ticagrelor or Plavix and aspirin. And then we decided to do CTA, MRA, some centers, and angiography follow-up. Frank Gehry. And this was then recently published. And as you see, your group here, Ricardo, contributed a fair amount. And like I said, I'm looking forward that similar consensus report and study will born out of this meeting as we go forward. So this is the characteristics. So on the one side, we said we use our dual antiplatelet patients. We had 13 patients in that group population. And then we add the Eliquis anticoagulation. There were 14. So there were some changes, so it's not completely comparable. Some changes were, for example, in the triple therapy, the patients were sicker. As you see, the disability pre-procedure, there were 28 patients with severe disability versus 2 patients in the dual antiplatelet arm. Then what about the access? We used more radial access in the triple therapy because by the time we designed the study, the radial access was born, and more people said, wow, going to the posterior circulation to the vertebral artery is much easier in these patients than going through the groin. So that was technically enabled because newer technologies were born, access products were. Then the other thing is, from the dual antiplatelet, we learned we don't want to telescope too many devices. So you see people were using more single devices. And that was something to be considered as an outcome. Now, what about the outcome? The overall MRS scale decline was seen only in 1 patient if they were on dual antiplatelet treatment. Came to me as a surprise, came to all of us as a surprise. So we were on something very important. When you look at the dual antiplatelet treatment, there were 69, also 70% of the patient had some kind of a disability after the treatment, leading to decline in the MRS score. What about the complete occlusion? And that's something that we have to deal with. The complete occlusion dropped in the triple A therapy. Not surprising because you had an anticoagulation on the one side and you had antiplatelet. So you are blocking basically all the elements of the blood that will lead to endothelialization, scarring, sprouting of fibroblast, myofibroblast. So you are disabling the aneurysms to close. That's why we are saying we had to taper slowly from the acute stage when you do the treatment over years to enable a clotting. This is one of the aneurysm from our side. I will show you cases from our side to illustrate the management we learned from this. So this is a patient with a fusiform dolichoic partially thrombosed aneurysm in front of the brain stem. He was dizzy, he has a dizziness, so early signs probably of perforator occlusion. So we placed the device, you see that? I have no mouse. I can't, you guys see that? So we placed a single device. So if you look closer, there is an endo leak from the right vertebral artery. So this is a patient that needs a sacrifice of the right vertebral artery. But then you have to think, there's a big pipe that was supplying the basilar. You acutely close it, you will have drop in blood pressure, a drop in blood flow in that vessel, and you may close smaller branches to the brainstem. So you have to keep the patient hypertensive in the ICU for a few days, manage him carefully so he tolerates or she tolerates that. That's what we did. You have to exactly know where you close these arteries. You don't want to close some perforators to the medulla. So these are technicalities. So we close it behind the flow diverter. So now what you have done is you have stratified the flow. You have taken the complex flow that goes between the two vertebral artery and simplified it. But then you observe that all these bigger branches, I'm sorry, I'm using this here. All these bigger branches that these are very important branches to the brainstem. You have your pica, icas, and then little perforators. There's a distance between the flow diverter to the gap. So the gap will accumulate clot. So you have to avoid the clot formation. Oh, thank you. Good. So you avoid, sorry guys, sorry for that group. So, so you avoid a clot formation here, which then, if you wouldn't have closed it, would wash out the clot and press it into posterior circulation. We had that case. We learned it 10, 15 years ago that you have to sacrifice and get rid of the endoleak. And that's what we did. We placed coils to close this branch, redirected the flow from here, and we wanted to make sure that you don't get immediate clotting of this part of the aneurysm, and then take out all these major suppliers to the brainstem. So you have to put the patient initially on heparin, and 2 days later you can move to Eliquis. This is how it looks. So like I said, the technicality is not a problem. You see the flow diverter, and then you can observe these branches coming off the aneurysm sac, and there is a gap. There's a significant gap because these devices don't abut. They can't open up to any sizes they have patients. And then you see the interface with the coil mass, allowing you to endoleak. Now, then there were other challenges. These aneurysms, for example, are humongous. There are no devices that expand to the size. This was a young patient in his 60s. I'm saying young, it's all relative. So patient with a non-thrombose, with an acute third nerve palsy, and he had something interesting. He had an aortic aneurysm they were observing, and that's something you will see. There's one group of patients that have atherosclerotic aneurysm of the abdomen and other parts, iliac, and they have associated fusiform aneurysm. Then there's a group, younger male, that has this aortic aneurysm, more collagenopathy, I would call them. They have also fusiform aneurysms from iliac, but also in the brain. So all male in our group here. So what we did then in this case is we said, okay, how do we get a flow diverter to sit here if the distal artery is almost 8 millimeters? And there's a lot of now ancillary products that we can introduce. So what we decided to do is we went with one catheter through the flow diverter and a second catheter through the flow diverter to the other side of the posterior cerebral artery. And then we placed 2 stents that expanded the flow diverter to supranominal size. It's like with a scissor. If the scissor is partly closed, you can open it further. And that's what you can do with these braided technologies, because their braid angle is small, but you can force them to open further. And that's what we did. So we did create, like you do autoiliac graft. We created the graft only in the other direction, and we opened this up. Again, you have to put the patient on Eliquis, anticoagulation, and antiplatelet. This is how it looks, constrained form. This is this normal expansion with this braid angle, and the supranominal means you force the device to further open up with a stent. These are brain stents manufactured for those locations. That's easily accomplished because the crush force of the braided system is very low as compared to the radial expansile force of laser cut. So there's a lot of tools that we have now for us to handle that. That's not more the problem. The problem is, like I said, It is a medical problem. This is the patient, then before and after. You see already part of the contrast doesn't fill into this belly of the aneurysm. And this is 1.5 years. The guy is doing well. He is still on Eliquis. We have reduced it 2.5 twice, and we reduced the Brilinta to 30 milligrams BID. So you adjust that, and something amazing happened. Over time, clot has formed, the aneurysm is nearly gone, patient is stable, and the phenomenal thing that happens with this case is, and that's the videotape shows, now vessels are sprouting from above through the clot, creating channels and supplying the brainstem. And we see that neogenesis. Las Jonias would have gotten, super excited, to say the least. So, so you see these branches, and that is unknown in the brainstem. We always think that the brainstem are end stream, all the perforators from the phylogenetic, from the evolution. But what we are creating is we are forcing through a very progressive remodeling process to give blood supply to areas that otherwise wouldn't get it, by creating a progressive, slowly occlusion and adding the antiplatelet agent. And we have seen that, by the way, in other areas like internal carotid artery, like anterior cerebral artery, posterior cerebral arteries, on and on. So this is something that the body can do. Another patient here showing you technically, again, a super easy procedure, a partially thrombosed basilar aneurysm. I won't go due to time in the technicality, but you see we came from the right radial artery. So you go up, takes like 5-10 minutes. I was in a case with Ricardo recently, he did it. It was very complex aneurysm in the back. I think from groin puncture to finish, he was done probably in 15-20 minutes. 15 minutes later, the patient is awake. Next day, she goes back. I think she was from a different state, I think from New Orleans. And I'm sure if he would have to do craniectomy and go to the midline approach, it would be hour procedures. By the time they're opening the dura, he was already done with the procedure. So again, very simple. You deploy your device. If you need a second one, we avoid a second one. Like I said, too much metal is not good. We place the device, and then if there's not good wall apposition, we check it with the CT scanner, which is inbuilt now in the angiography system, and it's called VASO-CT. And our group here, Matthew is sitting here, our group was very much involved in developing this technology with Philips a while ago. And you see there's a little bit miss wall apposition here and down here, and then we will go with a balloon, and that goes super fast. Can you forward a little bit in the back? Just take and forward the video clip. So you see the deployment of the device. There's a marker down here, and up to that marker, you can resheet it. You can readjust it if you need it. Use a different device, different lengths and size. So there's a lot of flexibility in doing this. Looks like stenting in the heart. Yeah, just grab it and move forward. Yeah, so you see now we go with the balloon. Keep going. Yeah, you're doing great. So we go up, go with the balloon. Yeah. Oh, stop. Yeah, so we inflate with the balloon to further oppose the device. And then can I get out of it? And that's how it looks. So we anchored the distal part, which is a stent, so we don't deal with a very tight mesh in the area of the upper midbrain where the smaller perforators are if we don't need it, and we reconstructed the whole thing. And then if it is well opposed here, we don't need to take down the vertebral artery, but if it's not well opposed, we have to close it. As you see here, we decided to close to avoid an endo leak. So it's a very straightforward construct. You check with the VASO-CT, and you see the same phenomena, that there is an endo leak from the other side, and then you go and you see here the endo leak that's nicely shown here. If you look closer, right here, flow can go behind it, dangerous situation. So you close it with some coils. Of course, you have to make sure they are not small branches that are dangerous. And then this is how it looks. And this is your construct. Again, there's never a complete wall apposition because of the size of the aneurysms and the branches you come necessitating the need for other problem that we have seen it, and these are the last slides, is that people out in the world wait with these patients. So this is a case that came to us super late. So an elderly gentleman in his 70s, grandfather came to me with gait problem, and he then produced these images. He said, well, they did a Fiesta MRI study in 2009, and then they said, I shouldn't get anything done. By that time, he was doing very well. And then 2010, the aneurysm has grown. They say, oh yeah, we will do every year a follow-up. That's not my philosophy. And our colleagues are moving more and more towards that. In fact, there was a patient who was sent to you early stage, she refused. And then she went 5 years later to a different place, but then the aneurysm was huge. They treated it, she was symptomatic. And a few days later, she died. So that's not the outcome we want. But you see here then on 2018, sudden growth from 10 to 18. And I asked, where are the images here? He said, well, they said, well, you are stable for a year or two. Why do another imaging? Dangerous situation, super dangerous situation, and we see that. So we went in, you see most of the aneurysm is clotted. There's some filling here, and then there's this nose there, like mine, which is sticking in the basilar. So we had to, close the vertebral artery, the other side, inflow, reconsider. The guy did it. He's still alive, and this is now his 6th year, and the aneurysm is stable. And you will often see that the aneurysm doesn't disappear completely. And that goes back to what Dr. Samaniego was saying. There are vasa vasorum in these aneurysms. They don't belong. And we don't know how to address this vasa vasorum. We think that these vasa vasorum provide with vascular endothelial growth factors and keep the aneurysm growing. So the aneurysm is not really an aneurysm. It becomes like a tumor, like a meningioma that is supplied through vasculature and is growing. And that's something we need to address. Sometimes it comes to stop. We don't know why. Some people are even putting these patients on chemo agents, I hear, in Europe. Or if you are a very good surgeon, you could skeletonize that, go and remove it and shave this mass out, but it has its own life. And then, sometimes it leads to hydrocephalus, and then you have to stop antiplatelet agents and put in a shunt, which can be sometimes tricky. So the bottom line is, first of all, we have to separate these various diseases. We have here from all the meetings we had with Ricardo and his team, shown that there is a difference between the one group of basilar trunk aneurysm and the other. Completely different entities, different epidemiology, different age group, gender, race, you can name it, ethnicity, you can name it. We have to get a little bit more handle on that. This is not a fatal disease like some of our colleagues think. I think we can offer them a intelligent answer, but a proper classification has to be done. It remains a challenge, not a technical challenge, like I said, a medical challenge. I think we should treat these patients early in the stage before they become symptomatic. I think the high perforated density necessitates the use of anticoagulation. Less is better, so single flow diverters. And I think we have to consider early sacrifice of the contralateral vertebral artery when you have an endo leak. Blood pressure management is very important. I keep these patients for the next few days in the ICU before moving them to step down. Anticoagulation management long-term has to be considered. This, like I said, is a medical problem. And then you taper it down as you do with dual antiplatelet. And role of cortisone, well, we don't know. Some people do that. I do that in an early stage, but I still have not understood that. With that said, I want to thank you and take some questions.
Thank you, Kumar. Any questions for AJ?
Thank you, AJ. So I appreciate your optimism that this is not, a lethal disease, but you are fully aware that there's, people with your wisdom that have been doing this for, as long as you, another group that, consider that like glioblastoma of the brain. I mean, the reality is that we are good at fixing the endoluminal process, but as you pointed out, a lot of time this thing has a life of its own. We're looking at those images and endoluminally, it looks good, but the truth is that the aneurysm a lot of time won't change. And so how do you know that you're changing tremendously the natural history of those patients and people that are, the aneurysm is found at a later stage? I mean, how could you be sure you're changing clearly the natural history?
First of all, thanks, Eric. I think that's an important question you're raising. So about 10 years ago, when we switched from dual therapy to triple, and the patients I treated at Leahy go back now to 7 years. And I have a group of about 10 patients I'm following. Some are living here, in fact, West Palm Beach, and they're all alive. They're in touch with me. I follow them. We do imaging. And it's interesting, to your point, some of the aneurysm have not disappeared. They have come to halt, and the mass is there. Patients are doing well, and geographically, the aneurysm is gone. Is the patient cured? I cannot tell you. Maybe 10 years down the road, suddenly the aneurysm starts growing again, to Edgar's point with vasa vasorum. But at least we have done something in those 10 patients. I do believe at least 1 or 2 out of those 10 should have been dead in 6-7 years. And that hasn't occurred. They have not ruptured. They have to be on antiplatelet lifelong, like maybe with coronary stents and other diseases in the body. I can't tell you this is the answer, but I can tell you that before the 10 years, when I was not using anticoagulation, that within a year or two, that subset of patients would demise. Not related to rupture of the aneurysm as much, because the rupture happens acutely more, or in 30 days, to those perforator occlusion, and we are avoiding the perforator occlusion. So my take home is it's easier handled when the aneurysm is small, shows the early signs of this belly expansion, where the perforators are still manageable. I would intercept then. Now you can say, well, maybe the patient will be fine 10 years from now, and you did an overkill. The problem is, if you take a larger population, they won't be fine. When you bring them 10 years later, they are either dead, have perforator occlusion, or the aneurysm has grown to the point with a mass effect that there's a brainstem compression. So that's why I'm advocating, and it's a good platform here to start collecting data nationwide, and because this is such a small disease entity. And we will be in 2 weeks with the FDA, and Ricardo is leading one of the workshops. I think we should make a move saying that we need, like other countries do. Europeans are doing that great, no? They do this multi-center study of these rare diseases to get a consensus formed on larger database. Right now, each center will do 1 or 2 of those a year. And we have our own spices to make this Caesar salad, whatever. But we have to come to a same way of approaching this disease. You have like 50, 60 patients that we follow up, and let us do a multi-center study. We have been talking about that. I think now is the time. I'm not a nihilist by nature, but I think there's a huge opportunity to help these patients. Huge opportunity. And these are young male. We're talking about between 60 and 70-year-old people.
Thank you. And technically, if you had a flow diverter available that would embrace the shape of the fusiform portion of the aneurysm, would you use such a device, or you don't think you think it's a good thing that it's not opposing fully the wall?
No, I think that those short segment, Eric, very good question. Those short segment aneurysms of the basilar, I just got yesterday somebody, oh, what would you do that? Matthew Priest. I said, I would put a short device. Those are not a challenge. The little thing, you place it, they open up, fine, short device. You don't need even anticoagulation. The problem with fully opposing of braided system is braided system will never fully oppose to the aneurysm. The reason is that these changes in diameter are like impingement points for a braided system, and it needs a certain length before it fully expands, unlike laser cut stent, which can go around like steps. But the braided system doesn't. It keeps, it stays collapsed for a while and then it opens up. So technical challenge, definitely.
I have a question,
Edgar,
Dr.
yeah.
Wacklow. Great talk. First, the triple therapy, I think is a great idea. We have a couple of patients following now that every time we stop the anticoagulation, even 6-12 months after, they start having like little ischemic strokes. So great approach. How do you
Don't stop it, Edgar. Just taper it down. Taper it down.
And this question for Dr. Wacklow, Ricardo, and Eric, when you guys see these patients in the office and they are asymptomatic, how do you decide to treat them? Because even with the triple therapy, you have a 7% chance of morbidity and mortality. What's the triggering point? Because as you show in your database, by the time you treat them when they're symptomatic, might be too late. How do you choose?
So I had recently 2 patients from Florida. Not from Ricardo, because I know Ricardo and I have very similar philosophy there. Came from South Florida, from Miami. Both patients had a fusiform aneurysm, and the doctor there said, don't treat, this is death sentence. Then he went somewhere else in New York, and they said, treat it. Then he went somewhere else, treat it. And then he came, what would you do? I said, treat it. So he said, okay, I want to have it treated. So what I did with him is I showed him our experience. I said, listen, this is my experience from the past where patients who came early in the stage had a good outcome. They had their morbidity of about 14%. So I tell them it's not 1%, it's substantial, 14%. If you wait and it should grow, then we are talking about serious mortality and morbidity. And you have to be upfront with the patient, and you will see that the patients walk with you. They walk with you. You have to be upfront. You have to say this is a medical management, a lifetime medical management. And those 2 patients from Florida agreed to have it treated. But it is a discussion, a dialogue between you and the patient, which has to be taken serious. The problem is many of the referring physicians have already primed the patient and saying, listen, you have a bomb in your head. There's nothing that can be done. Go home and we will do another scan in a year, as if scan would make the aneurysm disappear. I don't know where that philosophy comes from. So you're battling basically the referring physicians more than the patient.
I'm just going to add to that, Edgar. One thing is for sure, you have this discussion with the patient, decide not to treat. Again, you got to follow this patient very closely, because again, I can tell you a lot of patients that you see the aneurysm like you show on the 2008 or 9 picture, and these people are lost in follow-up. They said, oh, there's nothing to be done here, no worry about that. And the guy comes back 5 years later with this aneurysm like 5 times bigger. So if you point 1 to 2 there, 2008 or 2009 in your picture, you see this growth. Another thing I pay a lot of attention is we do vessel wall imaging. We look at clot on the wall. There's super nice Japanese, as good as data can be on this limited series. But if there's clot on the wall, we know these aneurysms are more prone to grow. So that's a hallmark for me. If you see thrombus on the wall, this wall is unstable, and I think I use that to counsel patients as well. But it's a tough discussion, as Eric said. Again, it's a 5-10% M&M on these smaller lesions that you're rolling the dice in somebody that essentially asymptomatic with dizziness. So I think that's a very tricky discussion. And if the decision is to watch, you got to tell this person, don't disappear, don't ignore this, because you see these things growing.
Dr. Wacklow, I just wanted to thank you. I'm over here. Hello.
Oh, hello.
Hello, Dr. Wacklow. Thank you very much. I always like to go back to this triple therapy thing, because as somebody who is helping to manage these patients, it's often something that you get a lot of questions about in our hospital. Do you start or do you typically start with the kind of high dose anticoagulation? So when you're putting them on a heparin drip, you keep them on for about 24 hours. Do you start then with that immediate 5 milligrams of Eliquis BID? And is there a reason why you don't start at like a half dose of the Eliquis? Because we had historically been doing that, is starting at a half dose triple therapy, then with dual antiplatelets. But we recently did have a case that we did have to increase that to a full dose. So wondering if we're kind of missing the mark and we need to start at that high dose anticoagulation from the get-go. There's a reason behind that.
First of all, thank you very much for this very important question. Can I, in a nutshell, walk you through what I do? So I didn't go into the details, but let me quickly do that. So I bring the patient, I don't pre-treat them with anything. The reason is I learned that from our colleague Cameron McDougall, that if you have wire perforation or the aneurysm is unstable and you're just touching it and it bleeds, there's no safety. So I'm moving in other patients the same way. I think that's a great philosophy. So I go up with the system, with the catheter, and before I drop the flow diverter or place the flow diverter, I do a loading dose of eptifibatide, integralin or 2B3. So once I have pushed that whole loading dose, patient is heparinized with the activated clotting time around 250 seconds. So then I deploy the flow diverter and keep the patient overnight on heparin drip and on integralin drip until next day. Next day, I start with Eliquis 5 milligrams BID, max dose from cardiology, and with Brilinta, if the insurance system allows it, Brilinta 60 milligrams. In the old days, we were 90, but we have found out that 90 milligram is an overkill, most of the patients. And you have seen that same. They are in single digit with their PRU values. So then what I do is over the next few days, monitor the blood pressure very tightly and take away the heparin is out, Eliquis is there, and you see whether the patient is tolerating the 5 milligram. And now what I do is I discharge them on Brilinta and Eliquis. And then in a month, I do an imaging, a CT. I don't do angiography. Now these modern CT scanners are very good. And then walk them through the Eliquis reduction program. So after a month, and generally it takes 6 months where you can go down to 2.5 BID. Now, if that doesn't work, you may have to go up to 5 milligrams, and that can be longer and longer over years. This one gentleman only after a year and a half is now on 2.5 milligrams. Brilinta, you can reduce to 30 milligrams. Do I take off the Brilinta and the basilar trunk aneurysm? I never take them completely off. At least leave them on aspirin. I wouldn't take them completely, but thanks.
Appreciate that. That's actually quite helpful. Yep. So no loading at all.
I think they're throwing me off the stage. Thank you. Been talking so much.
Please, on our behalf, take a piece of Ponte Vedra with you.
Thank you.
Our next speaker doesn't need really a presentation, is a frequent flyer to this meeting. We always enjoy his approach to novelty. He's always fully aware of what's happening in the field. So Matt, thank you for being here again this year.
Thank you so much, Eric and Ricardo, for having me. I've actually not missed a meeting. The last 2 years were virtual, but I haven't missed one of these meetings. And I agree completely with AJ. This is one of my favorite meetings because it's a small group, excellent program. So I think this actually segues quite well to the previous talks. I heard a couple of times what Professor Waklu presented, really one of the last frontiers, very complicated disease. And I heard a number of people say, AJ said it, Eric said it, these things are like tumors. And I think understanding more of the molecular underpinnings of the disease could inform completely new treatments. Right now we have a hammer, but maybe this particular disease is not a nail. So this is the work done by Robert King. This was part of his dissertation work in my lab. Eric Gale is a brilliant chemist who works at the Martino Center. And then Alex Bogdanoff, who we've worked with for many years, is also a chemist and molecular probes development person at the University of Massachusetts. These are my disclosures. I'll pause for a second. I think AJ said it well. If you work with everybody, then you're actually not conflicted. So that's the kind of the thing we go for. This particular work, there's absolutely no financial conflict of interest. This is purely academic and was funded by the National Institutes of Health. So this particular molecule is a sensitive. So it's, first of all, it's iron based, but it's not a nanoparticle. It's very, very important. It's not processed like that. It's actually an ion. It's a small molecule, and it's cleared very rapidly in the body. And what's special about it is that in the presence of reactive oxygen species or hydrogen peroxide, which is mediated or expressed during respiratory burst by inflammatory cells, it can sense that and it changes its energy state. I'll show you more about that in a minute. And why do we think it's important? What we've been working on, and this actually goes back to my very first lecture at this meeting, is to do molecular imaging of brain aneurysms to understand their risk of rupture. And so this is the updated version of what we've been working on. And we think that this is relatively old data. This is actually back from that lecture in 2016 here. From Brian Ho's paper, we estimate the cost of treating unruptured brain aneurysms is roughly $6 billion a year, and that's in direct healthcare expenditure. The mortality, we know this from the National Inpatient Survey, is as high as 1.2%. Again, this is for unruptured aneurysms. And morbidity was defined in this work as being discharged to a long-term care facility. That happened in as many as 14% of patients. So our thought was that the risk of treatment may indeed exceed the natural history. So we did some work using a myeloperoxidase. Myeloperoxidase is secreted by neutrophils. It's an inflammatory marker, and we found it in human brain aneurysms, and we found it in other cardiovascular diseases where it does indicate the risk of having an adverse event, a rupture of a coronary plaque or rupture of a brain aneurysm. And what we found is that indeed, patients, we resected the aneurysm tissue, we looked at the levels of myeloperoxidase, and we found that indeed that correlated very well with the FACES score. Not that I'm saying the FACES score is the end-all be-all in predicting risk, but it's what we currently have today. But this is a gadolinium chelate. It's a complex molecule. It's a serotonin-based GAD chelate. And what it does is when it senses myeloperoxidase, so it's a probe that has gadolinium in it, it's 80 Dalton, so it's pretty small. So it moves in and out of the vascular system pretty efficiently. But when it senses myeloperoxidase, it undergoes an enzymatic conformational change, which causes the molecule to oligomerize. And then it gets stuck. So then we can image it because, like I said, it's gadolinium-based. The problem from a regulatory standpoint is very hard now that we know that gadolinium is retained within the human body, and now using a chelated form of it, we're very concerned about the regulatory pathway. So that's why we're looking for other agents that might be have an easier pathway forward. We did validate this in aneurysm models. What you're seeing on the left is a control aneurysm that's given this contrast agent, and there's no enhancement. And on the right, we've artificially inflamed the saccular aneurysm, and I would say you don't really have to be a radiologist to see that enhancement. Of course, it's statistically different. So is there a way of imaging upstream inflammation? Is there a probe that we can residualize, preferably not being a gadolinium chelate? And that's what we've come to with Eric Gill in our collaboration with the Martino Center. Is again, it's a metal ion, it's iron 2. And when it sees this reactive oxygen species, it changes its energy state to an iron 3. And what we've measured in vitro is that creates a 15-fold change in longitudinal relaxivity. Basically, you can see it really well on MRI. Again, I want to emphasize, because I'm using the word iron, everybody here thinks I'm talking about a nanoparticle or a USPIO. It's not. We know that those have toxicity side effects. We know there's a lot of issues with them with anaphylaxis. This is a small molecule. It's secreted or completely eliminated from the body and within 800 minutes. What we needed is a new aneurysm model. We borrowed this work from Europe, where we create our standard rabbit elastase aneurysm model. It's one of the better saccular aneurysm models that we have. But in Europe, what they've done is decellularized vascular grafts, and they showed that creating these vascular grafts that are decellularized, those aneurysms actually rupture. But that was done in a rat model. Here we wanted a saccular aneurysm model. So what we did was in situ decellularization with SDS. It's basically soap. And when we first started this project, my collaborator, Alex Bogdanoff, who I've worked with now for 15 or 17 years, he said this is incompatible with human life. But what we did was we isolated it from the circulation. And indeed, what we found is that when we use this modification, the aneurysms are unstable. So what you see in the blue line is this modification with decellularization of the aneurysm wall. And they continue to grow over our observation period of 8 weeks. And they have a lot of inflammatory markers inside of them. So now we have a model of an unstable aneurysm. And this is a really complicated experiment. In a nutshell, we're going to give this experimental contrast agent, and we're going to image these inflamed aneurysms. We're going to compare that with a standard just gadobutyral injection. And then we're going to do this at 2 different time points, 4 and 12 weeks. And what we found here, what you're seeing on the left is this iron contrast agent. It's very important. You obviously see the enhancement of the aneurysm that's denoted as A. By the way, these inflamed aneurysms are very irregular and quite large in this aneurysm model. What I want to point out, though, is the green arrow. I'll have to use the laser pointer. This green arrow here is the parent artery. And you see there's no enhancement of the parent artery. And here is the left common carotid artery. There's also no enhancement of that. And again, I'm sorry, you guys kind of got screwed. I think we're small enough. Go over here. Whereas if you compare this to the standard gadolinium injection, of course, the aneurysm is enhancing as well, but we also have enhancement of parent artery, so non-specific enhancement, as well as the left common carotid artery. It's kind of superimposed here. And of course, these are all, different when you look at enhancement ratio. What was important, here's the dynamic study. So this first line here on top, the red line on top, this is an enhancement ratio looking at the aneurysm compared to skeletal tissue. And what you see is that we can essentially inject the contrast and we get a 1.5-fold increase in the enhancement. So very specific imaging of the inflammation. Whereas with the gadolinium, it was basically right around 1. And that's because when you're normalizing it, the entire image enhances over time. What we're seeing here is a much better resolution imaging. This is an imaging technique that we developed specific for these contrast probes. I won't bore you with the details, but there's a lot of flow suppression that's going on, as well as fat suppression. And you can see enhancement of the aneurysm when we give this iron imaging agent. So again, the agent is very specific. And I really believe tomorrow you're going to see some really interesting things about super high resolution intravascular imaging. That's truly vessel wall imaging. I think with MRI, we kind of got on the side point. The reality is some of the structures we're measuring, and Vitor is going to present this tomorrow, aneurysm walls that are like 20 microns thick, rupture of the internal elastic lamina, which is happening on the microscale. That's vessel wall imaging. I think with MR, what we really need to focus on is its contrast sensitivity, right? Because if you're using a voxel that's, half a centimeter, so, 5 millimeters or 4 millimeters, or I'm sorry, 0.5 or 0.4 millimeter voxels, we're not really capturing on the spatial standpoint what's occurring, but we can use the contrast. And that's why we're developing these molecular probes that are specific to biological activities inside of the aneurysm. And by the way, what's nice about these models is we can do histopathology. So I don't know if you remembered, 4-week and 12-week enhancement with this iron imaging agent was dramatically different. It was lower at 4 weeks. And what we see is that actually correlates really well with our histology. So what you're seeing here in red is active myeloperoxidase. This is a 4-week specimen. And we're also looking at calprotectin. And here at 12 weeks, we see it's reduced. It correlates very well biologically what's happening in the aneurysm wall from an immunohistochemical standpoint with what our contrast agent is showing. So in conclusion, again, this kind of goes back to the very first talk I gave at this meeting. We think we have now something that finally, Ricardo, I can give you to use in the clinic in a much more reasonable time frame to understand biologically what's happening into aneurysms to guide treatment decisions. But again, now if you understand these molecular underpinnings, we can start exploring other pharmaceutical treatments, especially for this rare class of aneurysms that Dr. Walkley presented. We're very impressed with the 15-fold increase of changing the energy of this metal ion during oxidative burst during vascular inflammation. We have a pulse sequence that took us a long time to develop that's ready to go. I can basically just give the protocol and we can, once this contrast agent's available, we now have the MR imaging protocol to be able to see it really well. And we just applied to the NIH to further develop this probe so that we can do the translational continuum. Tomorrow morning, I'm going to talk about, from an engineering perspective with devices, how we get it from bench to clinic. It's a really streamlined process, a collaboration with the agency, with academic investigators like you do here at Baptist to be able to get these technologies approved. Unfortunately, with these contrast agents, it's a much longer runway, requires bigger investment. But I do think it holds the promise. I don't think we should be discouraged because I really think it holds the promise for us to better understand aneurysm pathophysiology. So I'll leave it at that. Thank you very much. Oh, the last slide is actually important. Can you go one slide forward? I have to do this by law. There's a very last slide. It just says the NIH grants that funded it. So I have to give them credit. Yeah, acknowledgements. There, oh. Thank you. Okay.
Any question for Dr. Gunis? Matthew, first of all, congratulations. Excellent work.
As my mentor, I don't know if you're allowed to ask me questions.
I'm not allowed?
No, of course not. No. Please go ahead.
No, I think this is fascinating. Do you think that your new model that you have created with enhancement could work for drug assessment monitoring? In other words, is it stable enough? Is it reliable and repeatable model that you could say, okay, we are ready to assess some agents so we can address this basilar?
So as somebody who spends their life doing modeling, I can tell you immediately the best model of any disease is the human model of that disease. All of our models are artificial. I'm going to be totally candid with you. What we've created here, and I think Eric made a really good point. Actually, you made the same point too. This is a heterogeneous disease. And what we're finding with OCT is that when you can really image the vessel wall, you can accurately characterize, is this an atherosclerotic aneurysm with neovascularity in the wall? Is it a dissecting aneurysm? Is it a true saccular aneurysm with the rupture of the internal elastic lamina and a little bubble on top? When you image the vessel wall, you really learn a lot of information. We can also image when macrophages phagocytize various elements, you can see that with OCT. So you can see inflammatory infiltration. So I think that's going to inform a lot of, first of all, categorizing the disease. This particular model, all it does is it doesn't stop growing until 12 weeks. So it's just actively remodeling because there's so much inflammation inside of it. There's thrombus along the inner wall and attached to the lumen. It's very active. I think you also made this point in AAA. When you see the explanted AAAs where you see the thrombus accumulation, the vessel wall behind it is completely digested. So this model can maybe help us inform therapies. Does that translate to all human aneurysm cases? Absolutely not.
Matt, phenomenal as usual. So how do you, what name are you calling this agent? So if you're going to tell somebody we're going to use FE, what's your nickname for the agent, for the contrast?
So thank you, Ricardo. AJ in 2006 or 7 took a self-expanding stent and he pulled a clot out of a pig. And it was really the first publication that showed you could use a stent to pull a clot, right? And so we wrote the paper and it never gets cited. And the paper, because I'm an engineer, I was very specific. I said, laser cut nickel titanium extraction of a foreign body. Had I come up with stent retriever, maybe somebody would cite that paper. But anyways, I don't know. And I'll talk to you later. You can give me a good name. Right now, it's horrible. I don't even remember. It's FE, blah, blah. We have to come up with something cool. And also, I think we need to stay away from iron. The second you mention iron, everybody thinks ferriheme. That has a black box.
Yeah, exactly. That's what Edgar and I were talking. Stay away from iron.
Great talk, Matt. And I am aware of that paper. I usually cite it.
Oh, thank you.
The quick question, I know it's very preliminary data, but from your observations, where are the macrophages more active? Are at the neck, or at the dome, or at the where you think the bleb might be forming?
I'll be honest with you, we don't do a ton of macrophage staining in our aneurysms, so I'll have to go back. I think Charles Matuk did a lot of work on that with his specimens. We've been focused on looking at neutrophil activity and myeloperoxidase specifically, and that's very much in the areas deep in the dome, oftentimes near blebs, and particularly where there's thrombus accumulation. Now, this could be thrombus that frankly you don't even see on MRI, like very thin lining, but obviously that traps the neutrophils, and that's really what we've been paying attention to.
And the compound, the myeloperoxidase, is gonna localize the neutrophils, or is gonna localize the thrombus within the wall?
It localizes where the neutrophils are. It's typically in areas of thrombus. Absolutely. Thank you for all the questions.
Last one. Pathway for this to be used in humans. How far are we from that? From at least a clinical trial or something?
Is there anybody here who has about $1 billion? Because then it could be fast. So no, the typical runway for these things is 5 to 10 years. So it's not like medical device, that's 2 to 3 years. It's different.
There's no pathway for early feasibility or anything like that, like we have with devices.
Not to my knowledge. And you guys have organized this great meeting that Dr. Waklu's organized, Arise, where we can meet with the agency and try to find if there's faster ways to get these things through. I think these kinds of things are really necessary to understand aneurysm pathophysiology.
Thank you.
You, Matt. A token of appreciation. The next speaker, it's with great honor that introduce you a great Canadian. In fact, interestingly, you may not be aware of that. So Dr. Wong is in Calgary with a really dynamic group, but Dr. Wong was a role model when I was training, and I don't want to betray his age, but he was one of the first dual trained neurosurgeons. So historically, neurointervention was done by radiologists, mainly in Canada, and there was basically 3 pioneers in Canada, you, Gary Redekup, and Geneviève Milot, that I think were. So I was looking up to those people, saying that it was possible to get dual training. So thanks for joining us today.
Opportunity to present here. I am Canadian, and it's a pleasure to wake up and see the ocean in front of me and in the room, and as opposed to snow, and the immense sociability and the graciousness of the hosts. I really am appreciative of the opportunity to share a project that we've been working on. So in a bit of background, I am a neurosurgeon. I trained with Alex Berenstein and at Yale as an open vascular surgeon, went back to Canada, and I've been in practice for almost 20 years now, well, actually over 20 years. Along the way, I met my a fantastic resident. His name's Alan Mitha, and one of those super talented, kindest people that we each have the pleasure of meeting along the way in our journey and in our lifetime. And I became his mentor. He's in a way my mentor at this point. But along the journey, he became a biomedical engineer during residency. We recruited him back to Calgary, and it's his work here that I'm presenting. And we've honed in on this really, I think, interesting concept that I think will have some application to treating patients. And it's a bioabsorbable flow diverter for brain aneurysms. I'll just move forward here. Oh, I pressed the wrong button here. There we go. So in terms of disclosures, I'm at the University of Calgary. We do a lot of innovative work with ischemic stroke. I'm an associate professor there, and they help fund our lab. We are working towards commercialization of this technology, and the company is called Fluid Biomed. I'm part of management. I'm a shareholder, and we have patents as well. Again, the work is the effort of Alan Mitha, where we have postdocs and master's students and such. And of course, all this work is very preliminary investigational and is not available for clinical use. So I won't belabor the point, but essentially endovascular treatment at this point, you can sort of conceptualize it as basically coiling. Coiling holds about 80% of the market, thereabouts. Flow diverting stents are about the other 20%, and the intrasaccular devices probably at this point represent about 1% or 2% of treatments. And we have the benefit here of having one of the stent pioneers, Dr. Waklu, who knows more about flow diverting stents than I will ever know. But flow diverting stents, I think, do represent this next generation of technology. Faster. If you're Ricardo, you can place a stent in about 15 minutes. If you're in Canada, we take about 3 hours because that's how we roll in socialized medicine. It's probably more cost effective. You're using a single stent as opposed to several coils. And from an occupational safety standard, if it's quicker, there's less radiation to all of the associated staff in the room as well. There are issues with flow diversion, though, and that's borne out by a number of registries at this point tracking the use of flow diverters. You can see them there, but essentially those percentages there of ranging from 21% to 42% represent the proportion of aneurysms at 1 year that are still patent, that are still filling despite a flow diverter. And there's perhaps various reasons for that, likely hemodynamic. But essentially, this means that at 1 year, there's a significant proportion of patients where the aneurysms are essentially still alive. And from a practitioner standpoint, that puts us in an uncomfortable situation because although they are unruptured lesions, the question is that could they rupture in the future? And in reality, with the current technologies, there's no practical alternative and retreatment option except for just to place another flow diverter. You, of course, can't go in and remove the flow diverter. You can't go through the flow diverter to put in any coils. You're left with this kind of situation. And these problems with the existing metastents really leave the physician in a bit of a bind at that point. And from a payer standpoint, from a hospital system standpoint, there isn't perhaps a need for repeated procedures and testing that come at higher costs as a system, and then risk to the patient as well with repeated angiography. So along the way, we conceptualized potentially a part of a solution to this. And we thought about a polymer-based stent. So why polymer? So as in the title of my talk, polymer is, depending on the type of polymer, but polymer for the most part is bioabsorbable or technically bioresorbable. There's other characteristics to polymer as well that are quite intriguing. It's radiolucent, so obviously invisible on X-rays. And the really neat thing about it is that there are very intriguing mechanical properties to the polymer. So I'm going to de-emphasize the bioabsorbability aspect of this polymeric device. And I think by the end of the talk, you'll be intrigued by the possibilities here. The absorption itself, the polymer itself is a non-proprietary product. It's PLLA, and in terms of the absorption profile, it's very well characterized. Essentially, it's through hydrolysis and over time metabolizes to carbon dioxide and water. There are some aspects along the way, such as lactic acid creation that will drop the local pH that could have effect on the immediate vessel wall. But for the most part, it's a generally pretty safe material. It's used elsewhere in the body in various different forms, different devices by different specialties. But there is a certain amount of skepticism around bioabsorbable stents, and that's borne out by the cardiology literature. So about, say, 10 years ago, there was a fair amount of work around bioabsorbable stents for the heart overall, and it culminated in a product from Abbott, and they studied this. It's called the Absorb trial. And this study actually identified that in a small percentage of patients that there was concerns about thrombosis and inflammation around their coronary stents. And that's really put a moat around bioabsorbable work in general, partly because of this perceived higher side effect. And they actually withdrew from the market itself. So here you have a huge multinational company, Abbott, pulling out from bioabsorbable work. Now, there are bioresorbable stents out in the marketplace at this point, about 13 of them. So it continues on. And in fact, Abbott is marketing a bioabsorbable stent in the periphery for the leg. But these studies here, again, really cast a doubt around whether or not bioabsorbables will work. But what we found was that if you actually delve into these types of studies, you'll come to understand that their deficiencies in terms of perhaps the design of the stent. These are very thick stents overall. They're quite bulky, and those have some issues overall. Number one, they found that because of the bulk of the stent, it probably drops the local pH and incites some degree of inflammation in the vessel wall. So if you can get around the bulk of the stent, that might be helpful. The other aspects is even the configuration of the struts. These are very thick strutted devices that probably imbue some degree of hemodynamic stress locally along the wall and some turbulence that probably was not well understood about 10 years ago. And then lastly, in terms of even the stent delivery systems themselves, these are balloon mounted stents. And we have to remember that a coronary stent itself is created for a very different disease than say, aneurysms. Coronary disease is a result of atherosclerosis. So it's a hardened artery that you have to break open with a balloon mounted stent. And because of that, you probably do incite some degree of inflammation and injury to the endothelium, even in trying to deliver this product. That hasn't prevented other people, some brave souls in our specialty, from trying to deploy bioabsorbable stents that are created for the heart into the brain. And here's just one example of investigators utilizing bioabsorbable coronary stents for neurological disease, in this case, ICAD and aneurysms as well. And they found a generally reasonable safety profile. So with that concept in mind, we embarked on this journey probably about almost 10 years ago, working in the laboratory in Alum's lab. And what we developed was a polymer-based product. It's actually not pure polymer, it's a hybrid stent. It's mostly polymer, about say 80 or 90%. And the point of it is that it is a flow diverter. So as you've heard already this morning, flow diverters work by diverting blood flow and encouraging thrombosis of the aneurysmal sac. And the differences with our stent is that over time, most of the polymer will disappear. Again, the absorption profile I'll get into, but it leaves a thin scaffold of metal behind. And we think with this concept that we've overcome a lot of the issues seen with the previous bioabsorbables. We are publishing in the literature over the last, say, 2 years or so, and you'll see some of the examples of the publications here. First published in about 2019. There are a couple other labs working on bioabsorbables as well, but we think we're fairly far along actually in really carefully evaluating this from a scientific process. So this is our stent in an aneurysm model in silicone, and you can see the polymer itself. Again, I alluded to these mechanical properties. It's an extremely flexible and malleable material. That makes sense. Polymer is softer than metal. And in this case, you can see that we're delivering this stent in a silicone model of an ophthalmic artery aneurysm. That's a microwire going up. And there's our delivery microcatheter. And now we have our stent. The stent itself, we can follow along. We stand on the shoulders of giants like AJ, and so we can mimic in a way the stent delivery system used by, say, Surpass or Pipeline. And here we are deploying our stent. You see the 4 marker bands, and then the stent itself, the radio opaque part of the stent, the scaffold. That's the metal part. What you don't see is the polymer itself. And so again, quite tortuous anatomy, and we're able to successfully deploy the stent here. Oops, I'll just go backward. Oh, that's okay. So you can see here, we also do a number of flow diversion tests as well. We're working with Vitor Pereira at the University of Toronto. And this is an intriguing experiment. On the left side there, pre-treatment. That's a silicone model again, and we're just injecting contrast. You can see the aneurysm. This is like a periophthalmic aneurysm model, again, in silicone. And in the middle there, you can see the middle picture is our stent. We call it Resolve. That's the name of it. And AJ's invention there, Surpass. And you can see we have a fair amount of equivalence in terms of flow diversion, maybe even slightly better in just terms of stagnation of contrast inside of the aneurysm, which might suggest that the flow characteristics of this particular stent might lead to enhanced thrombosis of the aneurysm over time. The polymer itself, again, is radiolucent. So we do have a scaffold of metal that helps really enhance the visibility. We have some marker bands on the ends of the stent. And, I think that for myself, I'm sometimes even challenged with the existing flow diverters when we're trying to deploy them at the skull base to really visualize things. So the product itself is pretty visible, at least when we're using it in silicone. In the experimental angio suite as well. But the neat thing about it is that although the metal is visible, the polymer is invisible. And here on the left side, this is an experiment where we deployed a pipeline stent into a glass silicone tube. And then we're injecting contrast. There's actually an aneurysm still there on the left side, but you can't visualize it on follow-up MRA. And so this is an issue where in follow-up, after you deploy a flow diverter in a patient, you'll typically track them over time with either CT angiography or MRA. And I do think that because of the amount of metal with the existing stents such as pipeline or Surpass, that we are missing small aneurysms that are still present, but and that really kind of necessitates a invasive angiogram afterwards. On the right side, that's the Resolve stent, our polymeric stent, where we, in a similar situation, deployed our stent in a glass model and then done an MRA and then perform an MRA scan. It's much more visible, and it just kind of makes sense because we don't have as much metal there. There's less artifact, and so we're able to visualize these residual aneurysms. So potentially better non-invasive follow-up. At least with my patient population, they really dislike having angiography or invasive angiography after their initial treatments and such. So we try to really avoid doing cerebral angiography and prefer relying on CTA MRA instead. So this might be a benefit of having a polymeric device. Besides silicone, we've moved on to animal studies. In fact, we have at this point almost 100 animals with the stent developed over a fairly long time point at this juncture. We've exceeded 3 years now with the stent deployed, and we're looking at a number of characteristics you can see there in terms of safety, absorption, efficacy, and in different types of aneurysm models. We are focused on the elastase model. So this is again, I hope you can see there that this is an angiogram showing the subclavian there, and there's an aneurysm that's been created by Alam and his students, and then we deploy our stent. And I think is there a laser pointer here? Yeah. So I'll just point out over here is the aneurysm. Over here is the treated lesion, and there's again the typical stagnation of contrast that you would see after a typical flow diverter. We can again track this over time, and this is 6 months after treatment with our polymeric stent. The red arrow there demonstrates the aneurysm, and then 6 months later it's gone. We've done histology as well, and This is very interesting in that you can see that there's lucencies along the vessel wall that represents the polymer itself. And we've developed this fairly robust thickened endothelium and fibrosis across the aneurysm neck. So whether that's better than say some of the metal stents or not, it's hard to say, but at least in the healed aneurysms, we're seeing good histological representation here of aneurysm cure. We've also looked at other types of aneurysms besides saccular aneurysms. We reported on development of a fusiform aneurysm model. This may have relevance given AJ's talk about the posterior circulation dissecting aneurysms. Oops. So you can see here that there's an aneurysmal dilatation created with elastase in the carotid of a rabbit, and then we deploy our stent, and it's a nice smooth result about 6 months later. So we are seeing nice vessel remodeling in different types of aneurysm morphologies. We do look at the endothelium, which we think is paramount in terms of determining whether or not there's going to be a angiographic cure. And so if you look at the histology at 1 month, again, here's a section of the vessel wall. The lucencies there are the polymer itself. And you can see it's at 1 month, the stent is actually healed into the vessel wall fairly early on. We've done some scanning electron microscopy as well. So that's a pretty nice picture showing that neointima just sort of draped over the stent itself. And if you can compare it to the pipeline, and what we haven't seen with our stent, at least yet, is a hyperplasia or stenosis associated with the stent. So that's favorable from our standpoint. This is OCT that we performed in our rabbit models. So here, this is pretty interesting, where you can see the bright circle there is the cross section of the rabbit aorta. We've deployed our stent. This is the probe itself, the OCT probe. It's not as refined as something that you'll see, I think, later on today, but this is the standard that, say, cardiologists will utilize, that we have it in our own lab. And in this cross section of the rabbit aorta, we've deployed our stent, and those dots that you see there, this is immediately post-stenting. That represents the cross section of our stent. So just hugging the vessel wall. We don't, at this point, we are not doing balloon angioplasty of our stent. We're just deploying our stent and letting it expand to the vessel wall itself. And at 7 days post-stenting, you can see that already the stent has started to endothelialize into the vessel wall fairly rapidly, a nice, again, thin layer of endothelium. And then over time, in this point, it's 18 months, a year and a half. You have to look very carefully, but the stent itself is already starting to embed itself into the vessel wall almost completely, and it's not jutting out into the parent vessel, as we saw with, say, the cardiology stents. And if you look really carefully over time, and so you can see here that we've gone from immediate, this is again a highly magnified view, that's a vessel wall. Here's a stent just sort of sitting on the surface of the vessel wall. This is endoluminally. Over time, 7 days, 3 months, the stent starts to integrate into the vessel wall. And at 36 months now, 3 years after stenting, there's just a hint of a shadow of some lucency there. We think that represents perhaps the stent, or maybe maybe the stent's even completely dissolved. Again, the characteristics of the polymer are well known, and we know that the PLLA will dissolve over time in about 3 years. So this is following, again, this known absorption profile. Well, what about side branches? That's what people are always worried about. If you deploy a flow diverting stent, even at the initial use of these stents, the metal stents, will these jailed branches, will they be affected? And I think at this point, we're pretty confident that those side branches remain open with metal stents, and similarly with our stent here. So our model here is a rabbit aorta, where we deploy the stent between the small arrows there, and the larger arrows represent the reticulomedullary branches of the rabbit aorta, which are about the same size as perforators in the human brain. And again, doing OCT, we've demonstrated that the stent itself was absorbed into the vessel wall. And in this case, this is 2-year data showing that the opening of the side branch remains patent, and we have not seen a single vessel occlusion yet in any of our animals. So let's switch gears to another really interesting benefit potentially with a polymeric stent, and that's looking at different types of disease as well. So, of course, flow diverters are utilized in aneurysms that are more like sidewall aneurysms, like the posterior communicating artery, ophthalmic. The bifurcation itself is a quite challenging area to treat, at least even from an endovascular standpoint. And you can see all the devices out there to manage these aneurysms from an endovascular standpoint, whether it's stent assisted coiling from Webb, and you can see all these other types of devices that people have created over times, ingenious methods of trying to just fill the sac and leave the parent vessel alone. Time will tell as to whether or not these devices are beneficial over time. I think we're already starting to see, say, with the Webb device, aneurysm recanalization on the order of about 30%, as we go beyond a couple of years, where the device compacts into the aneurysm itself. And we don't have a huge experience with Webb device in our own center. But I still get the bit of anxiety when we're trying to deploy a bulky device into the aneurysm sac itself for fear of rupturing the lesion. And so if you can stay outside of the sac with a device, I think then people are just more comfortable and potentially more reassured that, and the case might even go faster as well. So with that in mind, some people have tried putting flow diverters into bifurcation aneurysms. And so this is just a simple drawing of a flow diverter. You put into the bifurcation itself, you intentionally jail this vessel. There's a certain percentage of blood vessels that will go on to occlude. And that's always a concern, I think, especially if this is a very important vessel like a middle cerebral artery. The goal, I think, of this is to somehow alter flow inside of the aneurysm that'll go on to the thrombose, and this branch will remain open. But at least in some reports here, you can still see that the aneurysm still continues to fill over time. So I don't think it's the right tool for bifurcation aneurysms, at least with the current metal stent technologies. So in our lab, we thought we'd try some experiments, and one of the things that we talked about before was the malleability of the stent itself. So here we have a plastic model of a bifurcation aneurysm, and you can see here that what we can do with our stent is just by loading or putting a bit of pressure on the stent, we can actually shape our stent. We call it like flow shaping or shelving the stent. And you can actually bridge the neck of an aneurysm from a parent vessel approach to get better control of the aneurysm orifice to hopefully create a better flow diversion effect. So if you see here on this image, we have 4 pictures here. This is again that Y model that I pointed out. The pre-stenting is no stent at all. The second one is we put in a pipeline into one of the branches, and the pipeline is deployed just like a cylindrical product. The third and fourth image represent our stent. The third one basically deploying like a cylindrical flow diverter, and the last image basically we're trying to bulge that stent, trying to shape it to cross the aneurysm orifice. And I think you'll see with this image here, again, the first angiogram just showing with no stent at all the expected flow pattern. And then with the second, third, and fourth images, you can see that, especially, if you can see there in that, let me get that going again. Like that. Let me just go backward. Thank you. You can see here that this the third and fourth, we haven't shaped the stent, The last one we have shaped the stent, and it really sort of portends towards better flow diversion if you can just cross that neck better. We're currently in the midst of a GLP animal study to sort of prove out this concept of creating bifurcation aneurysm model and then deploying the stent. So that's a pretty interesting concept. If we can, if it comes to fruition, potentially this is a bifurcation flow diverter. And lastly, here I'll just point out another really interesting characteristic of our polymeric stent, and it's that currently, as we discussed before, when you deploy the metal flow diverter and the aneurysm's persistent, you really can't do anything about it except for maybe put in another flow diverter. With our polymeric stent, the polymer is so malleable that we can actually go trans stent and with a microcatheter. So in this case here, the picture on your left is again a silicone model, and here of a periophthalmic aneurysm. We've deployed a stent, and you can imagine if the patient's on the table doing an angiogram, and if you still see contrast entering into aneurysm, at least in this case, in a certain select, not all aneurysms, it really depends on the angle of attack of the microcatheter, but we can fit a microcatheter through the stent itself. Again, this is a true flow diverter. This is a similar strand device to the existing metal stents, but we're able to pass a microcatheter through it and then put in coils. I think this is a very intriguing concept where, if we're able to do that, it really provides greater reassurance to the physician about curing disease at one go, rather than waiting over time to see if the aneurysm thromboses. And this might be the scenario where here this is the basilar tip model of an aneurysm, and we're already partway deploying our stent here. And so you'll see the stent is partly deployed. Now we're going to shape it. We're going to push that stent into the aneurysm orifice to get a better neck coverage. We'll do a dyna CT or angio CT. We're still unhappy there with that amount of opening there. So now we go through with the same catheter, go up with an SL10, get into the aneurysm, and then place some coils there. So just looking at it holistically overall, at least in the laboratory, we're trying to, we're taking this polymeric concept and think about where can we apply this. And number one, of course, there's fusiform aneurysms, which currently still remain a big challenge. Sidewall aneurysms that the current metal stents address quite well, but it's still imperfect, but we can use ours as a standalone flow diverter. And then the bifurcation aneurysms, which represent about 50% of the market. If our stent is able to address this, then this could be a game-changing technology. It's interesting, flow diversion in a way cannibalizes the coil market. It's one or the other. In our case, you can use them as complementary devices, and in a way use our stent as a neck bridging device if you see fit. And because our stent is essentially a cylindrical flow diverter, you can use it in any aspect of potentially where you'd use a pipeline or surpass. And it might also either be complementary or even potentially replace intrasaccular flow diverters. Again, avoiding that anxiety-provoking entry into the aneurysm fundus overall. So, is this potentially in the future a bifurcation flow diverter that allows trans-stent coiling? I think that would be quite appealing to many practitioners. And just as this might think my last slide here, to summarize the value propositions here, there are many metal stent products out there. Ours at this point, although I think the other labs are working on similar polymeric constructs, I think we're fairly far along in our potential product here. There's a unique versatility, I think, for physicians. We're addressing a broad scope of disease as well. This adjunctive use of coils, I think, is very can be very helpful. We can optimize the non-invasive follow-up testing for patients as well. And we haven't really looked at this at all because we're just so resource constrained, but the bioabsorbable nature and even the hemocompatibility of the polymer itself, can we actually reduce the need for blood thinners or antiplatelets? That's yet to be shown. Thanks very much.
Questions for John? Matt.
It's beautiful work. I've been following it for a number of years. I'm just wondering, it's a hydrolysis mechanism by which it biodegrades. And one of the questions we always had in the high shear environment of the cerebrovasculature, which is almost an order of magnitude higher than coronary system. As it degrades, is there risk of basically mechanical dislodgement of the strands of the polymer, causing distal embolization? Or is it because it happens over such a long period of time, it's already well incorporated into the vessel wall, so that's not a risk?
Yeah, I think it incorporates as you say, it incorporates into vessel wall quite quickly. So we see that. So I think it kind of in a way anchors itself. We haven't seen migration of the stent over time. We haven't seen that. The emboli question can be a concern, obviously, to anyone. And so we have a very interesting experiment going on where we've deployed the stent across the renal arteries in the animal model. And we intentionally keep them alive. At some point when we explant, we'll look at their kidneys and identify any infarcts in the kidney itself. That's our surrogate for potentially stroke, at least on a chronic basis. Thanks. Yeah, that's $1 million question. What's the risks involved with this potential product? Thanks.
John, the same direction. I think you start on that pathway. Just FDA can be a nightmare if you talk about bioabsorbable devices. I love the idea of the kidney. Any other hurdles that you can foresee in bringing this to the United States?
Yeah, there's a million hurdles. I think overall there's a 2 billion hurdles. We look at this as obviously a long-term project here, and that's part of the reason why we have so much animal data here. We almost have like 100 animals over and we're still going beyond 3 years just to try to mitigate any concerns that the FDA would raise along the way. So yeah, jury's out. We'll find out together how easy or difficult it is to move into the clinic. At least in the United States, there are other jurisdictions around the world where perhaps those barriers are less. And I won't give away too much, but I think next month you might be surprised to hear some news. So yeah.
I'm sorry, you may have covered this because I had to step out for a second, but do you know why didn't Abbott have a PGLA bioresorbable stent for the coronaries? And do you know why it got FDA clearance, but it's gone now?
Yeah,
what happened to it?
Yeah, we touched upon that, but essentially, and that's part of that mode of skepticism around bioresorbables and such. But I'll say again, there's 13 bioabsorbable cardiac stents out in the marketplace. Abbott stepped away from it. Concerns about thrombosis or inflammation, those numbers ranged about 2 or 3%. Also, I think that it was an early product with their stent delivery system, which was bulky. And then cardiologists, they really didn't understand so what if it's bioabsorbable? And so I think de-emphasizing the bioabsorbable aspect of it, because there's other real practical, tangible benefits potentially from a mechanical standpoint that make it appealing to our field. Abbott actually went back into the bioabsorbable space with the peripheral stent now that they're studying. So they haven't given up on bioabsorbables, but at least for the heart, it's that really colored a lot of people's thinking about bioabsorbables. Thanks.
Quick question. Me over here.
Yeah.
Great talk. You may have mentioned this, but what is your typical antiplatelet agents? So the picture that you showed like after months and years, I mean, those are very impressive. What is the typical antiplatelet agents for those patients?
Well, our rabbit patients, we still keep them on aspirin and Plavix. We haven't actually been manipulating the antiplatelet regimen, partly because, you know, you do a cerebral angiogram, and some people say there's a 25% risk of emboli that you would see just with an angiogram itself. So we didn't feel that we want to risk going down that road of trying to show that the polymer itself is more or less hemocompatible. We've actually compared our looking at thrombosis risk. It appears to be slightly less than the metal stents overall, and at least comparison with an unnamed fourth generation stent out there, it's about equivalent as well. But we're not going to play in that sandbox for the time being.
Sure. So ideally, how long would you continue the aspirin Plavix? You place this in a patient?
So we typically will just follow then for us in our practice, it's 6 months of Plavix and then aspirin thereafter, and we'll follow that same route. Thanks.
Any other question? Thank you, John.
At last, but not least, we have a distinct honor of having here a Brazilian friend lost in Northlands, aka Toronto. Vitor Mendes Pereira is a dear friend, and he's doing a phenomenal work. Anything that is new, innovative, goes through Toronto. Vitor unfortunately could not be physically body present here, but he's gonna join us any second here to talk about one of the fields that he's leading, that is neurorobotics in neurointervention. And tomorrow he's gonna show another one that is OCT for neurointervention. So thank you, Vitor, as they say in Geneva.
Thank you very much, Ricardo. I miss being there. We finally have good weather here in Toronto, but it's not the reason that I didn't come. I'm just here in my lab beside the room. As you can imagine, when you plan things is when complications happen. So I have to keep my eyes close to the angel. So it's a pleasure for me to be sharing my experience with robotics with you. So, and I'm glad that Ricardo is interested into it and will be joining this group. So these are my conflicts. This is the hospital we work in, the core downtown Toronto. And we have the advantage of having a research facility just beside our hospital that facilitates a lot of the translational work that we will be talking about here. So robotics in surgery is something that has been developed in the last 40 years, I can say. And the abdominal work really took a lot of the ground, and it's actually leading robotics. So although we don't have today evidence that robotic procedures improve outcomes in all areas, but it's known that it can facilitate the performance of the procedures and can bring to certain steps some precision. On the neuro field, on the neuroendovascular robotics side, it started with PCI and PVI that is cleared and approved in US, and the neuro was actually translated in 2008 and 9 and got CE mark approval, and now neuro remote is in development. So yesterday you probably heard that actually Siemens is cutting back on the cardiac program. So they are taking a loss of more than $300 million and actually focusing robotics into neuro, which is great news for us. So we had before to share the difference focus of a company with the other domains. And although cardiac and vascular were leading the way for many years, I think now neuro we are taking over, and I hope to show you why this is the future of robotics, and a company like Siemens is actually redirecting their whole strategy and focusing on us. So we will talk about the core path GRX, which is the robot that can perform neuroendovascular procedures. And this robot is composed by a cockpit, a console that can be controlled, and a robotic arm that is just placed on the bedside. And this is a closer view of the connection between the robot and the patient, which is safe, and it's connected to the catheters that are actually navigated manually to the neck of the patient. So this is a closer view of the robotic arm with the cassette, which is a steerable part that is connected to the robotic arm and have the catheters and devices connected. And this cassette has a distal portion to connect the Y, and is controlled by a joystick and a part of the screen, as you can see here in the corner. The green button here is the joystick that you can control, push, pull, and rotate. And there are two tracks. One is a rotational drive that can perform the rotation of devices. And this is usually for wires, and a shorter one, but it's very strong with a good grip, which is a linear drive. And this is a closer view of the console. So we have here a cockpit that is actually just behind me there. And I prefer to have the console in the cockpit because we actually, I like the comfort and the ergonomy of seeing the screen high definition in front of me. But other configurations are having this console here actually on the control room, which has some advantages and disadvantages. But yeah, I have the privilege of having a simulation space beside my engine rooms. So I have here a simulator from Mantis. This is I have this space, and my room is just on that door. So I prefer to actually be here and with a headset connect to the bedside team. So this has been our journey in robotics. I still remember in 2018 coming to join a board that Ricardo was also part of it, that helped making the translation from the cardiac to the neuro and performing some experiments in pigs. And then we quickly got a robot here, and we started doing experiments to test and to evaluate how we could perform neuro procedures and if there would be any specific preparation. And once we felt confident, we actually prepared a feasibility study that we actually enrolled 6 patients, and then we joined an international multi-center trial. And this is the publication of our first case that was a sidewall basilar aneurysm that we did in a stent-assisted coiling. And we actually realized during the experiments that the robot can improve the precision and execution of procedures. And additional to that, the radiation protection and the ergonomy are also advantages that I like to highlight. This picture here is a paper that I did many years ago on protective head cap and glasses in neuro procedures. And despite the fact that we saw some effects, but I actually was surprised on the amount of radiation that we get and that we sometimes neglect on when we think on the organization of our space and the future of endovascular procedures. And the robot brings precision, meaning not only the performance of specific tasks, but also on the manipulation of the devices. You can see here, I'm using the robot to catheterize this small neck ACOM aneurysm. So the robot, in my opinion, can perform rotational movements that we can't. So if you see this video in a manual case, you will see actually that the wire perform many loops and can navigate. This is the way actually we navigate manually. But with the robot, we can do firmer and shorter rotational movements. This is another case, an ACOM aneurysm, wide neck. We had planned to do stent-assisted coiling, and we had to cross the neck to the A2 on the other side. And this is the manipulation of the wire crossing the aneurysm and catheterizing actually the A2 on the other side. And you will see the robot is performing what I want. So I have to know manually how to perform these tasks, and I need to know what I want. And this is actually what I am actually performing at this moment. So now navigating the catheter. So in this case, we placed a stent. So in the center imaging here, you can see the markers, and we recatheterize the aneurysm through the stent, and we place coils. This is the final result. And these are the things we can do with robots. This generation of robots now. This is another case, a 63-year-old patient. And I had planned to do a stent-assisted coiling for this case. So you have here the images of the procedure, fast forward, and on the upper corner, the movements that I am doing on the console to manipulate the device. So for this procedure, we had navigated a catheter until here, the neck on the ICA, and then connected the microcatheters and the wire to the robotic system. And what you are seeing here is the manipulation of the devices and the movements that I'm doing. I'm using two joysticks. One is to control the wire, the center one, and the green one is to control the microcatheter. And as you see that I switch between the joysticks and the screen, on the screen you have some automated functions for rotation, for millimetric advancement. And there is also some functions like there's one called ADF, active device fixation, which is a function that the robot pin the wire as we advance the microcatheter, which is actually pretty good function to control the navigation of a microcatheter over a wire and preserving the slack on the system. So slack is something very hard to learn, very hard to teach. When the fellow learns slack, then boom, he's ready to perform a more complex procedures. And with the robot, we are able to control the slack in a streamlined way, and in a better way that sometimes we do it manually. So I'm here trying to advance the microcatheter, the stent through the microcatheter, and you saw that at the beginning I had to remove the slack because there was some resistance on the navigation, and this is what actually you were seeing here. And I had chosen a shorter stent than I should. So now I had to deploy the device really into the ACOM. And I'm here now switching from the joysticks to the millimetric controls. And now you will see there the deployment of the stent. So I'm pulling slowly the microcatheter, and now I'm pushing the stent, all seeing and being sitting, controlling the device. So now I'm deploying the stent. This is an Atlas stent. It's not a stent that is difficult to deploy, but it's a stent that's difficult to deploy in an ACOM because you need to control the slack. And here I didn't even need to think. Because the robot and the placement and the workflow helped me control this slack during the procedure. Now I'm getting back into the stent with the microcatheter, and I will now try to catheterize. And this is I'll just fast forward a little bit, because there's something that I want to show you. So now I cross the struts, and now I'm pushing the microcatheter over the wire. And you will see there's a loop building up on the MCA, and as manually, I had to fix the slack, and I had no feeling of that resistance, but I could see that the catheter was building that loop and that there was some resistance on the system. And I repositioned. So again, the robot has no autonomy. It will execute what we actually will want to do manually. And I here catheterizing the aneurysm. That movement actually helped me getting through a different strut, and then remove the ledge of the catheter and facilitated the entrance inside the aneurysm. And now navigation of the coil and the completion of the procedure as we have shown you before. So there's the coiling is an easier step to perform with the robot. The downside is that you have to add few minutes to loading to the robot compared to manual. But the precision that we got on the stent deployment and the control of the overall procedure, I think, in my opinion, justified that added time on the preparation for the robotic procedure. This case was enrolled in the study. That's what we're going to talk about in a few slides. This is the follow-up. And we also do some training of manual conversion. So fortunately, we've never had to do any manual conversion in a procedure. But before every case, this is our technologist, Nicole Cancelleri, actually disconnecting the system from the robot and actually giving it to the manual operator. It takes a few seconds. It's not an added step to the procedure and doesn't compromise the safety of the procedure zone. This is so far our experience. So we have enrolled in different studies, and this is why you see all the differences. And we have published our experience in many levels from the beginning until now. And our latest publication is actually the follow-up 1 year. So our first feasibility cases were cases where we could clearly see a benefit of the robot on the stent deployment and complex cases, but we could do it all robotically, and the outcomes were great, similar to what we expected manually. Complex aneurysms, but they were all completely obliterated at the end of the first year follow-up, as we expected with manual procedures. The other study that we actually participated and enrolled is the CorePath GRX Neuro study, which was a study that planned to enroll 120 patients, and it actually enrolled 117. 94% of these procedures were successfully completed robotically. 7 cases had to be converted to manual. In 2 cases, there was a device or control dysfunction. And in 5 cases, there was a coil or some limitations of the planning of the procedure itself, including the loss of the working length. That is something that we have to be to adapt from the manual procedure when we are performing the robotic procedures, because the catheter, we have to take in account the navigation of and the connections between the microcatheter and the robot, and the devices we have today are too short. So this is why we had to convert 5 procedures. I was not one of the sites, because we had done tons of experiments before, and we had seen that we can't use long catheters or diagnostic or distal access catheters in robotic procedures. But these are small adaptations, but certainly a learning curve that was captured here on the study. There were 3% of primary safety issues. So all those procedures were aneurysms and done in 10 sites with a lot of experience with manual procedures and studies. 2 intraprocedural aneurysm ruptures and 2 strokes. And this is actually what we would expect in a cohort series of stent-assisted coiling of ruptured and ruptured aneurysm. So this is the overall procedural characteristics. Most of them done femoral, but 40% done radial. And half of them had at least one stent placed, and half of them were just coiling, which is also showing that these were not only simple cases. And as you could see, my case is ACOM. We didn't select only easy cases. We're actually trying to enroll as many patients as we could. And on the preparation of the robotic procedure, there's something that we have to consider, which is what we call robotic travel distance. So the CorePath GRX has 20 centimeters of travel distance that we lose some because we have to connect with the RHV. And that travel distance is captured on the screen on that level there. And if you are too proximal or too distal, you may not be able to control the microcatheter or deploy a stent. So this is why something is very important to take that in account when we are setting up and seeing the catheters. So for example, this is a setup for basilar. So in this case, because I had to put the stent in P1, I have chosen to place my distal access catheter in V4 and was very comfortable. And in this case, for this ACOM aneurysm, I actually needed to reach a very distal portion, but I also wanted some pullback. So I actually navigated manually halfway and navigated robotically the procedure. And I changed the position of the link with the robot during the procedure to facilitate that test. So those are acquired tests. It depends on the experience. And if I take my experience, I classify 3 levels of difficulty because of all the access and all these concepts that we have to adapt for the robot. So the most straightforward ones would be the basilar, the second ones, the ICAs, the PCOMs, and with a higher difficulty, I would put the ACOMs and the MCAs because of this lag and also because of the distances that we have to reach forward and backward, particularly to deploy stents. The next frontier, in my opinion, is the use of devices that require more technical skills, like flow diverters and intersaccular. I think this is where we can see the robot enhancing the human and the performance of the devices. This is, for example, a Silk Vista baby being manipulated with the robot, and we can do anything manual that we would do manually with the robot with a pretty high level of reliability and safety as well. And in the future, I see that I foresee that we will be probably like the pilots. So I know that a lot of people are afraid of technology, but I think we should embrace technology as best as we can. We are already in the world with robots and AI. We should be working together, integrating them in a responsible way. And no one want to know what is the name of the pilot of a plane, because you know that they have so many SOPs that a flight is safe and the technology can actually help the execution of the procedure. And in medicine, you would never do a surgery unless it's an emergency without knowing the surgeon, without getting reference, without texting 300 people to ask what is the experience of their colleague. And I think in the future, we can actually take the example of aviation and use technology to improve the safety of our procedures. Our vision is that in this space that I'm here, we want to use more and more simulation in our practice. And this is a case that we did last year in the link. Manually was tried to do a stent-assisted coiling, this ACOM aneurysm. And actually, there was a fenestration that prevented the coils and the catheter to be inside the position of the aneurysm. And we actually brought this case to simulation, and we actually could reproduce the problem that we had clinically. And we actually realized that an intrasaccular device would be better. And these are my kids here in this room. And they did the simulation as well. And actually, they were the ones that could put a coil successfully, and none of us could. So the future will be certainly more digital, and the kids will have will be better than us. But we have decided, based on that experience, that not trying to do another stent-assisted coiling, but rather use the robot to deploy an intrasacral device. So we actually deployed, and this is the vaso CT of the device, and I was actually very comfortable doing this case, and my colleague that did it manually and couldn't was also very impressed, because it was very hard for him to stabilize the microcatheter because of the fenestration, and for me doing it robotically, it didn't influence much. So another example of that is this MCA aneurysm. I was doing it manually with one of my most experienced fellows. We had chosen one size, and was too big, and we had changed, and we had some slack building up, and we were trying to adjust the microcatheter and the distal access catheter, and actually we perforated the aneurysm. So we were doing it manually, and we had that perforation. We had a balloon prepared. We put a balloon, we coiled, everything went well. Patient did well despite the subarachnoid hemorrhage. These are the follow-up images, and we got our lesson from this case: the stability of the distal access catheter and the position with the microcatheter, and plus using a big web in a 27 catheter and not the 33 was also a big lesson. So a few months later, I had this other case, 46-year-old patient, large, and we also had planned to do a web, and I had my fellow that is very experienced and was afraid of actually webs and the big webs because of that other complication we had. And I actually have decided to do that web, but I was going to coach him doing it robotically. And this is actually, I'll just move forward, the navigation of the microcatheter. With the robot, we keep the microcatheter inside the aneurysm, and you have no slack on the system. You don't need to compensate because this is the way the technique actually happened. And here is he deploying. So I was beside, and for me as well, was very comfortable to coaching someone performing a robotic procedure, because I could tell, push the device, pull the microcatheter, and we could do it with the joystick, or he could do it with the screens, and was actually pretty comfortable on my end as well, having to coach a fellow that had seen and had a little bit of post-traumatic stress in a complication, and he could actually understand all the steps, and we can actually with a very technical procedure can perform it with a lot of confidence. And this is the deployment of the device. And this is the follow-up. Very happy. And the next frontier is certainly the remote. I think this is the first generation of robots, and I already see that can improve certain tasks, but the remote will actually be transformative. And we know the problems that we have here in Canada because of our vast geography with access to care to everybody across the country. So here in Canada, we are even worse than you, because we actually have everything concentrated south and a lot of cities north with no access to stroke care at all. So the idea of remote thrombectomy is actually very interesting, and hopefully it will be done soon, now that focus, for example, from Siemens is diverted completely and fully to that. But the current system can perform a thrombectomy. This is again the performance of the thrombectomy by my kids. I'm not selling them to you guys or asking for a job for them. But this is how easy a procedure can be done. This is a model. We did a thrombectomy. But the problem of doing a thrombectomy with the robot is that you need someone to navigate the catheter into the neck. So if you need that, this person can do the thrombectomy, because the most challenging part of the thrombectomy procedure is the access. So cardiology has already demonstrating that remotely we can control whatever robot we have on the other side of the line. So there were 5 procedures done remotely in India a few years ago, and there's already experiences across the US and between here, US, in Canada and Europe, that we can remote control a robotic arm. So then we need a robotic arm that can actually do all the steps of the procedure to prevent someone that has already experienced to be on the other side doing all the steps of the thrombectomy. So we've been studying the connectivity. This is a grant that me and my colleague did, and we are actually using internet cable and testing the reliability of these procedures, and also the imaging, the latency. So one thing is being able to control the robot. That's easy. Any connection can provide that. But the return of the images, that is what is key. And that's what has to be important, because you have to be able to see and get the X-ray images of what you are actually performing through the robot, plus an effective telepresence system that you are comfortable doing a procedure without being in the same room or in the same building. And the local team is actually confident to be a part of your hands, actually delivering the care at that level. So those are challenges. They are not big, but they are things that have been well thought to make this, that probably will be the next transformational thing that we will do in neuroradiology and neurosurgery, that will be treating strokes in a distance. So we've learned so far that the outcomes are similar to manual, which is good, but with benefits of radiation protection, ergonomy, and precision. And the planning is key. So to avoid those issues with catheter and drive, and also the team is very important. There is a new person on the team that is someone that will operate the robot, that will actually load the devices, will have to understand the flushing system. It's someone else that will have to be trained to the procedure, but with the good process, I think this is an advantage rather than a disadvantage to robotic procedures. With that, I thank you for your attention and looking forward to your questions. Thank you very much.
Thank you, Victor. Brilliant as usual, man. Any questions for Professor Pereira? Here, Matt.
Vitor, I did this preclinical study with these new articulating catheters. So one I'm thinking of is Bendit. And when I'm watching you, I'm thinking that the combination of robotics with steerable systems that the robot actually controls could be revolutionary. What do you think?
I fully agree. I fully agree with you. And there are probably different ways to deliver system. If the catheter technology is already there and can be controlled by a robot, it will certainly facilitate the tasks and will even enhance the performance of the procedure and facilitate the navigation piece. That's still something that we may struggle. We may increase the risk of the procedure if we are doing all manually or robotically. That's a great point.
Hey, Vitor, Edgar Samaniego, we just got the Corinthus at University of Iowa. How much of training do you need to do with techs and the staff to set up the robot? Is that a lot of work?
I don't think it's a lot of work, but you need a champion. So we have here a model that we have one champion. So on my side, I am the most interested. So I am the clinician side, but all my other colleagues, they do robotic procedures. But if there is some complex case or some difficulty, you always have someone that has experience, that spend more time on the model, on the experimental setup than others. And on the technology side, I suggest you having a champion that will actually train and be there to continuously training and implementing the the routine of the robotic procedures and the workflow. We've done many experiments before we actually do the first cases, and we saw the value of having all these mistakes done on the experiments before. I think with a good setup and a structured workflow, you could do a couple of days, like setting up, having models that can simulate the issues that, for example, the colleagues on the study had because they had catheters that were too low or too long and could not reach the aneurysms. And those are the points that you need to simulate. And as an operator, you need to be comfortable executing the maneuvers that you are used to do manually with the robot. That I would say, to be comfortable, it will take 5 to 10 cases, but you saw that I graded the levels of complexity, and I think a complex ACOM and MCA you would be comfortably doing with at least good 10 cases in your belt, and your team well-rounded to be loading devices, and you'll be focusing on the control and not in the room as well. So it's important to take that in account. So I think, particularly now, because you are early on, I suggest you spending a lot of time on the experimental setup and picking aneurysms in different locations and trying different setups, different catheters. Make mistakes on the models, because that's where you actually will gain the experience that for us was valuable. So I had no issues with catheter length during any of my procedures, because I had done and I had these issues before on the models. And the colleagues in Europe that, because of COVID, didn't receive a comprehensive training, they had issues that could be avoided then, and that actually, if it would never happen in my practice, but just because of my experimental experience before.
Anybody else, guys? If not, we're gonna let Victor go. Thank you, Victor. We know how hard it is to coordinate this with 2 cat labs running next to you. Thank you again, my friend. We'll see you tomorrow.
No, Gordis, thank you. See you tomorrow. Bye-bye.
So we're gonna go for lunch now, and then we have 45 minutes, and we start sharp at 1:15. Don't miss out next talk is Professor Walkloo talk about photobiomodulation. Come and see what that is about. Thank you, guys. Here we go again. We've got to start on time. If not, Dr. Naval is going to be really mad at us that we're late. You know, he can be very intense. We're gonna restart with a phenomenal talk from AJ Wakalu. Again, I don't know how many hours he has on his day, because you saw his presentation, the case after case after case. And on this meantime, he has 10 years of energy to invest in project A, B, C, D. So he's gonna share one of his projects here that he was kind enough to invite me to be part of. So by extent, we will be part of that movie. Please welcome AJ to talk about the concept of photobiomodulation.
First of all, I would like to thank you folks that have been working with me and to name the most important colleague and friend of mine, Barry Lieber, who is an aerospace and biomechanical engineer. And Matthew is actually, I think, his first student. I think so. Matthew, I'm right? No? You were not his first student? No. Good. But thanks. And I think we both were also engaged in the flow diversion, development of the flow diverter and the surpass. And then I want to thank two folks from UMass that have joined us, is Yumi and Kip. Both of them are cell biologists, and we have another mechanical engineer on the journey. So this is the core group that has been helpful in developing the concept I'm going to talk about. It's known as photobiomodulation, or also some of you know it as low laser light therapy. These are my disclosures, not directly relevant to this presentation. Now, you heard a lot about aneurysm treatment this morning, and I have to say I'm going back smarter because some of the lectures are so phenomenal. To get that for free, it's impressive. This is you have the best speakers. Amazing work on basics as well as on applied sciences. What was good about the aneurysm clipping, and I have the list here, was that it had really a permanent durability. So we knew that when your surgeons clipped an aneurysm, it was gone. The problem was the high procedural risk, and also the invasive nature of the procedure. To do a craniectomy is not everybody's job. So we moved then from there to endovascular treatment. Coil embolization really changed the whole field. It was less invasive, and you place these little wires into the aneurysm. And here Jeff is sitting, who and I go back 20 years almost to UMass time. And they came with another coil, with another product, and it kept on getting better and better as we evolved. The problem, however, that remained was that there is still a high rate of incomplete occlusion or recanalization, like we call reopening of the aneurysm that needs to be treated. And there's a gamut of technologies that are available and have populated the market. As you see, for sidewall aneurysms, we have this group of, we call them endovascular or endoluminal implants that stay in the artery. And then there's a group of implants that go inside the sac of the aneurysm that's called endosaccular implants. And then there's this hybrid in between the vessel and inside the aneurysm. And all of them have their own role for a sidewall, bifurcation aneurysm, sidewall aneurysm. So they address that. But one thing is unique about all the implants, they're passive. We place them in the aneurysm and we hope that the body heals them. Correct? We are not doing anything to them. We are just placing them nicely and hope that the body fixes that. However, the body cannot fix it all the time for many reasons. And this is a drawing. I made an illustration which basically idealizes what we want to achieve. We want to achieve a closure of the aneurysm with the implants clotting and scarring of the aneurysm, and the whole artery to be remodeled before what we call and fatigue or damage or migration or fracture to the implant happens. So there is this war between the body trying to seal something that's subjected to continuous cyclical forces of the blood. And you heard it very nicely from Dr. Malik this morning. With each pulse cycle, there is a damage that's created to the implant. It's on the microscopic level, but it's there. So what happens is before a complete healing is occurring, the materials basically collapse. Now, there is a whole process that occurs in healing, and that's very important to follow. And Matthew was alluding a little bit on that this morning. So there's the process of homeostasis where things come to stagnation. That is followed by inflammation. People think inflammation is bad. Inflammation is needed for a healing process. And there are cell elements like the neutrophils, lymphocytes that take a part in the inflammation. Now, the second part of the inflammation is that since these cell elements are running blood, but they are also in the wall, but they are not always readily available. So what the body does, it recruits from the vessel wall, either through sprouting of neogenesis, new vasculature, capillaries, or through migration, cell elements, they start to differentiate or proliferate and then do their job. That's how it goes. And the final step is remodeling to gain back the tensile forces of the tissue, whether it's the skin tissue, scarring, or in the body. And kids repair faster than adults. We know that from the literature. Now, what happens is during that process of healing, certain things happen, and this is nicely illustrated by the UCLA group. Yuichi Murayama wrote that a while ago, showing that during that healing process, unfortunately, small, mid-sized, and large aneurysms reopen because the material fatigue during the healing process. And Barry and our group worked on the forces that act on this material. And this is what is illustrated by this graph. During the pulse cycle, there is a force. If this is the basilar artery, this is the aneurysm, the cartoon. The forces that act with each pulse cycle on the aneurysm are tremendous. And that's here illustrated. So if the size of the aneurysm neck is the same like the artery, and you have a ratio of 1, the forces with each pulse cycle are about 270 dynes with each heartbeat. That it reflects about, if you take a small dime and hit it, the coil mass or the implant in the aneurysm, and those forces lead to migration of the devices, and we see that in up to 50% of the cases. And this is a case like that. An aneurysm that was ruptured, an MCA aneurysm that was ruptured, you see already early signs of reopening, and still there's some feeling of contrast inside between the network. This is an aneurysm that has completely reopened here. You see the base. Because of these acting cyclic forces, it's a translation of energy from the blood vessel into the aneurysm, leading to the basically damage of the implant itself. Now, there are a lot of publications in this field, and when we summarize, each of the products have their own shortcoming. And this is what is listed here. You have incomplete occlusion, recanalization in coiled aneurysm, up to 50%, flow diverters, you heard this morning, 20 to 30% incomplete occlusion, and 50% with the more recent products that are called endosaccular implantable devices, single device that's placed inside the aneurysm. So the challenge is clear. Passive implantable devices don't do all the job. So when we summarize these findings from the literature, we say there's a delayed incomplete healing, especially in larger aneurysms. That's what the study shows. There's an incomplete and delayed healing in ruptured aneurysms. So about 20,000 aneurysms are ruptured in the United States. And there's a healing dependent on the location. Are we in the basilar, middle cerebral artery, or are we dealing with a small aneurysm somewhere else? Now, there's another very interesting observation, and I think that's very important because we heard aneurysm at 1 year with flow diverter are still 20, 30. I think Dr. Wong said that this morning, and that was a very correct observation. We have the same. And the reason for that seems to be, and the graph illustrates that very nicely. As soon as we reach the retirement age, called today senior, it's a polite way for saying that I'm getting old. I like that, senior. So is the 65 cutoff. I always wondered, why would people go in retirement? That's the reason, because your reparative functions go down the tube. That is something Bismarck knew in 1865 when he initiated the regulation about giving people who are older than 65 retirement package. He knew also that they didn't make it to 65 at that point. Anyway, the funny thing is, however, that there are reasons why the healing response in senior population declines. The reason is we think it has to do that the inflammatory response from cellular element decreases, the motility of the cell elements that are residing, what we call hypoxemic niches within the cell wall. They are there, the precursor cells, stem cells are there, but their numbers decreases. Same thing, the precursor cells in the blood, they are about 10% traveling in the blood. They decrease also because their home is basically the bone marrow. And you know the bone marrow over ages gets sparse on stem cells. So there's a lot of mechanism that drops the healing of aneurysm. And this is with the flow diverter showing you with the age, it drops significantly. We found the same thing with our studies. And the paradox is, as we are moving into this field, more and more senior people are being treated. So there is a paradox. We are seeing less and less efficacy in senior population, and yet we are seeing better and better care of this patient population. And that's illustrated in this largest study on flow diverter prospective study. When you plot the younger population against the senior population, there is almost 20% drop in healing response and incomplete occlusion in the older generation. So that was the introduction, pretty long. So what we thought is, how can we improve the healing? So we are introducing something called photobiomodulation, low laser light therapy, by using certain wavelengths of laser to increase the proliferation and differentiation of the cells in situ. In cancer, you know that it's done ex situ. They harvest your stem cell, prime them outside the body and re-inject. What we did is now we are introducing in situ activation of the cells. And that's what we have seen in our bunny studies. That's a research that's still ongoing. We have done over 80 bunnies in different places. And this is the normal healing mechanism that I just talked about: thrombus formation, inflammation, and then occlusion with remodeling that takes anywhere up to 6 months and sometimes longer. We are bringing with laser energy and light that down to between 3 days and 3 weeks. How do we do that? So this is the model you heard from Dr. Gonis this morning, the model, elastase aneurysm model here, an angiogram of the model. So what we did is we developed a microfiber with a lens, a diffuser, we call it, at the tip of the microfiber. The microfiber is about the size of a hair, 100 microns, and it is in a tube. It is in a tube, and that tube travels through a microcatheter. Now, the laser energy that dissipates at the tip is super hot. You can burn yourself. But the diffuser makes sure that the laser beam doesn't come directly into the aneurysm wall, but it's diffused. That's one thing. The other thing is this cage, which is not detachable. We are working currently on a detachable version. The non-detachable centers the diffuser inside the aneurysm, so you're not in touch with the vessel wall. And then there's a box, a source for laser, outside source, that's non-disposable. So this part is a disposable part. So the energy and the wavelengths of the lasers were tested outside in cell cultures. And so we do single cell cultures here made out of smooth muscle cells, fibroblasts, and endothelial. Then you do a co-culture, and then you throw in also stem cells that are residing in the vessel wall or in the running blood. And that basically makes the platform for where we do be working in the wavelengths as well as the energy dose. And these are some samples on a mesh of a flow diverter. And this is the basic cell. So these are cells that are being shined by this energy. This is how it looks. So you have here endothelial cells, and they are bridging here. This is a nice way of displaying how these cells climb and attach to it. It's like we all would hold to each other with hands and start populating at the same time. Very interesting way. And these are the DNA staining and immune staining on these cellular elements. So we did that then in the rabbits. So after we optimized that, we went back to the rabbits, we combined it with flow diverters, and these are the first results. So what you see is on the, I can't see it, but what you see is on the lower range are these flow diverter placed in the parent vessel. So this is a sample at 3 days that was treated with a flow diverter, but without a laser light. And you see some clot, aneurysm is open. This is a similar rabbit study, another sample showing with laser light therapy, and you see the clot formation here and already early endothelialization at the neck. Now at 10 days, another sample without light, nicely showing you the device. There's some biofluid and some fibrin and cellular elements already seen on the surface of the device, but the aneurysm is still open with some clot. And this is the 10-day sample with laser energy showing a scarring and a mature endothelialization here and some endothelialization in the parent vessel of the implant itself. Now, we wanted to look deeper into that, what this is. So we did anti-gene immune fluorescence staining against alpha smooth muscle cell actin, which is non-specific for myoepithelial cells, but it's responsible for healing. It's one of the building blocks for healing. And then the other antigen was against the platelet endothelial cell adhesion molecule 1, it's CD31. And you see both specimens are subjected to the same immune fluorescence light, but you will recognize on the left side, without the laser therapy, there are barely any cells that light up. And on the right side, within the clot, you see these bands of cellular elements that are positive for actin, smooth muscle cells, actin positive cells. And on the lower side, you will see cells positive for CD31, indicating that we have abundance in the wall, in the parent vessel, as well as in the aneurysm wall, cellular elements that are differentiating or in the early stage of differentiation and proliferation. Another way of displaying that in histology, you see here in the immune staining, of course, lymphocytes, neutrophils, which are a part of inflammation, but you see abundance of fibroblast and myofibroblast. Both of them are cell elements that differentiate to smooth muscle cell and deposit collagen within the aneurysm. And down here, you have some lymphocytes and neutrophils in the group that was not radiated with laser light. After that, we said, maybe this will work with coils, and we were disappointed. So we did the laser light therapy and placed a single coil, hoping that the aneurysm will go away. This is without the light, and you see there's some clot formation here, and that's with light, and we didn't see any major changes. There was clot, aneurysm was open, coil was compacted, what we talked about, due to the forces. However, when you look closer, there was a surprise. There were the bands of cell elements within the clot, again, positive for actin, smooth muscle, alpha smooth muscle actin and CD31, indicating that in fact, the light is not doing anything to the coil compaction as expected, but a transformation of parts of the clot as well as migration of cellular elements from the wall. Very interesting findings. What in summary it tells us that we have to stabilize and create a scaffold across the neck of the aneurysm to provide a matrix and stagnation for the clot to form in the aneurysm. So these new cell elements can grow across this newly defined matrix. These are different ways of depicting the same thing on the left side without light, on the right side with light, indicating the cellular elements here in form of bands within this newly formed clot. Now, is laser light therapy something new? It's not. It's not new. You know it from superficial birthmarks. Here, a child with capillary hemangioma being treated with laser light. Ulcers, some of you may know, dentists have now these little console. They use the red laser light for ulcers, mouth ulcers, but also for cleaning, interesting, at different wavelengths. Then some of you know, I don't know whether you have used it, there's something called fine needle pinning for when you get this skin, the collagen tissue gets slaggy and breaks down. You do this fine needle pinning that creates inflammation and healing. You look younger and better. Now they are doing this fine needle pinning with laser light because there has been evidence that that enhances and promotes the collagen deposition. Now, how does laser work? The laser light works very interesting. It works in the ichor, in the mitochondrium of the ichoric cells, which we are, and does activate the protein synthesis through electron transfer within a reductase A and B. I would compare that in a lay term, like getting a suntan versus a sunburn or nothing. So when I was sitting here having the coffee break or the lunch break, I was getting a suntan. Now, we don't want to get a sunburn, so you put something. Other example that's good is a plant. When you put a seed and the plant comes out, you remember the high school project? The leaves are white, they're albino leaves, and suddenly they become green. Why? There's a molecule within the chlorophyll that's called copper ion. And the copper ion through the light is basically transforming, goes through an electron transfer, and that creates the color chlorophyll, which is the green color. So necessity. It is similar to that, and that's what the basic researchers here have shown in the past. So we think that photobiomodulation in the way we are developing that is very easy to be used. It doesn't require a new skill set. I think that it will accelerate and healing, especially in the senior population. It may also eliminate a long-term need for a long-term antiplatelet treatment. We are working now in the early stages, whether it can be helpful to get the laser therapy through the CSF space to stroke patients, to other disorders that I have listed here to your left. But we are far away from that. That's just an early. And then, of course, there are other areas where light could be regenerative helpful, like for joint disease and colitis ulcer. In summary, I think photobiomodulation in our preclinical study supports the notion of complete and early and expedited healing. We think we are introducing now for the first time using this fiber optic regenerative medicine into implants that are passive. Implants are passive. Now we are in situ activating cellular elements and differentiation, proliferating them to create a expedited healing, wound healing internally, basically. But we need to develop a scaffold that can be detachable for these bifurcation aneurysms. And I think it will be also a very important tool for things we saw this morning with these giant aneurysms that don't heal, whether we can stop their growth and maybe even eliminate. I want to thank, Ricardo mentioned it briefly, I want to thank Dr. Hanel for leading the KOL. He brought all these KOL leaders on board. I got him excited, which I'm happy about. And he got these other folks excited as well. So we have a great crew of KOLs that are supporting us in this journey, and we hope to report maybe next year the first in man. Thank you so much. Any question?
Go ahead, John.
Yeah, a fantastic talk, AJ. It seems to me that there has to be some element of hemodynamic disruption in your experiments. You used a flow diverter. So I'm curious, do you imagine that this therapy could be used in the absence of any physical construct and still affect a positive results here? And that's one question. And then the other question is more from say an open surgical application. Here you're going after, it seems very challenging to be working with in a minute space endovascularly, but have you thought about, or your commercial colleagues thought about an open surgical application for promoting healing with this type of laser therapy? Thanks.
John, first of all, I enjoyed your presentation this morning a lot. I'm a believer in that. I want to thank you for the presentation. To your interesting question, there are three paths we are taking in this. One path is as an adjunct therapy with flow diverters. So we place the flow diverter after placing a microcatheter inside the aneurysm. So what we do is we reduce the blood flow exchange between parent vessel and the aneurysm, and we shine the light then. The reason being is we think we have to have flow arrest in this bunny aneurysm, in these larger aneurysms. For two reasons. For one reason, to get rid of some blood products, because through the microcatheter, we have to flush saline solution to cool down the tip of the laser, but also create some clarity in front of the laser. So, and that volume that goes through the catheter is anywhere from 5-10 cc's per minute up to 20 cc's, depending on the size of the aneurysm. So that's adjunct therapy. Then we have a path, is the detachable system that will be deployed at the neck of aneurysm for bifurcation with the laser light going through the center. So what we do is we reduce against flow, shine the light, wash the aneurysm, shine the light, and then deploy the detachable system. They are all needed because when we did the experiments with coil alone, you see that the coil compaction led to reopening of the aneurysm. Of course, the clot transformation were different, but that's not good enough. So we need something stable at the neck. The third thing is small blister type aneurysm or aneurysm we are treating aggressively 1 millimeter, 2 millimeter, and some people leave it alone. We have a product, not implantable, where the light goes sideways from a balloon. So you inflate the balloon, there's a clarity, and some people have thought that may work. We don't know that yet, whether these small aneurysms will disappear when you just activate them early stage enough and enhance the reparative function. Needs to be checked. So these are the three. So for example, your device, for example, you showed us the 36 months follow-up. I see, for example, a great application for that because you could enhance your evolutionary the dissolution of the material faster if you get faster endothelialization, for example. So there I see a complement in that place. So definitely.
I have another question if I could ask. Mechanistically, you talked about stem cell activation, and Alam's been working in his lab on mesenchymal stem cells in a different capacity. But have you also looked at endothelial progenitor cells? Does this actually have an effect on those circulating cells, and could that be part of the equation here?
Yes, so you saw the platelet adhesion molecule 1, that antigen, it upregulates those cells. We see also that there is a enhancement of precursor cells. There is an enhancement of endothelial cells, but the most pronounced impact was on smooth muscle cells, some fibroblasts, but in the co-culture, we didn't, put specifically endothelial cells and mixed it. We have not done that. We are more focusing on putting smooth stem cells in mix with existing blood products like fibroblasts, myofibroblasts, and red cells and platelets. But definitely something to. Thanks. Any other questions?
This is more of a comment. The one picture you showed was 3 days post flow diverter with photomodulation. What I observed, I've been putting flow diverters in that model for a very long time. Usually the neointimal formation is on the luminal side. And what you saw in that case was it was actually on the aneurysm side. And the wall was completely mature. It was almost like a perfect smooth muscle cell layer wall, and it's on the other side. It's amazing.
No, you have both sides. So you have in the vessel wall, adjacent to the aneurysm, as you correct, and also on the aneurysm side. So that was our question. Why is it that we see also an enhancement in the parent vessel? And we think the reaction, the triggering mechanism or the signal process that happens within the aneurysm wall, and of course, within a certain limit, you get the energy, that there is a signaling process that goes within the system to repair it. So in other words, when we have a tear or a damage in a vessel in one location, it must signalize to a bundle of cells in the environment to respond. And I think that's where, when I spoke to Barry also, I see the value when you put this carotid stenting to go and shine it light, or you do venous stenting, or you do coronary stenting. We have a potential to expedite, even in areas where there are no aneurysm, expedited wound healing to decrease the length of dual antiplatelet or antiplatelet therapy.
And
but
this-
it's right. What you're saying is absolutely right.
And this wavelength goes through blood. You don't need to clear the blood.
You need to have some blood products, but you need to clear the blood.
You do.
So therefore, I think for the carotid, we were thinking like you do for OCT, you wash them out, but we have to do a balloon system that takes the laser light. Yes, please.
I'm just curious, in the case you mentioned with the single coil where the treatment basically kind of created some sclerosis around the coil but didn't fully occlude it, did you look at all about like repeating a laser treatment to create more sclerosis, like with the repeat treatments?
With a laser light?
Yeah.
Oh, we are not doing repeat treatment. The reason being is because when we talk our KOLs, they say nobody would go back. So we are limiting our therapy to a single treatment. So nobody wants to go back to them. So we have to stay away. But to Dr. Wong's point, can we bring the laser light open surgery? There you could potentially put one of those transparent bone elements they do now for pediatrics where they can do ultrasound through it. You could put that. In fact, I suggested when Bruce Willis had this dementia, we believe that light therapy may be helpful to slow down the dementia, to talk to his family. And Ricardo and I talked about that. Our group was a little bit shy. If it doesn't work in Bruce Willis, suddenly they will sue us and then we are dead, basically. So it's better to remain from prominent people unless you're not ready for that kind of a work. So.
I actually wanted to make a comment. I don't know about that last comment. So you're beating yourself up with the coil that it didn't heal that aneurysm. Histologically, that aneurysm was healed. So you saw the fibromuscular scar extending from the rupture of the internal elastic lamina all the way around. So angiographically, it's not cured, but that aneurysm was cured.
Matthew, I absolutely agree with you. The problem is when we say 50% stable occlusion with endosaccular devices, this would be like that. And unfortunately, I don't want to live with this. I want really a clean cut, unfortunately. That's the reason, but other than that, you're right. It was. What surprised us that we saw that difference with coil alone. Yeah.
Thank you, sir.
Thanks again.
Appreciate it.
Thanks.
I think we have, I think Ado is ready for his second talk. Can we connect with Professor Malik? So Ado, thank you again, my friend. Ado, next talk is an update on his brilliant work on endovascular management of normal pressure hydrocephalus. We're excited that we embark on that with you as well, Ado.
Thank you very much. It's an honor again to join, and I'll try to make it quick. Can you see my slides?
Not yet.
Okay.
When while Ado is loading there. So yesterday we had 760 people on Neurosurgical TV. Today at 9 a.m. we had 270. So thank you, John, for providing this phenomenal educational tool for people that cannot be here face to face. Go ahead, Adam.
My pleasure.
Okay. Thank you very much, and thank you, John. So I wanted to give you an update on our treatment of hydrocephalus using an endovascular tool, the Ceravasc eShunt. These are my disclosures. So hydrocephalus is not typically disease states that we treat, using endovascular means. Typically, it is treated with either a temporary ventricular drain or a VP shunt. This is a typical picture of hydrocephalus with the dilated ventricles, the transependymal flow, the dilated temporal horns, and of course it can decrease consciousness and it could even lead to coma. We are dealing here with treatment of communicating hydrocephalus, not obstructive hydrocephalus in the current iteration, and communicating hydrocephalus comprises usually over 80% of cases. So currently, the treatment involves surgical VP shunt, which has been a standard of care for many, many years, and really has not had much innovation and is ripe, if you will, for disruption A VP shunt involves making 3 incisions, one at the skull, one behind the ear for the valve typically, and a tubing that typically ends in the peritoneum. And unfortunately, it can be associated with multiple complications such as hemorrhage from the catheter, overdrainage because of the phenomenon of siphoning. When the patient stands up, the entire height of the column of fluid can sometimes suck excess fluid, and there are different mitigating devices, anti-siphon device that can be added to the valve, but that continues to be a problem. Catheter misplacement, despite our best attempts at using stereotactic guidance, many of these are placed freehand and they can end up in unintended locations. The presence of slit ventricles, such as in the case of idiopathic intracranial hypertension, where if you have a need for revision, it's really difficult to hit that very small spot of CSF. And then you may actually get a phenomenon where the brain collapses over the ventricular catheter and makes the shunt malfunction. And of course, with our society and the current increase in BMI, peritoneal catheter malfunctions remain a challenge. In fact, these are just 3 recent studies showing that the rate of malfunction, for a VP shunt is in the area greater than 20 to 40%. And so, the genesis of the e-shunt really came about from bringing some of the innovation that has gone into treatment of aneurysms and other vascular lesions, where the stents, the coils have really replaced the clipping, where into the area of treatment with an endovascular technique. And the concept really, began with a discussion between my colleague Carl Hellman and me over 14 years ago now. And the idea really centered on trying to duplicate the arachnoid granulation, which is a regular mechanism right now where the actual CSF is absorbed from the cistern back into the venous system. Our initial designs, at a patent were somewhat primitive. We thought maybe we could put a device that could somehow, maybe a corkscrew or some way get into the cistern. We could stabilize it with a balloon and maybe put it near the, either transverse or sigmoid sinus, and then get a connection that way. Unfortunately, as you know, many times the transverse sinus is difficult to compromise, and if there's any thrombosis or injury, then it can lead to massive clinical problems. And so through the pattern of the innovation loop, getting involved with the tech transfer office and connecting with some excellent business, experienced entrepreneurs, we were able to found Ceravask and begin the innovation and improvement process and development. And so I think the point of the device and this approach really centers on accessing and connecting the inferior petrosal sinus to the adjacent cistern. And why the inferior petrosal sinus? Because unlike the sigmoid and transverse sinuses, it is a channel that is actually well situated in bone, but is one that we routinely go through. And if it should be affected, it's an accessory and redundant pathway. And even with coiling of the inferior petrosal sinus, we rarely have any complications. And so this was a good target. And so the device, as you've seen before, involves a small tube that actually has a Malicot that resides in the cistern and prevents the device from pull through, and has a slit valve which prevents reflow of blood when the patient coughs or when there is a sudden increase in spike of the venous blood. This is the size of the device and the flow going through the valve. And again, the inferior petrosal sinus is very well known and familiar to neurointerventionalists, regardless of their background. It's one of the procedures that is learned early on as part of the transvenous approach for petrosal sinus sampling. And the concept, again, will be to bridge the cistern and the vein across this dura with a device. The current device involves an anchor system that is deployed with a flat rail that then enables the delivery of the delivery catheter, which has the device within this needle, which is unsheathed in position. And then because of the orientation and angulation of the inferior petrosal sinus, it's a natural spot where it's possible to traverse the dura into the CP angle cistern. And then this then enables us, after this needle guard is withdrawn, to deliver the E-shunt, which is kind of ensconced with this encapsulating shroud and enables the control until final release. This procedure requires careful imaging ahead of time, but it also comes at a time where there's a nice convergence of cone beam CT imaging, MR fusion, and the imaging technology, as well as the guidance, have really come to a point where we can offer this in pretty much any angiography suite. Most of the time, the access site is really at the midline of the jugular tubercle that you see here. And so we are able to segment and make sure there are no nearby arterial structures to simulate ahead of time for the treatment. So this is testing we perform in cadavers. You can see the micro catheter injection cone beam CT showing the cavernous sinus, inferior petrosal sinus, and then the desired access point. Leveraging 3D word mapping, we can select that point. You see the orange point and send it over to the fluorography, and then we can know exactly where we want to exit. And you can see this as the needle as it's entering through. This is the exit site. And then you can see the flat trail going. This flat trail also limits the depth of penetration. So if there's an inadvertent or ham-handed operator, it will prevent the depth of inadvertent penetration. This is just quickly the planning for the workflow pipeline. You can actually select the exit site. You transfer that for 3D road mapping, so you know where you're going to exit. It's the deployment of the anchor, advancement of the delivery catheter, unsheathing of the needle. Pull back and you can see the vector is going to align, and that with advancement that enables you to then traverse the dura. Deploy the anchor. This is the Malacot. And then when you pull back, you'll see this will come and tug, and then you can go back and retrieve your anchor and pull out. And this is the device that it looks from the inside of the skull, and it's actually traversing through and then going through the inferior petrosal sinus to the internal jugular vein. This is what it looks like on the other side. We initially started with our study with Dr. Lilik, first in human study in Argentina. This was the first in human patient. I think you've already seen this last year. A patient with subarachnoid hemorrhage, ruptured middle cerebral artery, which was coiled. And then we thought in this patient population, we would be able to offer the E-shunt for patients that have failed a clamp test. As you know, when patients have hydrocephalus, they have a ventricular drain, and then after a few days or a couple of weeks, it's possible to start clamping that drain and to see if the patient tolerates that and maintains the pressure less than 20 centimeters of water, then the drain is removed. In this case, the patient cannot tolerate it, and these patients require a VP shunt placement. In this particular case, they were offered an E-shunt procedure, and the clamp, the EVD would remain clamped, so we could actually measure the pressure after the E-shunt was placed. As you know, until this first in human case, we had no idea that this concept would work or would be feasible. This is that first patient with the pre-treatment segmentation, and this is Dr. Lilik going up, and then you can see that the needle has been unsheathed, and then you can see the advancement. And I actually performed a venogram during the procedure showing no leakage into the subarachnoid space, and then advancement of the E-shunt into position. And then after that, retrieval of the anchor. This was the patient's ICP. Right after placement of the E-shunt, you can see it went down. This was the overnight pressure the next day. And the primary endpoint was the ability to maintain pressure less than 20 centimeters at 36 hours, and then ability to remove the ventricular drain. Remember, the drain was kept clamped after insertion of the E-shunt. This is what it looks like in position with a CAT scan, and you can actually follow on cone beam CT down to the IJ. This is the Malacot outside of the IPS. And this was the patient's ICP. You can see it dropped. And then with the patient being moved or kind of exercised from side to side, you can see fluctuation in the ICP, but it actually remained below 20 and enabled removal of the EVD. Since then, 6 more additional cases were performed, and they all showed the same pattern of maintaining the ICP below 20 centimeters of water. All patients met primary endpoint, including an 8th case that was performed 2 days ago. This is the first 7 patients. You can see the analysis of the ICP. It actually drops down to around 9 or so centimeters of water. And then you can see on the statistical analysis, a highly significant reduction within 1 hour that remains low. What about other conditions? This is an actual patient that I'm going to show you after this image. One of the disease entities we're dealing with is idiopathic intracranial hypertension and transverse sinus stenosis, which can be elegantly treated with venous stenting. But one of the advantages of the e-shunt is the drainage is actually down in the jugular bulb area and where the pressure is low. Most of these cases have the stenosis at the transverse sigmoid junction, and so the pressure will be elevated here and low here. And so we could offer this as an option. This next patient was a patient of Dr. Lilik, who had a long-standing history of IIH. As you can see, the swelling from the optic nerve and the actual bilateral transverse sinus stenosis. This is the procedure. You can see the IPS, multiplanar reconstruction. And this is the intraprocedural imaging showing the IPS in orange hue here and the needle across. And then this is the tip of the Malacot as it's being deployed. And this is the patient at 30-day follow-up. You can already see the swelling around the optic nerve has subsided. And this is actually a 30-day injection of gadolinium. You can see that's actually coming down the e-shunt itself and draining into the ipsilateral jugular vein, but not on the contralateral one, showing patency at least for 30 days and beyond in other cases. So the title of the talk is Normal Pressure Hydrocephalus, and this is one that we're very excited about because it affects so many patients, and many of them are in nursing homes with dementia, and it can masquerade as Alzheimer's or Parkinson's. And of course, the social cost is tremendous, and it has a triad of impaired gait, cognitive dysfunction, and urinary incontinence. This is a nice case study that was published in the New England Journal of Medicine by a group at Mass General that shows, a difficulty diagnosing a patient and actually the response to a conventional VP shunt. And this is the lady that they have in that case report. You can see beforehand, she's having really difficult time walking. You can imagine the quality of life, the effect on the family that this would have. And of course, one of the reasons that the neurosurgeons don't like to perform the VP shunt, which she underwent here, and now this is pretty much soon after the procedure, you can see she's already walking better. And then this is at long-term follow-up. You can see it literally a transformed person, able to confidently walk, take care of her affairs, and be less of a burden for a family and hopefully resume a higher quality of life. So we actually started with a pilot study in Argentina with Dr. Lilik's group, who have been amazingly gracious and wonderful to work with excellent clinical experience and imaging. And the inclusion criteria involved an improvement in the tug test, which is a timed up and go test of 20% after a lumbar tap. And those patients would then be included in the study, provided they had the anatomical appropriate imaging. This is the first patient. You can see that they have a typical hydrocephalus. The inferior petrosal sinus was judged to be adequate. There's sufficient cisternal depth. And this is the actual procedure. You can see this is the target implantation site. This is the catheter tip with the flat trail and the Malicot. This is the e-shunt after insertion, and you can actually see its course into the IPS and down into the jugular vein. This is a 30-day follow-up. Again, similar technique as before, showing the ipsilateral jugular venous flow, and you can actually track the CSF through the actual shunt tubing. And so at 90-day follow-up, there was improvement in both the gait, the urinary incontinence, and the cognitive function. This is the patient before on the left, doing the timed up and go test, and the same patient on the right at 90 days. And you can see that the ability to, the gait has been significantly improved, and again, without surgery, using an endovascular technique. This was the assessment from that very first patient. And since then, we've had a number of patients, both in Argentina, but also started a pilot study in the United States, where this was Dr. Matuk's first case at Yale. We've also had one case at Buffalo with Dr. Siddiqui and Ila Levy. And this is a summary of the results so far. We can see that most patients at 90 days and at 180 days have had significant improvement of their gait, number of them cognition, and their incontinence. Some patients have not improved, and some patients may have shown some slight deterioration. But when we look at the entire population, and of course we're enrolling and we're gathering additional data, but this is the preliminary analysis. You can see that the timed up and go test showed what 30-day is significant improvement compared to baseline of about 35%, which was highly statistically significant and remains so at 180 days. And this is just with 4 follow-ups at this point. And when we look at the composite score of the timed up and go, the bladder symptoms, as well as the MoCA, the Montreal Cognitive Testing, using 100% as baseline, you can see that we have a very significant improvement that remains sustained. And so where are we so far? We have 4 studies enrolling. We have had 25 e-shunts successfully implanted for 3 distinct etiology, 8 subarachnoid hemorrhage. We've had 16 patients with normal pressure hydrocephalus. That's case report for the idiopathic intracranial hypertension. We have had no instances of procedural or delayed hemorrhage. And we are fortunate to be partnering with excellent neurointerventional neurosurgeon, including Dr. Hanel, which hopefully will be enrolling patients soon. And of course, we have testimonials, which we are always so gratified to hear about, where patients feel that they're improving. And it's very exciting because this is an opportunity to offer a less invasive approach to a growing population that needs it. And we hope that our long-term follow-up will continue to be encouraging so that we can bring this forward. So in conclusion, we have had important milestones, including the fact that percutaneous endovascular transluminal access to the central nervous system is feasible, safe, and reproducible. That means we can actually, through the skin, access all the way into the central nervous system, into the cistern, without having to drill a hole in the bone. I think this is a big win for the endovascular community, and hopefully this will be a path for other treatments in the brain. The concept of transdural venous to cisternal puncture can be safely performed when we have proper imaging and planning. The concept of cisternal to IJ e-shunt, basically providing that connection, mimicking the arachnoid granulation, results in rapid ICP decrease that's consistent, and also patency at 30 days and beyond, as we can assess with the cisternography. And these early results show that the e-shunt approach can provide a minimally invasive solution for many etiologies of communicating hydrocephalus, including subarachnoid hemorrhage, normal pressure hydrocephalus, and idiopathic intracranial hypertension. As far as neurointerventional neurosurgery, Dr. Walker was mentioning, the challenge with placing a ventricular peritoneal shunt for patients that develop hydrocephalus and have to be on dual antiplatelets for treatment with a stent or with a flow diverter. We hope that e-shunt may be one solution to this vexing problem. And the ability to access the central nervous system percutaneously, we believe will offer endovascular interventionalists many opportunities in the future for deploying various kinds of therapies. You've actually just seen Dr. Waklu's superb talk on photomodulation. This is actually one possible access to the brain. So I want to thank you very much. And it's really been very exciting attending the symposium. And I'm sorry I couldn't be there in person, but we'll make sure to be there next time. Thank you.
Thank you, Adam. Any questions, guys? Here, Matt. Matt has a lot of questions.
Adil, as you know, I'm a huge fan. I think this is an absolute game changer in the field. My question is, based on your preliminary experience, what are the true anatomical failures? In other words, based on your pre-procedure imaging and planning, that particular patient, what percentage of patients are not appropriate for an e-shunt device?
Sure. As you know, Matt, right now, our goal is to absolutely maximize safety with this first generation device. And so we are setting thresholds for depth of the cistern and other proximity of arterial structures that are very conservative. And we don't have currently a trocar mechanism, so it's a needle that's traversing. And so I would say currently we are able to treat about 70% just purely on imaging, criteria, 70 to 80% based on those criteria. And I think that when we learn more and we have a better handle on, the risk of overall of this procedure, which so far, as you can see, has been, extremely favorable, then it potentially may be expanded. The other issue has to do with the device design. The first generation has certain features and size, and so future iterations will enable us to minimize the size and then potentially offer it for the pediatric population. But at this current point, I would say 70 to 80%.
John first, and then AJ.
Thanks very much, Val. It's John Wong from Calgary. Fantastic work. Just wondering, is there a certain antiplatelet regimen you need to use to maintain patency of the device? And second of all, long-term durability, do you imagine that it's secondary to a pressure gradient from CSF towards the vein? And is there any incidence of reverse flow from the vein towards the CSF? Thank you.
Excellent question. Thank you very much. And so for the first one, none of these patients are on antiplatelet therapy as a requirement. We don't require antiplatelets. The procedure itself is performed with conventional anticoagulation like you would do for any transvenous procedure. In about half of the cases, that was reversed with protamine before the needle was used to traverse. And the other half, the heparin was not reversed at the time of access of the dura. So you have to think they were fully heparinized and were able to access safely. The other question that you had has to do with the pressure gradient. So we think, one of the limiting factors, if I just bring you back to early on, the initial thought was, the device is so small and so thin, isn't it going to clot? It turns out that small lumen also means that the velocity of the flow at any particular flow volume rate is very high. So unlike the shunt tubing where you have a long shunt tubing that has stasis, the actual velocity of the flow is very fast. And so, We have had up to 1 year follow-up without evidence of occlusion. And we have had 30 and 60 and 90 days cysternography showing persistent patency. And we have not had any immediate post-procedural or delayed hemorrhage from passage of blood in retrograde fashion. Remember, it is a slit valve here, and that slit valve is able to resist 45 millimeters of pressure against flow. So even if you put 45 millimeter pressure of gradient, it will not actually flow back. So I hope that that answers. Does that answer the questions, Dr. Wong?
Yeah, thank you. Fantastic.
Adel, yes, Ajay, fantastic work. Amazing, and I'm impressed. Quick question. You mentioned in your presentation that imaging, including segmentation, using flat panel, angiography, MRI are important. As a operating physician and inventor, what would you like the imaging companies like Siemens, Philips, Canon, who else is out there, to happen to enable this technology? I'm sure that there are things you would like to see expedited. What would you suggest to those companies to do?
So
I'm not
thank you very much, Ajay. We've actually had initial conversation with Philips. Unfortunately, didn't go very far for just random, contractual issues. So the reason we use segmentation is kind of like the highest end of, kind of this was based on my experience with, segmentation for doing computational fluid dynamics and so on. But the truth is, a CTA with a CTV, and we get these as part of our stroke protocol currently. You just do a CTA, and then you actually acquire in the late venous phase. Basically, it would show you the arterial structures and the venous phase. I'm not sure you would need necessarily segmentation, but I think, in the pre-procedural area, I think it certainly would help if there was an automated segmentation protocol. And currently there are many companies, that do augmented reality and kind of a surgical visualization that could help in this realm. But you could see that perhaps as part of the CTA, CTV acquisition, you would have the kind of an AI type segmentation protocol that would just do, growing snakes or any type of different algorithms that would simply segment the IPS as well as the arteries, whether in true segmentation or just virtual rendering with removal of the brain, pretty much like you do automatic bone removal on the current CTA. So I think it probably would be of that nature. The current angiography suite offers, because of 3D road mapping, offers the ability to perform this procedure currently. And in fact, it can be performed without even 3D road mapping. Now that we know what it takes and where we are, 3D road mapping is useful, but it's actually not critical. And the reason is, as you can see, when we are in the right spot, the needle makes a slight change in attitude, where you can see that now it changes and the vector becomes straight. And so I think, I don't think it's going to require a next generation imaging improvement, but certainly additional tools like you would find with iPilot in the Siemens or others with Philips, where you can kind of help, provide a few tools. In terms of robotics, I think this is very amenable to use of robotics because, this kind of aspect here is rife for robotic contribution. Although, of course, being an old timer, I kind of enjoy the tactile feel, and I really enjoy, the actual procedure itself. So I hope that's not taken away with robotics, or hopefully they provide us with some haptic feedback.
Thank you, Ado. Really appreciate, my friend. Looking forward to get this started here.
Thank you very much. We're really excited and looking forward to that, working with you.
Awesome. Thank you again for your time. We're going to move to our next session with our fearless leader in critical care, Professor Neeraj Naval, or Siri likes to say Naval. Please, Neeraj, take over, man.
Thank you all for coming. So the neurocritical session has two talks, has two, maybe three debates, depending on how much time we have left. Please stay for the debates because they're very entertaining. It usually devolves into fistfights. The level of discourse is better than our presidential debates, though, so you should have fun. The first talk is going to be given by someone very special, someone very close to me, Dr. Monisha Kumar. Some call her Dr. Kumar, some call her Monisha. For me, she's Mona, or as we used to call her back in residency that we did together, 23 years ago, 22 years ago, Jungly Girl. So we go back a really long way. She is, I've always wanted to be her, a male version of her. You know, intelligent, cool, witty. I failed on the intelligent part. I failed on the cool part. And the witty part, I think, as Dr. Savage or Eric likes to say, I always make myself laugh, so it kind of works. But Dr. Kumar, or Mona, did her residency at Hahnemann, moved on to do her fellowship at Mass General in neurocritical care. It was a combo stroke neurocritical care fellowship. Then she moved on to the Harvard of the West, Stanford, to become faculty. Then she decided to come back to UPenn, and now she is the neurocritical care director. She for neurocritical care is the future, I think. And I'm so happy that she's here to speak to us about TEG. Thank you, Mona.
Well, those are some very kind words. I'm really happy to be here. I'm not sure which way, I think. I'm really thrilled to be here. This is really an exciting conference, and it's pretty amazing, the technology that's been presented. So this is more of a clinical talk, so it's a little less technical, but I hope that you find it enjoyable. So I was going to say the only disclosure I had is that I've known Dr. Naval for about 23 years. But my second disclosure is that I did not write this talk with ChatGPT. So just you can. So like I said, we're going to talk about traumatic brain injury. I don't know how many TBI patients you have, so I'm going to spend a little bit of time talking about the epidemiology of TBI. TBI is associated with some coagulation derangements, and it's unclear whether these derangements actually cause expansion of traumatic hematomas, but that's something that's really important because it's that expansion that actually correlates significantly with outcome. We'll talk about the impact of pre-injury antithrombotics. As we know, our population is aging and many patients are on anticoagulants and other antithrombotic agents. And then we'll talk about whether there's a role for viscoelastic monitoring in monitoring these patients in the ICU. So just to start, traumatic brain injury is extraordinarily common. There's about 2.5 million ED visits per year. And we know that there's probably many more traumatic events that happen, but not everyone seeks medical care. There's 61,000 deaths per year. That's about 150 deaths per day. And that's twice the total incidence of aneurysmal subarachnoid hemorrhage, just to put that in perspective. That's how many patients die of TBI. Unfortunately, the outcomes from TBI are not great. The CDC put out that over a 5-year period after traumatic brain injury, only 25% of patients actually improve. The rest either stay the same or get worse. When you think about TBI over the age spectrum, it's really a bimodal distribution with more young people and old people being injured. The types or mechanisms of injury vary over time. So motor vehicle collisions occur more commonly in the young, where falls happen more commonly in the elderly. And the thing to know about the elderly is that those elderly patients who have a TBI, they tend not to do well. There's a higher rate of mortality from their traumatic injury in that patient population. And many of them, as I just mentioned, are on anticoagulants, which compound their injury. So put a pin in that. We're going to come back to that at the end of the talk. So just to set the stage in terms of what is the problem with TBI. So this was a patient in one of the articles by LaRoche in 2012. It was a 73-year-old woman who had fallen down the stairs. And you can see that there's hyperdense material throughout the CAT scan. You can see in the occipital region, there's a soft tissue swelling. It looks like there's edema formation on the right side of the brain, and there's an evolving subdural. The laboratory parameters are not that abnormal. I would say the INR looks slightly elevated. The PTT does seem frankly elevated, but the platelet count is normal. But within 6 hours, there's massive expansion of the hemorrhage. And so what you see here is that there's now diffuse subarachnoid hemorrhage that's really everywhere. You have intraventricular hemorrhage, which you didn't have before. You have significant edema and swelling, and you can see that the bone flap has been removed because this patient had to go emergently to the operating room. At this point, the laboratory parameters look definitely worse. The INR is higher, the PTT is more prolonged, and the platelet count has dropped, even though it's still within the technical range of normal. And so, like I mentioned, this progression of hemorrhagic injury is really a major determinant of outcome after TBI. And so figuring out what contributes to the expansion is paramount. And so what is it? Well, the hematologists think that there's a DIC that's induced by brain injury itself. And why might that be? Well, the brain is actually enriched in tissue factor. Sort of like the placenta. There are organs in the brain that are very differently enriched, and the brain is one of them. And in this text of consultative hemostasis and thrombosis, they identify that closed head injury is a model for acute severe DIC. Now, I think I said DIC, and some people's eyes rolled back into their heads. They're like, oh my God, I heard about that in medical school. What is DIC? So DIC is kind of considered the hemostatic pathway gone awry. It's thrombosis and bleeding at the same time that's made worse by consumptive loss of your coagulation factors. So one of my former mentors who took care of TBI patients in Camden looked at 1,000 patients with TBI and just sort of chronicled the conventional coagulation factors or parameters over the first 24-hour period. And what you see here is that at time 0, the PT and PTT, which is this dark black line, look pretty normal. However, over time, they get progressively prolonged, peaking around 12 hours, and then normalized by 24 hours. The dotted and dashed line are the fibrinogen degradation products, and they have a similar pattern, but they actually peak more at 12 hours. Fibrinogen, which starts off as normal, drops precipitously and naders at 12 hours and then rebounds. And we know that fibrinogen is an acute phase reactant. So it initially drops and then it shoots up sky high. And then the D dimer has an opposite pattern. But you can see that something is happening in these patients with acute brain injury. And so I looked on UpToDate, which is what I always do when I don't know what something is. So I looked DIC up on UpToDate, and what they had here was on the left side of the screen, the activation of intravascular coagulation. So this is the thrombosis part. It's like, but what happens is you get so much thrombosis that you lose your coagulation factors. And so you end up with a loss of platelets, a prolongation of your PT and PTT, increased D dimers, and increased fibrinogen degradation products. Now, that sounds familiar, right? That's the DIC score, and you calculate that when you're looking at patients with DIC. And so most of our tests of DIC tests for bleeding. But I think what's really important is the microvascular thrombosis that also occurs. And this microvascular thrombosis is what leads to organ ischemia and organ failure. It's what causes multi-organ failure from sepsis. It's what causes multi-organ failure from ARDS. But we don't have great tests that really look at this microvascular hypercoagulable state that is driven largely by neutrophil activation and endothelial activation. And then I added this part to the up-to-date, which is sort of where my research lies, which is in the damage-associated molecular patterns and understanding platelet activation, activation of tissue factor, and the role of extracellular vesicles. Now, damage-associated molecular patterns occur with trauma, and that some of that is normal, but when it gets dysregulated, it can actually result in unfettered clotting and bleeding that can worsen these other situations. And so that's, figuring out how we can identify what is problematic and what is appropriate immunothrombosis is crucial. So when thinking about the problem, like how do you test for something that is multifactorial, that is dynamic over time, that might be associated with early progression of hemorrhagic injury, that might be compounded by antithrombotic medications? These patients need to go urgently for surgery, but then we know that there are risks of blood product administration. And if we treat or overtreat, we could actually result in late thromboembolism, which could negate any benefit from treatments that are given early. So is there a system that can do that? Is there a system that could identify high-risk patients, patients at risk for progression of hemorrhagic injury, those that might need surgery, or that could predict mortality, or that could urgently assess the effect of antithrombotic medications if the patient themselves can't tell us what medications they're on? So one proposed solution is to use thromboelastography. Now, I know people think it's, oh, TEG, it's like a new thing. It's actually not. It's been around for 75 years. Helmut Hartert in Germany originated the technology in 1948. And it was designed to evaluate clotting in real time. So one of the things is that your PT, PTT, and other markers are actually studied in plasma, not in whole blood. And the cellular contributions to in vivo coagulation are considerable, but we don't really assess them. TEG has been used for years in cardiac surgery and liver transplantation, and it's able to guide resuscitation in a judicious way. So for example, in cardiac surgery, patients are on heparin, they're on dual antiplatelet therapies, they're also having the trauma of surgery itself. And when they see increased chest tube output, so increased bleeding from the chest tube, they run a TEG and they say, which component is abnormal? Instead of just giving all blood components, they can guide judiciously which aspect. Do I need fibrinogen? Do I need platelets? Do I need heparinase to reverse the heparin effect? And TEG can also monitor platelet function. So how does it work? So the TEG 5000 technology, the prior version of TEG, it had a cup filled with whole blood, and that cup would oscillate. There was a pin attached to a torsion wire that would go into the cup, and an activator would start fibrin formation. And as fibrin formed, it would bind the cup and the pin. And then the oscillations from the cup would generate the TEG trace. And so you can see a TEG tracing from clot formation through clot dissolution. ROTEM is the other viscoelastic hemostatic monitor that is out in common use. It's rotational thromboelastometry. It's now called just thromboelastometry. Instead of the cup rotating, in this version, the axis with the pin rotates and the cup is stationary. It actually makes ROTEM a little more stable as a device because there isn't as much rotation of the cup. And so what do you get? You get a tracing that looks something like this. So on the x-axis, you have time, and on the y-axis, you have amplitude. The first half of the tracing will show you how clot forms, and the latter half, how clot dissolves. The early part is clot time, and clot time really is a measure of your coagulation parameters. So how much of the coagulation proteins do you have? And its time to clot formation is really your R time. Then you have the clot rate or clot kinetics. And you'll see that this is really a function of how much fibrinogen you have and how active it is. clot can form and quickly you can see the curve splits, or it could take a long time for that curve to generate. And that's the clot rate or clot kinetics. Clot strength is measured next, and that is your amplitude. It's how strong is this platelet plug that's formed. And then you have clot stability. Once a clot is formed, does it dissolve very quickly or does it stay for some time? And that's an indication of fibrinolysis. The TEG can also do platelet mapping. So when you have a TEG, you actually run 4 chambers at the same time, and you get functionally clot formation with an activator that really doesn't contribute much. You get one that's thrombin that hypercoagulates the patient so that you get a sense of the least amount of clot formation with the most amount of clot formation. And then you can add, arachidonic acid and ADP inhibitors so that you can see how much contribution of that clot comes from these different platelet antagonists. So if you wanted to look at the different viscoelastic hemostatic assays, you can compare TEG and ROTEM. TEG is a little bit cheaper. There's a lot of training and support. ROTEM is really less operator dependent. It has a device where the screen is attached to the device itself. It's more stable. The old TEG 5000 was very operator dependent, and it was sensitive to vibration, which could really impact the results. But now if you look at that device that's on the your bottom left, that's the new TEG 6S device. It's a cartridge-based device that uses microfluidics and resonance to actually assess clot formation. And so it's a different technology now, but it's much more stable and easy to use. And what it can show you is these different phenotypes. So at the bottom left is the normal TEG trace. And then in blue, if you have a prolonged R time, that's like your heparin sort of effect, or a low MA, which is a platelet strength effect, or a low angle, you'd be worried about a hemorrhagic phenotype shown in blue. If you have a very wide fat tracing, you'll see expansion of that alpha angle and a shortening of the R time. That will give you a hypercoagulable phenotype in pink, and you can see fibrinolysis in green. But for those of you who can't remember those cutoffs, it's 5 o'clock somewhere. So a champagne flute is what a pretty normal TEG tracing looks like. A beer mug that's fat and wide is a hypercoagulable tracing. Anything that tapers, like a Pinot Noir glass, will be indicative of fibrinolysis. And if you see something that's really quickly tapering aggressively, the trauma surgeons have called that the Hershey kiss of death. So how does TEG differ from the routine coagulation tests? We get the PT, PTT, platelet count, D-dimers. We have all the tests. We don't really need anything more, but it's important to know, like I mentioned, that the PT and PTT are done in plasma and they do not take into account protein or cellular contributions to clotting. These tests are done, so even platelets, which are the most crucial part of the plug, these tests are done without platelet contributions. The PT and PTT were intended to determine adequacy of coagulation factor levels, like do you have hemophilia? Not really what is your preoperative risk of bleeding. Perioperative bleeding might be multifactorial. It might not just be about the enzymatic contributions. It might be about fibrinogen, or it might be about platelet function. And we don't have great ways to test for that. So ultimately, the PT and PTT do not represent in vivo clotting. And so if you really want to know what's going on with your patient, you need to get a TEG. Well, you could get a TEG. So let's go back to that example. So when the patient came in, a TEG was run, and the early TEG looked reasonably normal. That dotted line is sort of the normal tracing. And then when the patient had expanded, the repeat TEG shows that there's a significant decrease in the clot kinetics, the platelet, the clot stability, and the clot strength. And so you could argue that it would help guide treatment to know what that tracing looked like earlier. So, okay, I think I've made the case that maybe TEG could be useful in TBI, but what are the data? I know you're thinking, show me the data. So standard TEG, so not platelet mapping, just the standard TEG has been looked at in TBI. This was one of the studies from over 10 years ago, looking at almost 70 severe TBI patients. And when they compared how the TEG parameters predicted outcome to how conventional coagulation tests predicted outcome, only the TEG R time was able to discriminate significantly patients who survived from patients who died, how many of them had ICU free days, hospital free days, and how many patients needed neurosurgical intervention. So ultimately, you could say that standard TEG was significantly associated with neurosurgical intervention and mortality and important ICU outcomes. Rapid TEG in this study of nearly 300 isolated TBI patients was indicative of or identified a coagulopathy, and that coagulopathy was a predictor of progression of hemorrhagic injury, which is, I think, sort of like the holy grail. Which patients are going to expand their hemorrhage? That's what we want to know, because we want to intervene on those patients sooner. If you look at platelet mapping, it has been studied in TBI. And so in this study, it was only 50 patients, but looking at the platelet maps, you could quickly distinguish patients with TBI from controls. Okay, I know that's not that interesting, but it could also discriminate injury severity. So patients who had a GCS of greater than 8 versus less than 8, you could tell that that pattern was different using TEG. And similarly, it discriminated between survivors and non-survivors. This other study, this is 120 isolated TBI patients. So one of the things that's complicated in some of these patients is when you have a polytrauma patient, you might see evidence of the polytrauma and not the isolated trauma. But here, this is looking at isolated TBI, ADP inhibition. So that's the platelet mapping component, was significantly associated with mortality in this cohort. And so another group looked at the isolated TBI, and they found a pattern also of coagulopathy that showed delayed clot formation, but no evidence of fibrinolysis. So one of the things in the trauma literature is that what TEG has been really helpful is identifying early fibrinolysis. And so there's been a lot of use of antifibrinolytics in those patients. In isolated TBI, it's a little bit more controversial. Some centers use it, some centers don't. But what they were able to show is actually that it was more of fibrinogen contribution, suggesting maybe there's more of a factor replacement need in lieu of or in addition to an antifibrinolytic. So one of my colleagues and I, we did this systematic review looking at TEG in TBI. And we also were able to demonstrate that the literature showed that ADP inhibition was associated with decreased survival in a meta-analysis. This is sort of a complicated chart from that slide, but basically what it shows is if you look at different populations, so TBI versus healthy controls, TBI versus trauma controls, severe TBI versus mild to moderate, TEG could actually discriminate between these different populations. And so just for an example, I've highlighted the AA and ADP inhibition. How you would interpret this, this chart would be that the AA and ADP inhibition in TBI patients is increased, which indicates significantly more hypocoagulability in this group. All right, so we think that it can stratify by injury severity. It identifies which patients were more likely to have neurosurgical intervention, which had higher ICU length of stay, which might expand, and it can distinguish between survivors and non-survivors. But that's all retrospective. That's not really prospective. That doesn't really help us with the patient in front of us. So can it actually guide treatment? So I'm sorry that this formatting got off, but This was actually a single center randomized controlled trial of 111 trauma patients. And what they were able to demonstrate was that there was higher survival in the TEG algorithm approach than in the conventional coagulation testing approach. And those patients with conventional coagulation tests received significantly more blood products. And we now know that blood products are harmful. This was a recent study from 2020, from last month, actually, looking at ROTEM in almost 700 trauma patients. They did what was interesting, a propensity score matched approach. So this is better than sort of a retrospective study, but with sort of high fidelity. And so they looked at all these different parameters, and then they compared. Their primary outcome was, are patients alive and free of massive transfusion? And they met that primary metric, which was more patients in the ROTEM group, or viscoelastic hemostatic monitoring, VHA, than in the conventional arm. They also showed that there was a significant reduction in cost when you use the ROTEM. And we think that's because it's more judicious in how you need blood products, so you use less. This was a European trial that was published a couple of years ago, looking at TEG specifically, not ROTEM, but TEG for major trauma. It had almost 400 patients, and it did not show a benefit of TEG in the trauma patients. But it interestingly did show a survival in the TBI subgroup. It was unclear why, but it was very significant. Almost 20% more patients in the TEG arm did survive compared to the conventional control arm, but did not use platelet mapping. And this was just an interesting paper that I came across looking at COVID patients. It was sort of a small sample, but they did the same thing. They took an algorithm. I'm sure you guys took care of COVID patients. I know it seems like a long time ago now, but they were very hypercoagulable, right? Like they would go on dialysis, their circuits would clot. It was very complicated to deal with them. But then the literature suggested you shouldn't anticoagulate them routinely, but how do you know maybe some needed to be anticoagulated? So this group actually looked at TEG, and they were able to discriminate between the two. And interestingly, the non-algorithm guided group resulted in heparin use that was a 10-fold increase in mortality. That's pretty whopping. So at Penn, I decided, we have a bunch of elderly patients who come in with a subdural, and they need their antiplatelet agent for their stroke risk or for their CAD. And I wanted to know, should I be reversing them routinely, which was our, default approach to managing these patients. And so I was like, could we use TEG platelet mapping in this population? We know that in spontaneous ICH, reversal with platelets is harmful. So I really didn't want to give these patients a platelet transfusion if they didn't need it. And so I looked at patients who were admitted to our trauma center, who were older than 50, who were not on any other anticoagulants or antithrombotics. I defined expansion as less than a third of baseline, moderate as greater than a third, but I put an absolute volume on there of 12.5 cc's. I did derive this from the literature, and severe. We saw a ton of patients, but many of them were on concomitant antithrombotics. So those numbers got smaller pretty quickly. So we had 37 in our control arm and 62 in our platelet mapping arm. This was our protocol. We would do a TEG with platelet mapping. If either the AA or the ADP site were inhibited, then we would look at which value was most abnormal. And then we would treat either with DDAVP if they were not getting a neurosurgical intervention, or DDAVP and transfusion if they needed either operative intervention or an EVD. We used this free tool that was developed at the University of Pennsylvania and the University of Utah called ITK Snap, and it quantitates based on imaging the amount of hemorrhage on a CT scan. So we didn't use like the ABC over 2 approach. And this was our demographics table. It's very busy. You don't have to look, but basically when it came to demographics, there were no differences between the 2 groups. The only difference was that there was a slightly shorter PT or prolonged PT in the control group, but this is by our reagent still within the range of normal. And what we were able to show was that we reduced platelet transfusion from 57% to 10%. We actually did this in the context of QI, and we told them that our goal was a 10% reduction in blood product administration, and we had a 47% reduction. And to be honest, the pre-test group was more like 100% when we started this project, but because we kept talking about it, the control group already was sort of improved, but pretty significant results. And the most critical part is that there was no significant increase in hemorrhage expansion, in clinical worsening requiring late treatment, in delayed transfusion or neurosurgical intervention. So it was a small study. I'm out of time. I'm just going to say that, it was limited and that we're doing more work to expand it. And so in summary, a platelet mapping algorithm, may reduce platelet transfusion in our study. We thought DDAVP treatment was reasonable, but with the new TEG6S device, we have to refine our arachidonic acid and ADP cutoffs. But overall, I think that it's clear that TEG and platelet mapping can identify abnormalities that are more significant than conventional testing in TBI. It can stratify patients between sicker patients, patients who need neurosurgical intervention, and those that have a worse prognosis. And it could be safely used to judiciously determine who needs antiplatelet in TBI. And I think that the new device really holds promise to improve upon prior data. Thank you.
Hi, that's awesome. Thanks so much for talking about this. And interestingly, where I work, we're looking at our TBI patients and how we might be able to actually step them down faster. Because of course, they take up a lot of our ICU space. And one of the big questions is when you have these that come in and you don't have TEG or ROTEM to check, many of us are feeling uncomfortable just going by CT. Did you find in any of the literature that you looked at that there was like any kind of subgrouping or evaluation analysis of patients who met the criteria of TEG that could be stepped down, that looked at, oh, these patients did well if they didn't go to an ICU? Like, was there an AHA number or result that would help give you a comfort to say, oh, if this patient's TEG was at X, maybe consider sending them to an intermediate unit after that initial scan if their blood volume was low enough?
Yeah, I mean, I would say that I think it's a combination of the initial blood volume. So they're like, how much bleeding did they first have? And if their TEG was normal, then expansion was, we didn't really encounter expansion. I think it's a good point. We can look back at our data set and even see like, who are those patients who might have, slipped by? Most of the time, it would be that the TEG device is really good for, like dabigatran can be picked up on the TEG device, but the factor Xa inhibitors, not so much. So if you know that they're not on antithrombotic therapy, and there is a new cartridge that's available for research that has it can discriminate between the factor Xas, the direct thrombin inhibitors, so you can actually get that information in real time. But I think if your blood volume initially is pretty low and your TEG is normal, and you have an exam to follow, and we're not there yet, I wouldn't say just like go ahead and do it, but I think it would be worth, just looking at retrospectively. But pretty much if the TEG is normal, we didn't see a ton of expansion, significant expansion.
Yeah, that's, I had one other question. Is, remind me, does ROTEM not appropriately capture when patients on antiplatelets? That's one of the biggest differences, correct? And
correct. It does not have a platelet function testing.
That's what I thought. Okay, thank you.
Hey, Mona, I have a couple of questions for you. I feel smarter already now. the first question, actually two different ends of the spectrum for stroke patients. Has there been any work done? Because, one of the graphs that you showed on patients who are potentially hypercoagulable, and that's why they had a stroke. We talk about cryptogenic strokes all the time. There's so much focus on bleeding, but what about those that might be hypercoagulable? Like if you get a 75-year-old who has a stroke and you're like, that looks cortical, it looks cryptogenic, I didn't find any AFib, they get linked, they get sent out. No one does a CT chest, abdomen, pelvis as standard of care. But if you did a TEG that suggested that you are hypercoagulable, perhaps we would then get more imaging and look for underlying cancer. Has that ever been looked at?
No. So I think because there's just not as many of those patients, and so there isn't big of a cohort. In stroke, typically it's looking at whether there's hemorrhagic conversion. One of the things that I think we should be doing more often is doing a TEG for patients who come in who don't get TNK, who don't get endovascular therapy, just to see if they might be on an antiplatelet agent, but we don't know if there's aspirin resistance, if there's high on treatment failure. Like, why aren't we doing it that way and saying, like, let's try to target something different? Because, the way that at least stroke treatment is at Penn, like they sort of view all the antiplatelet agents as being equivalent. So someone could come in with a stroke on aspirin and leave on aspirin. Doesn't feel right. So I think that for me is a question that's burning, but I think the hypercoagulable piece has really not been addressed much in literature at all.
One more question related, and you brought it up briefly, the CRASH 3 trial, looking at isolated head trauma and using antifibrinolytic therapy. And, when the headlines came out, 1 in 5 people, 1 in 5 lives saved. And then you read the actual paper and you look at what they did and the post hoc and subset analysis, and then looking at head injury associated mortality, which was very controversial. Still believe, I think, that perhaps there's a subset population that it's useful in. Has anyone gone back or did they do any TEG in that patient series? Is anyone doing it? Because maybe there is a subset within isolated head trauma where it might be beneficial.
It was the only data I've seen is in that one paper that I presented where it was 110 patients. And they looked at TEG and they said, it was interesting. The isolated TBI patients, they did not see any evidence of hyperfibrinolysis, but they saw indicative like clot rate. The K constant and the alpha angle were the ones that were really problematic. And so they were saying, why are we giving all of these patients an antifibrinolytic when maybe what they really need is cryo or FFP?
Thank you.
I have one for you. First, I think you need to add MA to your TAT, because call a guy over 50 elderly. I think that's not a good. I felt personally attacked on that one. That's one. Again, I'm neurotic about platelet function, and again, we start this 15 years ago. A TAG in patients, not trauma, IPH. We lost a patient recently, very complicated, subarachnoid hemorrhage, spontaneous IPH. Reoperation. So tagging in spontaneous IPH and tag in aneurysm treatment. So we do routine platelet testing. We had a discussion this morning about a study that we're embarking, and one of the investigators said, no, we should not test anybody. I said, I have a problem with that. But again, it's a bit of a religion, right? Do you believe in those tests or you don't believe? So how do you see tag on those two separate applications, spontaneous intracranial hemorrhage and looking for patients that are failing antiplatelet use, as you alluded in the previous answer?
No, I think that's a really good question. And I think as we sort of our treatment options are morphing in ICH treatment and subarachnoid hemorrhage. So I would say for ICH, there are some papers that identify which patients might expand their hematomas. The big problem is, do you get the TEG early enough? A lot of the patients who expand might have expanded before they even got to the hospital. So I think it's understanding that the dynamic process is very early and you need to get the data sort of sooner rather than later. And so I don't know, I think that maybe that helps. Like maybe if you could identify which patients would be expanding, sort of like a spot sign, or sort of, could you then target with, maybe not factor 7A, but something like that, that would limit it. I think there is promise there, but I think we have to understand it better. In subarachnoid hemorrhage, I actually have been really interested in that question. And I started my TEG work in subarachnoid because what was interesting to me is that early, there's that hypocoagulable phenotype where they're bleeding and the aneurysm is about to re-rupture and you're concerned. But then, we don't have great treatments for DCI, right? I mean, I think the guidelines have come out and we don't really know what to do. Every Triple H therapy is now no longer, efficacious. And so what do we have? But there are these blood biomarker signatures of a hypercoagulable state that's transient. And I think that we really do need to be addressing that. And whether, that means that we should follow Mark Simard and put everybody on heparin, or whether we should do something different, I don't know. But I do think that this is the critical piece, is this transient hypercoagulability that is related to angiographic narrowing. There's something in that story that we need to flesh out.
And what's the cost per tag? Do you know that?
So it's about 100. So if you look at, there's many studies that actually look at conventional testing and TEG, and it's about the same. So if you get like a PT-PTT and a platelet count and all of those things, it's essentially the same. As a matter of fact, there are trauma centers now that just do TEG because it's cost effective, because not only are the tests themselves are cost effective, but then the guidance is cost effective. So it restricts the amount of blood products needed.
Thank you.
So my question is kind of a follow-up to that, which is, this is a 75-year-old technology that at least for the last 20 years is well supported in trauma, liver transplant, cardiac surgery. And it's like a couple of years ago, neurocritical care just woke up and was like, oh, hey, this is cool, we should use this. Why aren't we? What are the barriers?
Well, so I think, it's funny because so at our trauma hospital, through the work that we've done, we actually secured it and got it into the lab because we demonstrated cost effectiveness. At our main campus hospital, where the hematologists run the coag lab, they just don't feel like it's useful. So the cardiac surgeons use it through their perfusionists and it doesn't go through the lab. I think that it's sort of a political issue, really, because the surgeons tend to like it, right? Like if you're in the operating room and you're seeing bleeding and you get a tag and it makes sense and you give the component and then the bleeding stops, you think that the technology is telling you something that's meaningful. But the hematologists don't really have that angle, I think. And so I feel like the validation is not the way that the hematologists would like it. I'm curious with this microfluidics device, now that it's a little more stable, now that it's a different technology, I think we're going to see more adoption. And the military really likes it because it can discriminate between ischemic stroke and hemorrhagic stroke. And so when they see patients in the field, if they could get a sense that this is, hemorrhagic, then, I think if the military adopts it, it'll definitely be kind of brought to civilian states sooner.
Thank you, Mona. So initially, I had planned to basically introduce everyone based on their CVs. And then Mona sent me hers, and it was 33 pages long. And we only have 35 minutes per talk, so I'm just going to do like a more informal introduction. My next speaker is Dr. Joshua Levine. He is married to Dr. Mona Kumar. So can you imagine the amount of brain power in that house? I mean, it's ridiculous. Their kids are going to have an IQ of like 200. It's freaking amazing to me. So Dr. Levine went to medical school only at Harvard. He then did his residency at Penn. Then he did his fellowship back at Harvard. And then he went back to UPenn to become the division director of neurocritical care. He's the vice chair of clinical affairs of neurology. I mean, it's quite ridiculous. Sometimes I go home and I feel good about myself. And then I read their CVs and everything they've accomplished, the two of them, and I just go and weep. And I'm appreciative I had kids that love me and, kind of make up for it. But Dr. Levine is going to talk to us about brain death. And, for some of us, some of you, you think, well, brain death, it's a definitive thing, right? If you say you're brain dead, you're brain dead. But are you really dead? And that's what we're going to hear about. So welcome, Dr. Levine.
I'm really honored to be here, and I want to thank Dr. Naval and all the other organizers of this conference for inviting me to talk about this topic in a way I think that we don't often talk about it, and I hope that this prompts you to think a little bit more about brain death in ways perhaps you haven't thought about it to date. Let's see. Which button? Here we go. Okay, so I have nothing to disclose that's related to this talk, except for the fact that I'm a medical doctor. I'm a neurointensivist, and I'll discuss some medical issues, but I'm also going to discuss legal and ethical issues. And I'm not a legal scholar or an ethicist, but I've put a series of papers and lectures in a reference slide at the end of this, in case you're interested in delving more deeply into some of these topics. So what I hope to cover is to understand how brain death evolved in a historical context, and to give you an appreciation of how brain death is viewed in very different ways across different disciplines, from medicine to law to biology and ethics, and how it's not all of the same. And I think most of us have been taught a single way, but I'd like to expand your thinking to many different ways. Then we'll talk about some of the challenges and controversies that brain death faces within these disciplines, and maybe address some of the current ongoing efforts to reconcile some of these challenges. So we'll start out with some history, and it really began in the 1950s, when some medical advances like the ventilator and CPR and the defibrillator really allowed, for the first time ever, physicians to maintain people who were in a coma and had catastrophic injury with no hope of recovery alive indefinitely. And almost immediately, people who cared for these patients had concerns. For one thing, this put us in a position where we were using medicine for no apparent therapeutic gain. Up until this time, if we did something to a patient, it was to make them better. But now it seemed like we were doing things to patients and not making them better at all. There were financial concerns for patients, for families, and for hospitals. What are the implications of being able to keep people in this comatose state indefinitely? And what about the emotional burden it placed on patients' families and their caregivers? And people were asking, was removal of life support in these patients homicide? At that point, that was a very real concern. This was before the Kiernan Quigley case that came in the 70s that allowed withdrawal of life-sustaining therapies. And so people asked, if I take away the ventilator from these comatose patients, will I be arrested and charged with murder? And that was a very real concern. In the 1960s, organ transplantation became a reality, and it was really the combination of azathioprine and prednisone that allowed, for the first time, a kidney to be transplanted between two non-related people. And it was immediately apparent that transplantation was more successful if the circulation was intact. And the first heart transplant occurred in 1967, and it was from a donor who was in a coma. And people immediately questioned, well, was that donor dead? Did we take a heart out of a dead person, or did taking that heart out of the person kill the patient? And I think this caused a lot of consternation ethically and philosophically. And it really spurred an ad hoc committee at Harvard Medical School to convene and form the Harvard criteria. And Henry Beecher, who was the chair of anesthesia at Harvard, led this effort. And the Harvard criteria proposed to determine criteria for irreversible coma, and suggested in their report that perhaps irreversible coma should be a new criterion for death. And at the time, this was a very novel concept. Until then, death was pretty clear to everybody. It's when your heart stops and it can't be restarted. But the Harvard criteria was really the first suggestion that perhaps when the brain stops working, that should be considered death too. In the 1970s, individual states had different criteria for death, and many, but not all, states adopted laws that allowed physicians to declare death in comatose patients on ventilators. And it led to this bizarre situation where, because there was such heterogeneity in law, someone could be dead in one state and alive in another state. And so the US President's Commission for the Study of Ethical Issues in Medicine and Biomedicine convened, and they said, yes, we endorse the Harvard criteria, and we think this should be sort of rolled out nationally. And in 1981, it paved the way for Congress to pass the Uniform Determination of Death Act, which really established brain death as legally equivalent to death by circulatory criteria. And some version of the UDDA was adopted by all 50 states. And I put here a quote from the Uniform Determination of Death Act, which basically says that if your brain stops working, you're dead. But I underlined an important part of it, which is that it says a determination of death must be made in accordance with accepted medical standards. And we'll get back to why that underlined statement is so important. So in 1995, the American Academy of Neurology published guidelines for the first time about how to determine brain death. And in 2008, the President's Council on Bioethics reaffirmed that they think brain death is a thing, and it is death. And in 2010, the AN updated and reaffirmed their guidelines. And what this led to is the concept that we've all been taught that brain death is death. And this is a mantra that, was hammered into me over and over and over. It's sort of the medical party line that brain death is death. And currently, the majority of the medical, legal, and ethical communities support the idea that brain death equals death. But this has created a lot of trouble. And, one idea is that from its inception, there have been controversies about this that haven't been fully resolved. And the language we use doesn't really help, right? If we're calling brain death, that term alone implies that it's something other than death. Otherwise, we just call it death. So the terminology we use just adds to some of the confusion. And the two main points that I'm going to try to convince you of in this talk is that whether you think brain death equals death really depends on the perspective from which you're asking that question. Is brain death death? Are you asking it from a medical perspective, a legal perspective, a biological perspective, moral, ethical, philosophical, sociological, cultural, or religious perspectives? And the answer might be different depending on which perspective you're using. And I think that conflating these perspectives may be responsible in large part for a lot of the controversy and confusion that's persisted and grown in recent years. And so you'll tell me by the end of the talk if you're convinced that that's the case. So it's really all about perspective. Now, I think what I'm like to convince you of is that from a medical perspective, brain death is death. But there are lots of threats to that exist right now. I think similarly, from a legal perspective, it's pretty clear that brain death is death. But similarly, there are lots of challenges, especially in the last couple of years. From a biological standpoint, I don't think it's clear that brain death is the same thing as death. And my opinion is that it's probably not. And we'll talk about why that is. And then if you're talking about from a moral, ethical, or philosophical standpoint, it's complicated, and it depends on which school of philosophy you're approaching it from. So we'll start with the medical perspective. Brain death is equivalent to death from a medical perspective. Why? Because how do we set standards in medicine? They're set by authoritative medical bodies. They're often codified in guidelines, and guidelines are usually based on evidence, or when there's no evidence, on expert opinion. And there's a medically agreed upon state that defines brain death. There's general agreement that it is death, and standards exist for its determination, the guidelines that we have. And therefore, when a patient meets these criteria, the patient is, from a medical standpoint, dead. But there are major challenges that threaten the integrity of the medical diagnosis of brain death. The first is there's lack of global agreement and consistency about what brain death is. Not all countries recognize brain death. And of those that do, there are fundamental and foundational differences in the definition. So, for example, in India and the United Kingdom, someone is dead if their brain stem alone stops working, but in the United States, that's not sufficient for brain death. And it's a little strange to have definitions of death that are so dramatically different. There was a survey of global practices that found major differences in key components of the diagnostic procedures from country to country. And it's very clear that perceptions of brain death vary from country to country. It's not just a global problem. There's a lack of national consistency and standardization within the US. There's each hospital has its own policy. When I arrived at Penn, which is a health system that has numerous hospitals, the policy from hospital to hospital within one health system were different, and I had to work to standardize those. And there's considerable variability in practice within the US. Maybe more concerning, there's a lack of adherence to guidelines. And this is true in the United States and presumably elsewhere. There was a very well-publicized article in JAMA in 2016. And what the investigator did is he obtained brain death policies from virtually every hospital in the United States and compared them to guidelines and said, do they differ from guidelines? Are they the same from guidelines? And what he found is, and this is a quote from the paper, that hospital policies in the United States for brain death determination are widely variable and not congruent with contemporary practice parameters. And there's a lack of understanding and competence among physicians. And I think that's a big problem. There was a study in 2019 where they surveyed doctors who performed brain death determination and said, how comfortable do you feel? Are you competent to do this? And virtually all doctors said, yes, I am competent to declare brain death, but only 25% of them followed AAN guidelines. 10% didn't perform any apnea testing at all. And of those that got ancillary studies like nuclear blood flow studies or cerebral angiograms, a quarter of them did that if the patient breathed during the apnea test, which is sort of by guidelines crazy, because that should automatically disqualify that patient from any further testing. There are studies from other countries that corroborate this, and there's little reason to suspect that lack of competence and comfort with declaring brain death is not more widespread across the globe. And I think that these taken together, these are problematic, and especially the last two, because they lead you to conclude that it's likely that there's a high rate of misdiagnosis of brain death. If we're not adhering to guidelines and physicians generally lack the level of competence we would hope, the odds are that there are significant numbers of misdiagnoses every year. And all it takes is talking to your organ procurement organization, and they'll corroborate that because they see practices that are clearly in violation of recommended guidelines. How about from a legal perspective? Well, I think from a legal perspective, brain death is equivalent to death. Why? Because laws are created by legislative bodies, and the equivalence of brain death and death was established by an act and codified by state laws and statutes. So legally, brain death is death. But like in medicine, there are challenges to the legal definition of death too. Laws are not immutable. They're subject to interpretation by courts. And there have been many legal challenges that have arisen. So the first problem legally is that there are inconsistencies in state laws. While all states have adopted some version of the UDDA, the state statutes vary in their language and in their requirements. For example, they vary in who can determine brain death, religious objections. And I just want to point out, there are a couple of states, New Jersey in particular, if the family objects to brain death determination on religious grounds, the physicians are not allowed to declare brain death. And then there are a couple of others that have similar, but not quite as extreme laws. Now, can you imagine a court saying that if someone's heart stopped and they were cold and a family objected on religious grounds to declaring death, you have to treat that person as alive? Probably not, right? That's pretty inconceivable. So if you can do that for brain death, someone doesn't think it's quite the same as death from cardiac standstill. And in laws with respect to informed consent vary too. There have been inconsistent legal rulings, and I'll give you an example. So do you need informed consent to declare brain death? The American Academy of Neurology's position is absolutely not. But contrast two legal cases that occurred virtually simultaneously Both involved a child who met criteria for brain death and whose parents refused to consent to brain death testing. In Montana, the court ruled that brain death testing is a medical procedure and, like all medical procedures, requires consent. Whereas in Virginia, the court ruled that consent is not necessary to diagnose death. So here's two cases on virtually an identical problem with diametrically opposed legal rulings. The courts have even questioned whether the AAN criteria are the accepted medical standard. And there was a case of a woman who was a 20-year-old in Nevada that was declared brain dead in a hospital after anoxia during surgery. And her father filed suit to prevent discontinuation of mechanical ventilation. And the district court said that the AAN criteria were followed and the patient was dead, and therefore the doctors could go ahead and remove mechanical ventilation. But the father appealed, and the Nevada Supreme Court reversed the district court's decision. And they said it's not really clear that AAN criteria are an accepted medical standard. And remember, that's why I underlined that language in the UDDA. And why did they feel that way? Well, they said, look at all the variability in practice, all the data I showed you, that we don't follow the rules, we don't follow guidelines. And so the court said, how can you argue that this is accepted medical standards? Luckily, the legislature of Nevada then made a law saying, yes, the AAN criteria should be the medical standard, but the courts up until then questioned whether those are really accepted standards. And there are other legal challenging issues that I suspect will arise, maybe in this state. Let's take the case of pregnancy and brain death. So in 2013, a 33-year-old woman who was 14 weeks pregnant was declared brain dead in Texas. And her husband requested that she be discontinued from mechanical ventilation, but the hospital refused because they thought it might be a violation of the Texas Advanced Directive Act, which prohibits withdrawing life-sustaining therapies from pregnant patients. And the court said, well, this isn't a violation because this is not, the patient's already died, and so you can go ahead and withdraw support. But I would ask, how do you think this ruling would be decided now, since Dobbs versus Jackson Women's Health Organization overturned Roe v. Wade? Because withdrawing the ventilator on this patient would functionally cause an abortion. And, I'm not aware that this has been litigated yet, but I have a sinking feeling that it's only a matter of time before this specific situation comes again to the court. And, I'm not sure, states now vary in their laws about abortion, but clearly someone who's declared brain dead, who's gestating a fetus, is going to pose a problem for the legal system. Now, we'll get to something a little bit more interesting, in my opinion, which is the biological perspective. And I think whether brain death equals death biologically is a very tough question, because defining death in general from a biologic standpoint is not straightforward. And ideally, a biological definition of death should be applicable across species. And I think most people would agree about that. And the best definition of what dead is that I've seen from a biological standpoint comes from the physiologist Walter Cannon, who in the 1930s said that what distinguishes an inanimate from an animate object is the use of energy-consuming processes that oppose entropy. And so death then, according to Walter Cannon, is the permanent loss of an organism's capacity to maintain homeostasis and resist entropy and disintegration. And brain death does not fulfill this definition. People who have been declared brain dead can persist for months and years without disintegrating and maintain homeostasis just fine. And I think technology is further blurring boundaries. Medical technologies have blurred the boundaries between life and death and are redefining what's reversible or irreversible and permanent. And I think everyone would agree that death should be a permanent state. So we have a ventilator that can replace absent breathing. ECMO can replace absent circulation. Pacemakers can maintain a normal heart rhythm. Defibrillators could get you out of a fatal rhythm. Dialysis can replace kidney function. And now there's an emerging science of reanimation, and investigators at Yale were able to restore circulation and cellular function, including brain function, hours after circulatory death in pigs. And I've just put two articles here, which I think are fascinating, and you might want to read, where they literally subjected pigs to cardiac standstill and then perfused them with a solution that had cell-preserving chemicals in it. And hours later, were able to restore a heartbeat and restore neuronal function. They demonstrated that neurons were sending electrical signals and that under the microscope, they were indistinguishable from normal healthy neurons. And so biologically, the lines between life and death are becoming blurred. And I think this is a very important point, that in contrast to law and medicine, where we draw bright lines, biology doesn't work that way. It functions along a spectrum. What do I mean by that? So when you turn 18, suddenly, legally, you become an adult. And you're accorded all these privileges that an adult has. And when you're 17, you don't have those privileges. Now, is there a biological difference between a person on their 18th birthday and the day before their 18th birthday? Absolutely not. It's the same thing biologically. In my ICU, when someone has a fever to 100.5, we call it a fever, and suddenly we draw cultures. But if they're 100.4, we don't. Right? In medicine, we draw a bright line. We have to. For testing purposes, we draw thresholds, but biologically, there's no difference between 100.4 and 100.5. So biology operates along a spectrum, whereas in medicine and law, we draw bright lines. And on this image here, I have I guess on your left side, a spectrum of brain function, from an uninjured brain to a completely necrotic and liquefied brain. And brain death falls somewhere in the middle there. And whether you should draw a bright line at brain death, that level of function, and call that dead is somewhat arbitrary. And it doesn't really reflect the way biology works, which functions more along a spectrum than these hard and fast categories. And then we can look at it from a moral, ethical, and philosophical perspective. And brain death has been viewed by ethicists in many ways. Number one is a philosophical construct. So someone who views it that way might say, the organism is alive, but the person, as distinct from the organism, is dead due to irreversible unconsciousness. You can look at it as a moral construct, and someone might say alive and dead are just covertly normative moral terms, functioning similarly as persons does in an abortion debate. So dead in this case means lack of moral status as members of the human community, and that removal of organs is permissible, but the body is biologically alive. And I think this is very analogous to the debate we have in abortion. Is it possible to define life at some point after conception? No, it's a spectrum. But that doesn't necessarily mean that you can't make a moral decision about when the fetus is accorded the rights of a human, or whether it is at all. And same here, someone who's brain dead, biologically, it's hard to say whether they're alive or dead. It doesn't mean you can't necessarily make a moral decision that they no longer have the moral rights of a human, and you could then say that taking organs is permissible. You could also look at it as a social construct. And I put this picture up here with a question to you: is that art? And this was actually on display in Miami at Art Basel, Miami, as a piece of art. And that's a social choice, right? We have every right to decide this is art or this is not art. It's a social choice. And some ethicists have argued that brain death is a social choice. We can make a choice as a society that the state of brain function that is brain death is socially equivalent to dead. And then you can also justify it ethically by saying, no, this is biological death. That is why it is ethically justifiable. It's biologically death. Now, My opinion is that it's very difficult to justify this on a biological basis for the reasons I've given you. But this last ethical justification that it's biological death is the most established view right now from an ethics standpoint, that brain death is death and it's ethically justified because it's biological death. And in fact, this was the view that was articulated in 1981 by the President's Commission. And, in their report defining death, they said that technology is just making dead people look alive, but they're really dead because they've had loss of integrations of the bodily functions as the organism as a whole. And this view, which is, was the original view and still the mainstream view, has been criticized on many grounds. So number one, we've talked about that death is biologically hard to define. And if you do define it by Walter Cannon's definition, brain death doesn't really seem to meet that definition. And furthermore, the arguments used for equating brain death with biological death have changed over time, and each one is flawed. So in 1981, when they first said brain death is biological death, the reason they used is that when a person is dead, there's inevitable loss of bodily functions and the patient has a cardiac arrest within 1 week for adults and within 2 weeks for children. But that was true in 1981. It's not true any longer. We can keep people in a brain dead state for years without cardiac arrest. And so in 2008, when the President's Council revisited this issue, they said, okay, we acknowledge that that really wasn't a great argument because it's not true anymore. So they came up with a new justification for why brain death is biological death. And they said, because when someone is brain dead, they've lost the capacity to do vital work. And that's a strange term. It had never been used before, certainly not in a biological sense. It's not even clear what they meant by that, but what they said by you've lost the capacity to do vital work is that the organism no longer has a drive to exist, to interact with its environment and exist. And this definition was roundly criticized by ethicists. And they said, this is just an ad hoc definition with no real justification, designed solely for the purpose of justifying brain death as equivalent to death from a biological perspective. Others have said that brain death is death because it involves irreversible loss of critical functions of the brain as a whole. And we all have this idea that the brain is something special, it's privileged. And if you lose that, you've lost something about the organism that's vital. But that's a philosophical argument. Privileging the brain above the heart or the lungs or the kidneys is not a biological reason. That is a moral or a philosophical or an ethical reason. And so using that to justify brain death from a biological perspective doesn't really make sense. And so brain death faces major challenges. Studies suggest lack of understanding and competence in the medical community, lack of public understanding, ethical concerns that have been raised since the concept existed persist and really have not been put to rest. And the legitimacy is increasingly being challenged in the courts. And the number of lawsuits challenging brain death has grown dramatically just over the last 5 years. This challenge to legitimacy was just commented on about, 3 months ago in JAMA, where a bioethicist from Harvard wrote an editorial about this, and he points out some of what I discussed and really arguing that the current state is not tenable. And so, I'll summarize what I've said so far by saying that it's complex and it's widely misunderstood. It's undergoing increasing scrutiny and challenges to its legitimacy. And I think a lot of it stems from conflating feeling this need to say that it's biological death and conflating that with, other approaches like philosophical and moral approaches. And we also use imprecise language when we're talking about it, which doesn't help. And presently, as a concept in the process for determination, it functions adequately, but it's far from perfect. And I like these quotes that some have written about the current state of brain death. Some have called it a superficial and fragile consensus, well settled yet still unresolved, too flawed to endure, too ingrained to abandon. So where do we go from here? And this is just my opinion. I think brain death serves a vital society role and is pragmatic. It leads to, without brain death, there would be very little organ transplantation. And I think most people would agree that that's of societal importance. So I think it's important to maintain or augment public trust in brain death and in the organ transplantation process. And there are lots of solutions that have been proposed to sort of reconcile some of these problems we've talked about. And I've listed some of the solutions here, and they range from minor to radical and extreme. Some have proposed revising the definition of brain death and revising the Uniform Determination of Death Act. Some have suggested and are working on revising the guidelines for brain death determination. Some have suggested doing away with brain death determination altogether, whereas others have suggested that we abandon the dead donor rule. And that's sort of an ethical principle that we can't take organs from people who aren't dead. And that's one of the main reasons we have brain death, because we feel we can't take organs from people who are alive. And there's a good reason for the dead donor rule. If you don't have that, it can lead to abuses. But there are very strong arguments that you could prevent those abuses by very strict regulations and just abandon it. And, if you can consent to donating a kidney to a brother or an uncle, why should you not be able to consent that upon, that if you are in a certain state where physicians deem you have no chance of recovering from a coma, you can also donate organs without having to call that state dead. And some have said that we should be more transparent with the public and let them know that, what you're seeing with your own eyes, that this person is warm and has a beating heart. Our natural inclination is say this is very different from someone who has rigor mortis and is cold, but we've been telling the public that no, they're both dead. Some say we should make it more clear that biologically there absolutely is a difference. Others say exactly the opposite, that if we accept the idea that biologically this state is not the same as having your heart stop, the public will totally lose hope and lose trust in brain death and won't accept it. And there's actually some literature about what attitudes might be. And surprisingly, the literature at least suggests that the public would be very open to understanding that this is not the same as cardiac death biologically, but we make a societal choice that it's okay to recover organs from people in that state. So I think continued efforts to iteratively improve brain death from a conceptual standpoint, operationally and legislatively are probably the most feasible and realistic path forward. There are ongoing efforts there in physician training, and probably we're going to reach a point soon where physicians will have to be certified, since it's pretty clear that a lot of people who are declaring brain death aren't doing it the way that guidelines suggest they should. And there's a major effort underway by the World Brain Death Project to standardize brain death determination, both nationally and internationally. And then there are efforts underway politically through lobbying and public education. And I think all of these are important. And I'll just leave you with this quote from Edgar Allan Poe. And the quote is, "The boundaries which divide life from death are at best shadowy and vague. Who shall say where the one ends and where the other begins?" And what's interesting is that this was from a horror story he wrote, published in Philadelphia, called The Premature Burial in 1844. And it was about a man who had this condition, catalepsy, where he'd go into this trance, and he had this mortal fear that when he was in a trance, someone would think he was dead and bury him alive. And believe it or not, at that time, contextually, that was not an absurd fear, because physicians misdiagnosed death with alarming frequency, and there were numerous people who were buried alive. And it spawned this whole industry of all these contraptions attached to coffins, where if you woke up in a coffin, you could ring this bell that would sound outside, and there were breathing tubes. And so it's not, physicians have misdiagnosed death before. We have a long history of doing that. And I hope that, I think this quote from Edgar Allan Poe nicely sums up where we are with brain death right now. It's not as clear cut as at least I was taught it was in medical school. And I think expanding your horizons to view it from different disciplines sort of adds a layer of appreciation to the challenges we face. So I'm going to stop there, and here are some of the references and take any questions.
Hey, thank you for that tremendous talk. I always thought that the two things that are certain in life are death and taxes. But we know death isn't certain now. We know certain ex-presidents didn't pay their taxes. So I don't know what's true anymore, to be quite honest. Promised I wouldn't make political comments, but I guess I want to relay a story and then get your thought behind it. I was a new fellow and I was doing brain death testing on one of my patients. First round of testing was we didn't find any brainstem reflexes. The second one had the apnea test. Went through the whole spiel, did brain death testing, did the apnea test. But like about 4 to 5 minutes out, and the patient's blood pressure starts dropping as they get more acidotic. So I tell my nurse, hey, push 1 cc of neosynephrine. I want to keep the systolic over 100. He misheard me, might have been my accent, pushed the whole 10 cc. This patient's pressure went up from about 101, 102 to 200s. I've finished the full brain death testing. I'm just waiting for the apnea test to get completed. She almost sits up, the patient. I'm like, this is some weird sort of Lazarus sign. I don't understand what's going on, but her pressure essentially doubled. I went in and repeated my brain death testing. After that happened, she had a cough reflex. She had 1 corneal. So my question is brain death, because we have these arbitrary, like you said, everything's arbitrary. It's either right or wrong, dead or alive. Is brain death a relative phenomenon of perfusion? Like maybe this patient had ICP. This was a patient who had a PCOM aneurysm, subarachnoid hemorrhage, IVH. And so maybe the cerebral perfusion pressure was inadequate for me to clinically find any signs of brain activity. And when we overcame it with a systolic of 200 inadvertently, and that's not the goal we set ourselves when we do brain death testing, now you see brain activity. So it's always disturbed me and bothered me for like a couple of decades. Like when I declared someone brain dead, is it relative at that pressure, or at a higher pressure, maybe would they be more alive?
I think you're getting at some very important underlying principles that I think are not widely discussed. So number one, we insist, the law says that there has to be loss of whole brain function. There's not loss of hypothalamic function in many, many people who are brain dead, and it's not even supplied by, it's supplied in part by extracranial circulation. So it's protected. And you could argue that hypothalamic function is more important for maintaining homeostasis than the reticular activating system. And so, we've convinced ourselves that when we go through this very rigorous procedure that there's no brain function, which is nonsense. There is brain function histologically, the cells deteriorate at different rates. And it's not surprising that reflexes come and go. And I think the more important question is, why are we so hung up on making sure that every single one of those things is not working when, again, biology functions along a spectrum? So I would ask you, is there a difference biologically between a person who meets all criteria for brain death and a person in the next bed who meets all those criteria except has a single corneal reflex? They're both hopeless and aren't going to recover. And so, I think the problem is we've tried very hard to convince ourselves that this is a biological reality, that there is some testing we can do that defines a very specific biologic state, when I just don't think that's true. And there will always be islands of cells that are functioning, some more important than others. And maybe if you raise the pressure, you'll get some that were ischemic back functioning for a little while. And that either does or doesn't bother you, depending on whether you feel compelled to accept that state as biologically equivalent to death. We can still accept that it's not biological death. It's just one in a spectrum of bad brain, there's a spectrum of brain function from normal to horrible and irrecoverable. And this is somewhere in that spectrum. And then the question is it okay from a social, moral, and ethical standpoint to just say we're considering that person as if they had died, but not that they biologically this is death. I don't know. That's a long-winded answer, but you know, I think what you described isn't shocking and isn't probably, you're not the only one who's probably observed that. And I think the only reason it's disturbing is if you really feel compelled to justify brain death from a biological standpoint.
Question. So I'm having a hard time wrapping my head around the spectrum biologically. So I see the aging when you're 18, you're not an adult biologically, but the animate and inanimate across all species, we know this is not alive. So I'm not talking about brain death, just death per se. Which school of biology, says that it's a spectrum?
It's not as, I think just in general, biological processes, it's hard to draw a bright line. We can think of numerous examples, but the one I gave where, if you have one corneal reflex left or you have no corneal reflexes, there's not a whole lot biologically different between those two organisms. So to draw a line and say that one is dead and the other is alive is a little bit arbitrary. If you have brain death and you wait 6 months and you do an autopsy, the brain, there's nothing in the cranial cavity, it's liquid. The whole brain's liquefied. That's definitely irreversible and permanent. And we know what normal is, and everything else is somewhere in the middle. And it's a spectrum. You can be a little worse, a little bit better. And most biological processes work that way. Now in medicine, we have to draw thresholds that indicate testing. The aneurysm, is this many millimeters in size, and the studies show that there's a higher risk of rupture. But if it's a fraction of a millimeter larger or smaller, is it really biologically different? Probably not in any meaningful way. But we have to draw thresholds. That's how medicine works. That's how law works. That's just not how biology works. But yet we're, so I think, and that's okay. We have to do that in law. We have to do that in medicine. You have to know when someone's dead legally because of, wills and property rights and other rights. And so you have to draw a line somewhere. That doesn't mean that makes biological sense. And I think we have to become comfortable understanding that we can use different standards depending on which discipline we're talking about. And I think the problem here is that ethicists from the get-go have tried to justify the concept of brain death by clinging to this idea that it is biological death. And I'm just not sure that it is. It's clearly, a child could walk in, examine two people and tell the difference between someone who's cold and has rigor mortis and someone who has brain death. They're clearly biologically not the same state.
Any other questions, anyone? I thank you, Josh.
Thank
This
you.
was as a neurologist, I have to say this is like, I'm experiencing right now what someone who worked for the mob probably experienced when he watched Goodfellas or The Godfather. Like, it was like, whoa, this is really good. Thank you again. Taking a little break and come back for the debates. You can bring some popcorn, pillows.
Just an announcement for any nurses that are in the room, please don't forget to turn in your eval to the registration table when you leave today. Thank you.
Really? Amir. Yeah, I thought maybe turning them closer, like more towards each other though. Since they. Yeah, they can watch this person. Then I'm gonna say. This. Mic check. In here.
Hey, guys. Debate time. All right, no sharp objects, okay? Just use words. Right? So we have two debates, at the end of which Dr. Chimesani was due to speak today, but he couldn't because he had to fly out. He had a personal emergency, so he won't be here. What we're going to do is have the two debates that were scheduled, and we may have one off-the-cuff debate at the end of it without any presentations, but let's see how it goes. So first debate is Diane McLaughlin versus Yogesh Muradia. Diane McLaughlin is one of our awesome nurse practitioners. She is on committees of so many societies. I didn't know that many societies existed. She is quite brilliant. She worked at Mayo, UF, Cleveland Clinic, and has now come to Baptist, and we're honored to have her. Dr. Muradia makes, when this sounds wrong, but when people see Indians, they're like, oh, you must be a doctor. You must be really intelligent. You must be really smart. And I'm like, I'm not, but Dr. Muradia is. So he makes all Indians look good, all 1.4 billion of us. So both of you make me look good, please. Welcome. So the topic is going to be a lumbar drainage in CSF, and you're going pro? Early CSF, or lumbar drainage for subarachnoid hemorrhage.
All right, so the first time I became interested in this topic was about 10 years ago at Mayo when Dr. Hanel was actually still there, and we had a patient with an EVD set at 10 and a lumbar drain set at 5, and I was trying to figure out why. And if any of you know Dr. Freeman, he, instead of answering, rattled off some citations or some references. And this will be kind of an introduction so that we can start off. In general, we know subarachnoid hemorrhage has high expected mortality. This has improved over time, but it's a secondary issues that become a problem for us. And about 50% of survivors have lifelong issues. So first is preventing re-rupture, and then you can see the sequela that we try to prevent. And as all of these scales that have been in existence for the last 40 years, we know that blood in the subarachnoid cisterns is bad and associated with worse mortality, worse morbidity, and a lot of the secondary injury that we saw. So when we're talking about lumbar drainage, we'll start with how it might affect vasospasm. So about 70% of subarachnoid hemorrhages have at least radiographic vasospasm. And one of the hypotheses regarding why this happens is that it's hemolysis driven, in that there's both systemic and local inflammatory response with that degradation of red blood cells. And that causes, again, both local and potentially systemic vasodysregulation and vasoconstriction. So how does lumbar drainage potentially help this? Well, that very first article that was referenced to me when I saw this in practice was this CLEMO 2004 article, which looked at about 160 patients, 80 in each group, and demonstrated decreased incidence of vasospasm as a primary outcome and immediate improvement in mortality, though the later effect it did not show in long-term outcome. In 2008, this was repeated with a smaller group. I think it was around 40 and 40, and it again showed decreased vasospasm. Then the early drain trial, which the initial publication was in 2011, that showed just the study protocol. And actually, Dr. Muradia emailed the investigators, which I'm going to thank him because it's another positive indicator that this could be effective. They presented this 2 weeks ago at the Neurologic Society's annual meeting. And it also showed a decrease in delayed cerebral ischemia and improvement in outcomes. And they interpreted that as a positive signal that maybe this is something that we should be doing. The Loomis trial, another one, about 100 patients, showed the same thing that everything else is showing. improvement in vasospasm. And as was kind of alluded to earlier, this is one of our biggest obstacles in managing subarachnoid hemorrhages long-term. And then the Park et al. Paper, which was again around 100 and 100, showed the same thing. So if this is what we're failing to manage with Triple H, and that's why we got rid of that. And there's still some debate over augmentation of blood pressure. And this might work, then I don't necessarily see a super great reason not to try it. And that's before finding out there are other things that it helps with as well. So hydrocephalus is another common theme that you're going to see in subarachnoid hemorrhage patients. And the proposed pathophysiology behind this is blood is heavy, it falls and causes an obstructive hydrocephalus. So again, the Climo paper, and this was a secondary outcome, looked at hydrocephalus and shunt dependence, and they found big decreases there. Again, this looked at need for, in the Orman paper, need for shunt also showed decrease. And then the Yim et al. Paper, again, showed a decrease, even though I will say the methods were a little bit interesting here because they looked at the bicaudate index and showed radiographically, and that number was very different than how few actually got shunted, but all still positive for lumbar drainage to prevent need for shunt. And then lastly, there's actually not a lot of great evidence to look at therapeutic indications for a headache or a meningismus. The only thing I could find was a recent case series with 5 patients that showed patients reporting relief. So since I don't have great quality of evidence, I'm going to use the Tom Black scale, which says that I believe this, and so therefore it's true. And anecdotally, like just 2 weeks ago, the last shift I worked, I had a lady ask me at 3:30 in the morning to perform a lumbar puncture on her as we were escalating dosages of opioids through the course of the night. And then she didn't complain of a headache after that point. And you can see when you start with motor oil and you end up by the end of 4 tubes, clear CSF being drained, why that might be the case. So multiple meta-analyses that over the last couple of years that say the exact same that we just went through, that, hey, this is promising and maybe we should start paying attention to this. And most importantly, if you have a very skilled provider, you might be able to mitigate some of the proposed or suspected risks of the procedure, like over drainage and potential headache. You can use atraumatic needles, infection. There was actually a study 2018 that looked at lumbar drain versus serial lumbar punctures. And if you're really concerned about infectious risks, then the lumbar punctures were just as effective without the risk of infection. And then herniation, you're going to stratify your patients regarding who would be appropriate to do this on and who not. So in conclusion, if I have a subarachnoid hemorrhage, I would like to pick who does it, but I would like a high volume lumbar puncture early on to prevent all of those secondary injuries that happen as a result of that. You're up.
And very convincing. No, I think this is fine. So I'm not going to just straight out say that lumbar drainage of CSF after aneurysmal subarachnoid hemorrhage is just plain bad. I want to ask myself the question, whether is it good for everybody, some patients, or no one? And we'll try to look at some of the same evidence that Diane presented from a different perspective. Think of it as a rectangular projection of a cylinder. So it's the same thing, but we're looking at it from different angles. So some established fact, which I agree with you, vasospasm is common. Risk of spasm is linked with amount of hemorrhage, and spasm, ischemia, and outcomes, they're all intricately linked with each other. Some generally agreed upon notions is that microvascular spasm is a real thing. You cannot see it on the imaging, but it does contribute to the ischemia and the outcomes. And certain interventions may affect outcomes and ischemia without actual observable effect on the macroscopic vasospasm, i.e. nimodipine. So it is reasonable to assert that removal of blood and blood products from the subarachnoid cistern may reduce the risk of macroscopic vasospasm and microscopic vasospasm, in turn leading to decreased risk of ischemia and improve outcome. So I think we are in agreement up to this point. Now, not all subarachnoid hemorrhage patients are same. They come in all different varieties of different grades in terms of clinical pictures, radiographic pictures. They're treated differently as well, and they follow different clinical courses as well. And along with that, they probably respond differently to different interventions as well. So for certain interventions, maybe a subgroup of patients may respond better than the other group, and maybe some group of patients may get harmed by those interventions differently as well. So let's take a look at the evidence. So some of the retrospective data that you mentioned, I want to take a little closer look at that. So the study cited here, it looked at lumbar drain versus standard treatment, only coiling patient, showed lower vasospasm, better outcome. What's the catch? Vasospasm was defined clinically only, no TCD, no vascular imaging. And the most important thing was control group was much sicker. Huntington's grade 5, 10 times more likely in this control group. And we know with retrospective data, if the control group is sicker, you just cannot get rid of the confounding there. Another study, lumbar drain versus EVD after coiling, no difference in vasospasm, but better outcome. Why no difference in vasospasm? Because we needed objective confirmation of vasospasm. Why improve outcome after lumbar drain? Because the control group was significantly sicker. You can see that Huntington's grade 5, 88% in the EVD group, 76% of lumbar drain patients were just mild grade. So in summary, in clinical practice, lumbar drain so far is usually inserted in generally lower grades, mostly compared to EVD patients. It leaves the control group, and you look at those data retrospectively, leaves the control group with much higher severity, which leads to worse outcomes. And no matter how much statistical gymnastics you perform, you just cannot get rid of the residual confounding. And vasospasm rates are similar when you ask for objective evidence. You're gonna go by only clinical judgment. It can be different. A little bit more. Another study of clipping patients only. No EVDs here. It was only lumbar drain versus controls. Controls meaning they got no drainage. Well balanced in severity. So a little different here. What's the outcome? Again, better vasospasm and better outcomes. Now, because the EVD patients were excluded, there was a significant number of very high-grade patients in the control group who did not get any drainage. So these are all the patients who were only clipping. So they're a little different from our usual practice right now. Only clipping patients and very high-grade subarachnoids not getting any kind of CSF drainage. So if our control group is not similar to our current clinical practice, should we change our practice because the study group has a better outcome? That's the question for us. Another interesting study, single arm cohort of lumbar drain. What's the vasospasm rate? 56% on CT and MRI. So objective evidence of damage by vasospasm, 56% only in the patients who got lumbar drain. Infection rate, 52%. And author's conclusion, you might have to brace for it. Lumbar drain may decrease vasospasm rate. And reason, based on historical controls. So retrospective data, it's not sounding too convincing so far. So let's take a look at the prospective clinical trials, randomized patients. First trial that Diane mentioned, sorry, it was a text from the nurse saying there, it's fine. LUMAS trial, lumbar drain versus standard therapy. Results, symptomatic vasospasm, again, better in lumbar drain. Problem, defined subjectively only, no TCDs or any vascular imaging needed. And how was it defined? Any transient focal or non-focal deficit. Patients confused for 5 minutes, vasospasm. There you go. If you look at any objective outcomes in the same trial, no difference at all. Persistent deficit, no difference. Stroke, VP shunt rate, MRS, death, all the objective outcomes were equal in both groups. Another trial you mentioned, lumbar drain versus EVD, no difference in vasospasm, shunt rate, functional outcome, but more acute hydrocephalus and infection in the lumbar drain group. Author's conclusion, wait for it. Lumbar drain is better than EVD. The conclusion was based on this. EVD patient had more EVD tract hematoma than lumbar drain patient. Think about it. Another trial, moderate grade subarachnoid, only clipping patients. Again, lumbar drain, clinical spasm, better, improved 3 months outcome. The catch here. Clinical spasm was extremely high, higher than you'll usually see in our practice, 63%, because it was again defined subjectively, including non-focal symptoms. If you look at only focal symptoms, the rates are similar. No vascular imaging needed. And the risk of infection, 17% after getting prophylactic antibiotic of a combination of a cephalosporin, sulbactam, aminoglycoside, and flagyl. And risk of bleeding events, about 7% that required evacuation. So that leads us to this, the biggest randomized trial, the one that was just published close to a month ago. This trial had the best methodology of all of this, okay? And it was more generalizable, a very pragmatic trial. Lumbar drain versus standard of care, include all kind of treatment, coiling, clipping, doesn't matter. The only problem they ended up having was the group was kind of split into two hands. There were a lot of patients in the very mild category and a lot of patients in the most severe category, very few patients in the middle. Outcomes, primary outcome, which was 6 months functional outcome, was better in the lumbar drain group, and infarct at discharge. So objectively proven ischemic damage was also improved in lumbar drain. What was interesting was there was no change in vasospasm. Clinically suspected spasm, TCD vasospasm, angiographic vasospasm, all kinds of vasospasm was equal in both groups. So, and the take-home points from this trial was better 6 months outcome, less infarct burden, and macro vasospasm rate unchanged. We have to see, because the group was kind of split into two halves, and because it showed improvement in the functional outcome, I want to believe that the results on the functional outcome was driven by one group. I want to say it was driven by the more severe group, because the grade 1 hemorrhages end up usually doing well with or without drainage. And so the difference may have come from only one subgroup. We don't know the details yet. We don't even have the publication of this trial yet. And so we need to see the paper for closer scrutiny. So in conclusion, what we've seen is retrospective data were just too weak to draw any real conclusions. 3 randomized trials with extremely severe limitations. One of them showed lumbar drain may decrease transient, subjectively defined clinical events in a non-blinded treatment group, but no durable effect. Second one was just lumbar drain is not an alternative of EVD, even though they concluded something different. Infection risk is not negligible. And same thing with the third trial. It may improve outcome in the moderate grade after clipping, which may not be generalizable to our population, and the rate of complication was just alarmingly high. And the early drain trial, as I mentioned, the prelim results are encouraging, and the results of improved outcome without actual effect on the vasospasm is reminiscent of our nimodipine trial. So maybe for some subgroup of patient, it may be beneficial, but just as a blanket treatment, I don't think it's the right thing.
All right. So I agree, the retrospective data is crap. We all know that. But I think there's still some promise to the prospectives. What I'm hearing is even though you don't like the way that they're defining vasospasm, I'm hearing there are still less neuro changes in patients that receive lumbar drainage. Also hearing potential complications from having a lumbar drain itself. I also don't disagree with, because we have other studies that have shown that serial lumbar punctures is just as effective as lumbar drainage and then takes out some of those risks. I also know an attending that happens to offer a lot of his subarachnoid patients lumbar puncture, which seems very confusing to me since it might not be the best there.
So the data we have for lumbar drainage cannot be extrapolated to just lumbar puncture by itself, because if the lumbar puncture is less harmful, maybe it's less effective as well in terms of the outcomes they had studied. That's one thing.
Have you seen the CSF when you do these lumbar punctures, how it goes from Kool-Aid to clear?
Mm-hmm.
That's pretty convincing to me.
It's convincing that when we put a needle in the lumbar space, bloody CSF comes out. That's the conclusion I draw from it. That's all it means.
It is rewarding though.
It is. Well, any questions?
I think the question is, if you had a subarachnoid hemorrhage and it was poor grade and you had a lot of blood, would you want a lumbar puncture?
So,
even though you're a man, still.
What grade are you gonna give me?
Let's do a 4.
Okay. So again, if we cannot tell other people what's the right thing to do without data backing it. Just personal experience and personal decisions do not apply to other people. For that reason, just if we're just going by the data, what the data has shown, it seems like the lowest grade patients are just doing too well to have any effect of lumbar drain when you measure it on the outcomes of the vasospasm rate. The question is for the moderate to higher grade, could it, and your question is, this would be in addition to EVD?
No, my question is, would you specifically want lumbar drainage performed? And then whether or not you have an EVD? Completely different.
No, it may be relevant here actually, because EVD and lumbar drain are not completely different treatments. They both achieve similar goal, but different way. Maybe one is effective in getting the blood out more effectively than the other one.
Even though the 2012 guidelines say that they could use either or interchangeably.
But then again, by 2012, the data we had was all crap. That's what we just proved. And so the guidelines are not helping here. Okay. Now, the good thing is we do have a trial with some signal. I think the reason we are not coming to an agreement is that we don't have the details of the trial, because my feeling, again, this is a feeling, my feeling is that there is a real signal there and it is driven by the high grade patient. Okay. And just like we've adopted nimodipine as the treatment, even though the initial idea was that it would prevent vasospasm, but now we all think that, okay, it prevents, it gives you better outcomes.
And those studies had issues too.
No, I totally get that, but I'm kind of trying to be on your side here, that maybe this is going to be one of those things that when objectively you look at the data, you're not going to be convinced that it does prevent vasospasm. But again, in the clinical trials, if it improves outcomes, who cares about the mechanism? Right?
Can we agree that maybe a center that has a large volume of subarachnoid hemorrhages might be an ideal place to test this hypothesis?
Yes.
That's good enough for me.
All right.
You can put a lumbar drain in all Eric's patients. I'm kidding. Him. Let's see if he's going to agree on that. It's no. That's just I cannot even agree with you guys who is dead, who is not dead these days anymore. After Josh's talk, it put me a lot of thinking on that. We look into this with Freeman and Lanzino, and I was at Mayo. Randomized lumbar drain, randomized EVD, low pressure, keep these people EVD at 5, trying to decrease ICP, increase CPP. Again, vasospasm is one of these situations that no matter what you try, you keep getting negative. As you said, I want to read the paper because when Klimo oh, look at this, phenomenal, let's do it. And then you try and fail. Magnesium, Tirilazad, again, you go on and on and on. It's just, it's one of those situations. I don't know. I used to be more on your side, Diane. Now we see so many shortcomings of lumbar drain that it's hard to say, okay, let's do this consistently with, again, we had a recent one with Limitor. Again, regardless of the system, it's a very frail system. And you put the Great Resignation there with travelers. And again, Lord have mercy, I don't know if I would sign up my patients for that clinical trial.
Was just high volume lumbar puncture rather than the drain.
So I remember my mentor, that was a Torsund resident at Mayo, the PGY2 first job of the day, 5 a.m., put every single subarachnoid hemorrhage on the side, needle, every single day. Subarachnoid hemorrhage in the hospital, lumbar puncture, daily basis. And that's what they had back then. It worked or not, there's no randomized data for that, but that's what they used to do, so. Sometimes I have to twist somebody's arms to lumbar puncture for headache, and the patient, you know that, right? No, thank you. You got the first one, second one. So Eric, are you gonna volunteer for that?
All right. We can hug it out.
Radha is going to come back here and he's going to debate Dr. Murthy, who is essentially, even though he works at Cornell, at New York Presbyterian, he's essentially a Baptist employee now because we keep calling him back. One of these days, he's going to forget to fly back to New York and then settle down here. Hopefully his family will join him too. So Dr. Muradi and Dr. Murthy actually were co-fellows about 10 years ago at Hopkins. I had the great pleasure of working with them back then. I don't know if you guys have watched Bollywood movies, but like, you know, when I was 70s, early 80s, all Bollywood movies had the same theme, that these bandits that would kind of come into this village, kill the parents, the two kids would run away, get lost. They would both grow up in very separate circumstances. As the movie on, they fall in love with the city and they fight. And then towards the end of the movie, as they're fighting, they realize that they have some sort of a sign on their shoulder that was imprinted, and it's the same one that the other person has. And they realize they're brothers, and then they hug it out, and then they kill the bad guy. So that's what I expect from these two guys. You know, they can fight, and they have to hug it out at the end of it. Such a pleasure having both of you here. All right, seizure prophylaxis for subarachnoid and ICH, pro and con. And I think Dr. Murthy is going pro.
Hello, everyone, and thanks, Dr. Nawal, for the very confusing introduction. It's always a pleasure to be here. Thanks so much for the invite. So I'll be talking about seizure prophylaxis after intracerebral hemorrhage, and I'll be talking pro. Dr. Moradia called me last night and requested that I go easy on him, so I decided not to joust, and we decided to change the format of this debate. So I go first, and then he goes. Just so that he doesn't lose on home grounds. Clearly, he has disabled the remote. Working. Sorry, these are my disclosures. So I do have a disclaimer. I definitely would advise some viewer discretion. Now, there are several debates that probably will never be solved, this being one of them. And obviously, I'm a huge soccer fan, so this is an eternal debate in the soccer world also. But one debate I hope to convince you is using seizure prophylaxis in patients who have an intracerebral hemorrhage. So I'm actually going to directly oppose what you will probably hear from Dr. Moradia and what you have heard from the American Heart Association 2022 guidelines, which essentially say that there is no benefit to routine seizure prophylaxis in ICH patients. In fact, The latest guidelines also say that you should treat seizures, be it clinically or electrographically, and not necessarily put everybody on seizure prophylaxis. And additionally, if somebody's mental status or neurological status is out of proportion to what you would expect based on the neuroimaging, then those patients ought to be on continuous EEG monitoring for at least 24 hours or more. So with those guidelines in mind, I hope to convince you otherwise with 4 simple questions. So first question being, how common are seizures really after ICH? And if they do occur, when do they occur? So for all intensive purposes, the seizures we'll be dealing with here would be clinical or electrographic seizures, and not any staring episodes. So the incidence of seizures usually range between 5 and 10%. If you look at literature, they even go as high as 20%. But seizures can be classified as early or late seizures, depending on the timing of their onset. So less than 7 is generally taken as early, and more than 7 days after ICH onset is delayed. Early seizures can be seen in up to about 15% of patients, and delayed seizures are a little less frequent and can occur in up to about 8%. Now, electrographic seizures, on the other hand, can be seen in almost a third of all patients with ICH, and usually occur in the first 72 hours after symptom onset. And the worst of the lot, weighing the most severe spectrum, which is status epilepticus, you can see them in a little less than 5% or so. Now, this was a large study from the NGH group, where they looked at 1,000 patients who survived in ICH. And what was striking was that the early seizures were remarkably common after ICH, and they all occurred in the first 7 days. Even after the 7-day mark, when patients were followed as long as up to 5 years, you can see that the rates are not completely insignificant. Now, we looked at the risk of seizures in different stroke subtypes. Now, what we found was patients who had an ICH had the highest risk of stroke, both short and long-term, compared to other stroke subtypes such as ischemic stroke and subarachnoid hemorrhage. So clearly, these patients have a really high risk of seizures. Now, what are the factors that tell us that somebody is at risk for seizures after an ICH? So you can have some factors associated with early seizures and factors that are associated with delayed seizures. Now, as far as early seizures go, involvement of the cortex, having a very high hematoma volume on admission, or having a high severity of clinical symptoms as evidenced by a high NIH stroke scale, these would be things, and the concurrent presence of either subarach or subdural hemorrhage would be things to keep in mind. But when you're looking at delayed seizures, on the other hand, then usually long-standing pre-existing factors are more associated with delayed seizures. So those would include pre-existing dementia or presence of white matter hyperintensities on the MRI or microhemorrhages. Now, there is speleological evidence to say that we can actually predict seizures. So they use a CAVE score, which essentially you give 1 point for cortical involvement, 1 point for age over 65, a point for volume over 10 cc's, and then a point for early seizures in the first 7 days. And based on this, there is pretty accurate prediction that if you have a high CAVE score, then these patients are at a higher risk of delayed seizures. Fine, now we know that some patients had an increased risk of seizures after ICH than others. We know how common seizures are, but do seizures really affect ICH outcomes? Now, a lot of early retrospective single-center data have given conflicting results as far as the relationship between seizures and ICH outcomes. But this was the most compelling paper that I found, which essentially looked at the relationship between early and delayed seizures and ICH outcomes separately. And what the authors found was that patients who had early seizures, there was no relationship or association with either mortality, dementia, or loss of functional outcome. But when it came to delayed seizures, then those patients had a higher incidence of dementia down the road and more loss of functional independence, suggesting that delayed seizures are actually associated with functional outcomes. So the authors hypothesized that patients who experience an early seizure after ICH have an increased risk of recurrent seizures, but this may necessarily not have any bearing as far as functional outcomes are concerned. On the other hand, if you have a patient with an ICH and delayed seizures, then those patients are likely to experience worse outcomes long-term. So fine, seizures may be associated with worse outcomes after ICH, but what about anti-seizure medications as such? Are they really that bad after ICH? Now, this was a study again from the Harvard group where they looked at two different institutions, and in both institutions, almost 50% of patients with an ICH were started on seizure medications. And if you look at the last line, what was really striking was close to 90% of patients in one cohort and almost 60% of patients in the other cohort who had anti-seizure medications at the time of discharge did not experience any sort of clinical electrographic seizures or, in fact, even epileptiform activity on EEGs. What about some of the secondary analyses of large data sets? Now, this was a secondary analysis of the CHANT trial. In about 300 patients, the authors found that using anti-seizure medications was associated with almost a 7-fold increased odds of poor outcome after ICH. And most of these patients were on phenytoin, notably. Again, in another study with a decent number of patients, about 100 or so, again, phenytoin was shown to be independently associated with worse outcomes after ICH. Now, we all can agree that phenytoin has literally fallen out of favor, and Keppra has, by default, become the drug of choice for seizure prophylaxis, or even, for that matter, treating seizures. And in this study by the Chicago group, we can clearly see that the use of Keppra has gone up exponentially in the last 5-10 years or so. And conversely, the use of phenytoin has come down drastically. So how does the increased use of Keppra reflect in terms of the association between anti-seizure medications and ICH outcomes? So this was a study from the ERIC collaboration, and they studied close to 1,000 patients. And what they found was using the more recent versions of anti-seizure medications, there was no association with poor outcome. And finally, we have the PEACH trial, which was a randomized clinical trial that came out late last year. And in this particular study, it was a small study with just 50 patients where all patients received continuous EEG for at least 24 hours in the first 48 hours. And you can see three important things here. Patients who received Keppra had a significantly lower rate of seizures, 16 versus 43%. Patients had lower incidence of electrographic seizures with Keppra. And even those who experienced seizures in the third bar graph, you can see that the mean duration of the seizures was also significantly lower with Keppra. Now, I've agreed that this was a small randomized trial, but that definitely sets the stage for a larger phase 3 or phase 4 RCT. Now, you can all argue that Keppra long-term is associated with poor cognitive function. We've all been taught that since med school. But I would argue against the contrary and say that Keppra may not actually be associated with poor outcomes. In fact, Keppra may be associated with improved outcomes. And the reason I say that is based on the small randomized trial in Alzheimer's disease patients. And there's accruing data to suggest that Alzheimer's disease patients experience a lot of seizures because of brain hyperactivity. And when they randomized patients to Keppra versus no Keppra in this group, those who received Keppra had actually significant improvement in several cognitive domains. What about secondary ICH? Now, we've all known that secondary ICH, such as brain tumors, cavernous malformations, AVMs, and cerebral sinus thrombosis that causes ICHs, these patients experience a much higher rate of seizures. We have shown that patients with AVM, the rate of seizures is 20% more than double than that you would expect in patients who don't have AVMs. Similarly, ICHs that result from cavernous malformations, again, almost a fifth of these patients go on to experience seizures. So, and about 12 to 15% of patients who have an ICH from cerebral sinus thrombosis also go on to have seizures. Regardless of all these increased evidence showing increased seizures, the AHA guidelines still, even for an ICH that results from cerebral sinus thrombosis, they very clearly say that you only treat a clinical or electrographic seizure, and there's no role for seizure prophylaxis. But I'm hoping that with all the data I have shown you, that we can safely conclude that seizures are common. They occur pretty much early on after seizures. The ICH severity characters usually are associated with seizures. You have early and late onset, but data may suggest that it's the late onset seizures that affect outcomes. And anti-seizure medications may not be that bad after ICH. And finally, I would like to provide some incriminating evidence to suggest that my esteemed colleague, Dr. Moradia, is a very strong proponent of the ketogenic diet, especially when he's on call. Thank you very much.
The file that says destroy. I prepared two, and one of them had the Bollywood music, butterflies, rainbows, and I had to pick one. So I think I'm going to pick the destroy fly. So are odds ever in your favor for seizure prophylaxis after spontaneous ICH? Should we give seizure meds to patients who have seizures? And I think everyone would agree, yes. What about to those who don't have seizures yet? And that's the question we need to answer here. A lot of us may share these common feelings. The meds are anti-seizure and I am anti-seizure. And error of omission feels a little worse than commission. And you may feel that if my patient who's not on seizure prophylaxis gets a seizure, I am personally responsible for it. How can I stop somebody else's anti-seizure medication? And things like that. These are all feelings. So let's take a look at some facts. So I'm going to start with defining what's the seizure after intracranial hemorrhage and what kinds they are, because they are very different. The three kinds of seizure that happens after a brain bleed. The first one is onset seizure. It happens at the time of ictus, usually day 0. A lot of these are not epileptic seizures. A lot of these are convulsive syncope or even posturing. One of the trials data, onset seizure rate after posterior fossa hemorrhage was 9%, and we know they were all posturing. Second group is the early seizure. That's the focus here. Can we prevent early seizure with seizure medication? These are also called symptomatic seizure. They result from inflammation, edema, neurochemical changes related to the bleed itself. And the third one is the late seizure that happens because of scar on the brain, something that can lead to epilepsy or recurrent seizures in future. And the first type of seizure, onset seizure, you cannot prevent them. They happen at the time of the onset. Late seizure, we are not arguing that we are gonna give prophylaxis to prevent long-term epilepsy. That's a crazy idea, and I don't think Dr. Murthy would go for it. So I think we are kind of limited to finding the answer to the question, can we prevent or can attempt to prevent early seizure benefit our patient? That really is the question. Now, for seizure prophylaxis to help, these three conditions need to be met. One, patient needs to have a seizure in the absence of prophylaxis. If those patients who were never going to have seizure are not going to get any benefit from this medication. Second, that seizure, that one single seizure needs to cause harm. Because if the seizure is harmless, again, prophylaxis is useless. And third, the attempt you are doing, medication you are giving needs to prevent seizure, because if the medication fails, then the whole project fails also. In other words, prophylaxis benefit depends on three things. One, rate of early seizures after ICH. Second, durable consequences of a single seizure. We're not talking about recurrent seizure because then it falls under the category of treatment of seizure. We're not talking about treatment. We're purely talking about prophylaxis here. So durable consequences of one single seizure, like permanent neurologic injury, long-term risk of epilepsy, and things like that. And third, efficacy of seizure meds in actually preventing early seizures, symptomatic seizures. And to quantify the effect of all of this, we're going to track them with these numbers, P1, P2, and P3, which are actually probabilities here. They range from 0 to 1. So let's look at the rate of early seizure after intracranial hemorrhage. Every single study that actually mentioned or quantified early seizure that does not include the onset seizure and the late seizure, the number has been around 3%. Large number of patients, around 3%. When we look at a study and it says 10% risk, it's including the onset seizure as well. But he also mentioned there are some studies that say seizure rate of 20, 30%. These are those studies, EEG-based studies, 28%, 31%. Now, these studies did not have the denominator of all ICH. It was the patients who they thought were having seizures and were put on the EEG, 30% of them had seizures. For example, the Klassen paper, the denominator was 600, actually, yeah, 600 patients. Out of them, 100 were put on EEG and only 30 had seizures. So 5% of seizure rate of all ICH patients. So we gotta know what number they're mentioning. Second, consequences of seizures, effect of seizures on the actual outcome. There are a bunch of retrospective studies. They all can be divided into two kinds. First kind of study shows early seizures are more common in seeker patients, larger bleeds or lower GCS, and then they'll pretend to control for severity and conclude that early seizure worsens outcome. But in reality, what they show is seeker patients have worse outcomes. And second groups of studies are, they have balanced severity in the seizure and non-seizure groups, and they all show that the early seizures don't affect the outcomes. A classic example of the first kind, where you have, I'm gonna read to you, GCS, the lowest GCS, almost comatose patients in the seizure groups, 48%. In the non-seizure group, 21%. So more than double the rate of almost coma in the seizure group. And sure enough, when you look at the multivariate analysis, these patients had worse outcome. What's the catch here? They did not have data on the ICH volume. They couldn't control for it. They were left with residual confounding. All it shows is seizures are more common in seeker patients. Seeker patients die more. And these are multiple papers that basically showed that early seizures did not affect outcomes, mortality, disability, or long-term seizure risk when they had similar severity, or they were able to control for ICH volume. Third, efficacy of, so basically it looks like our P2 is either 0 or very close to 0. And going to the third, efficacy of aid is in preventing early seizures. There have been multiple meta-analyses. A lot of these studies were overlapping, but overall, the total number of people have looked at so far is above 5,000. And none of those studies have so far shown that those anti-seizure medications actually prevent early seizures. Now, I'm going to give you a primer on probability theory, okay? A combined probability of 3 independent events, P1, P2, and P3 is the product of that, multiplication of those 3 numbers. So if you were to play a game of a roulette, a dice, and a coin toss, your chance of winning all 3 together is actually 0.2%, 1 in 500, which is much lower than any of them individually. That's how probabilities work. So in our case, for prophylaxis benefit to work, we need to multiply these 3 numbers. We know P1 is close to 3%. Our data shows that P2 is 0. Our data shows that P3 is 0. But even if we assume that those studies fail to capture actual effect there, we have to understand when you look at a large number of patients and you don't detect difference, if you're going to assume that the study failed because of your beta error, meaning false negative error, the effect size has to be really small. Anyone who has done statistics would know that the effect size has to be infinitesimally small for a large study to fail to detect the difference. So we know if P2 and P3 are not 0, or very close to 0, and when you multiply it, our game becomes this, trying to win a game of roulette 3 times in a row, which is about 1 in 50,000. So what we show is the benefit side of the risk-benefit equation is extremely small here. No matter what you do, you don't need any prospective data. You just based on this, it's a logical argument. Now, the risk side of it is non-zero. It is not negligible. In addition to all of these commonly known problems with seizure meds, behavioral problem, acute and chronic cognition problem, interactions, hemodynamic, arrhythmic profile, fever, a common problem that we run into is something called therapeutic momentum. Once somebody goes on seizure meds, they do not come off of it. It's a non-issue in a perfect universe, but ours is not. So we must overcome our feelings. And why? Because we were victims of our feelings in the past. The smartest people in the past thought heavier objects fell faster. But we know it's not true. Science is all about facts over feeling, and it does guide us in the right direction as the time goes by. And as Dr. Murthy suggested, in the past, the guidelines wanted us to give prophylaxis. Slowly, it has transitioned from phenytoin for 1 month to seizure prophylaxis only for low-bar hamlets. 2, do not give seizure meds. 2, do not give seizure meds. Now, that's how we conclude that odds are never in your favor. But I want to add a little bit more, because Dr. Murthy presented a clinical trial that trumps all retrospective data. When the effect size is really small, you need a very large sample size. So in this calculation, let's assume that the seizure rate was 10% and not 3%. And prophylaxis actually prevented half of all the seizures. You would have needed more than 800 patients to prove this theory. If the seizure rate was lower or the effect size was smaller, you would have needed way more number of patients. But he was able to prove with just 50 odd patients that seizure medicines prevent seizures, and it's helpful to patients. When that happens, something's going on. Either the trial has picked up noise or you've been tricked. Let's find out. Freeze trial. Whoa, look at that. Seizure rates, 16%, 43%, odds ratio, p-value, less than 0.05. We win. Not so fast. What's the catch here? The trial is new. So this is what happened with the trial. They wanted to have a much bigger trial. It was truncated because they lost funding. And they ended up only with 40 patients. And on those 40 patients, there was a significant baseline imbalance. ICH volume was much larger in the control group. They were much sicker patients. When they did multivariate, and they knew that the ICH volume had impact of outcome that everyone would agree, and impact on the seizure rate as well. In the controlled analysis, they did not include the ICH volume and published the p-value without that was significant. But this was hidden on a page, hidden in 73-page long supplementary appendix, where when you include the ICH volume, the p-value was what you're seeing there. It was a negative trial. There were so many electrographic seizures. How many clinical seizures did they have? Guess. 0. I repeat it again. 0 seizures in both groups combined in a trial of seizure prevention. Okay, you may say, okay, these were electrographic seizures. They hurt the patient. We just didn't see it from outside. 0 patients had change in mental status. In the control group, there were 140 electrographic seizures over 48 hours. And there was 0 change in clinical exams. And of course, the eventual outcomes were exactly the same in both groups. So why is this happening? What's happening here? It was because the way the electrographic seizure was defined. It was defined as, was it low amplitude fast activity or rhythmic spikes? Or was it rhythmic slow waves? And anyone who knows anything about EEG would tell you that's crap. These EEG events were not deemed worth treating even by the trialists themselves. Those 140 seizures that they detected in the trial were not treated. So the difference would have been completely invisible if they were not on EEG and not treated even if we discovered it. It's like the tree fell in the forest and no one was around. Did it make sound? So unless you monitor for this tree falling, the advanced technology that we don't know how to interpret is not going to help us. So yes, I've been tricked. There was another trial that he actually didn't mention, but it was a trial of valproic acid versus placebo, an old trial, again, looking at do seizure meds help these patients? And the seizure rates were exactly equal in both groups, but somehow in the valproic acid group, there was better 12-month NIH outcome, unusual choice of outcome, but it was there. And their explanation was somehow valproic acid is neuroprotectant. They were obviously joking. They just picked up the noise.
Any questions? Anyone in the audience? So much quantum physics in that presentation.
I just want to add that we may have gotten a very good insight into Dr. Moradia's gambling habits. But besides that, as a disclaimer, I think it's very important to acknowledge the current guidelines, which very clearly say, for all the reasons that Dr. Moradia mentioned, that anti-seizure medication should only be used if there is clinical or electrographic evidence of seizures and not necessarily just as prophylaxis based on Argestol, based on the location or any other thing. But besides that, I try to hide a lot of the statistical anomalies and the issues, the limitations with the trials in my talk. But unfortunately, Dr. Moradia saw through all of that. But yeah, I'm happy to take any questions.
Would have not.
Any questions, anyone? The tattoos, no, that's hidden. So I will say though, we get into this mess, like you said, the Peach trial, right? Their intent was to show a difference and they did cover it up, and it happens all the time, which is why invariably you have to go digging in the supplementary appendix, like page 69, randomly you'll find something. But it's interesting. So if you look at the AHA guidelines, when you go back to Dilantin, worsening cognitive outcomes, post-ICH, written by Andy Natick, one of the papers you referenced. And that is on the guidelines saying Dilantin increases mortality. And that paper actually suggested Dilantin caused mortality to increase tenfold. Now, in all seriousness, we know Dilantin's probably not good for you. We know it'll probably worsen your cognitive outcomes. There's nothing that'll increase your mortality tenfold. So what they actually found in that paper, interestingly, was that Dilantin use was collinear with ICH volumes, right? So they looked at this database, and the difference in the two groups in terms of the ICH volumes was 22 cc's. In other words, Dilantin was used in the group of patients who had larger hemorrhages by a mean difference of 22 cc's. So we know that on an average, when your hemorrhage is 1 cc bigger, the likelihood of poor outcomes increases 7%. But they eliminated ICH volumes from that multivariate analysis. So now they said, well, it's not the ICH volume difference of 22 cc's per patient that's causing a significant worsening of outcomes or increased mortality, but it is the Dilantin itself. So I do think that there are a lot of biases in these studies, depending on what you're trying to prove or disprove. But thanks for bringing those up.
I'm still confused regarding the large volume hemorrhages. Should we give them prophylaxis issues, and how high is a large volume?
I'm sorry, is the question whether the large volume bleed should get prophylaxis?
Yes, yes
My
or
answer
no?
would be no.
No. Okay.
Yeah, I agree that that's consistent with what we do also. We don't, based on the volume of the bleed, we don't routinely give seizure prophylaxis. And that said, with the latest results of the ENRICH trial, where minimally invasive surgery has shown to be of benefit for patients with a lobar hemorrhage, now that surgical intervention is now going to probably become standard of care, the seizure prophylaxis is going to be a little more complicated and probably will need to be readdressed, because now you're talking about craniotomy. So it's a good chance that most patients would, after surgery, end up on routine seizure prophylaxis for extended periods of time, depending on institutional practices.
Any comment about people who might have had predisposing conditions? Let's say somebody elderly who has strokes in the past. We see kind of old strokes, or people who said, oh, he might have a seizure before, but could have been alcohol, could be something else. Do we start antiprophylactic seizure?
In patients with ICH and having old stroke?
Yes. Mm-hmm.
No, again, no. At least there's no.
Yeah, I agree.
Thank you.
They've looked at risk stratification in patients with subarachnoid hemorrhage, because that's controversial too, right? You want to like do seizure prophylaxis before you fix the aneurysm. Once it's fixed, very little evidence to say you should continue it. Or when they've looked at high-risk patients, they've looked at patients with MC aneurysms, temporal hematomas, craniotomies. So I do think that not all ICH patients are the same. And I think the guidelines have come out because there's been rampant overuse of seizure prophylaxis. I do think there's a subset of patients who probably deserve it, but the fact that pretty much everybody's put on seizure prophylaxis at some point, I think AHA stepped in and said, okay, stop, you're really overusing it on these patients. But I guess if you don't use it and you see, well, okay, sure, you need to be on seizure medications then.
Thank you.
Thank you both. Diane, it's 5:15. We'll have to wait to fight until next year. All right. Thank you all for coming. And I think we have a prize that Wendy will be giving out to the lucky winner of this raffle.
I know.
I'm not sure what it has.
Chocolate.
Looks like chocolate and wine. And the winner is Dorothy Adair. Since she isn't here, I'll be happy to accept this on her behalf.
Yes, no,
No, it's too late. No.